Hello?
Hello.
Hello, Balaji, sir.
Yes, ma'am. Can you hear me?
Yeah, it is audible, sir.
Yeah.
Shall I admit all the candidates now?
Yeah, candidates and judges also, they can verify
Okay.
their presence.
At 3:30 sharply we'll start.
Excuse me, ma'am. Can admit the candidate, ma'am.
Yeah. Admitted, sir. Admitted. They're joining.
Yeah. And judges also, we can verify their presence.
Okay. Judges, Ravindra sir yet to join, sir, actually.
Okay.
Ravindra sir
Yes.
yet to join as well as
Dr. Periyasamy sir has come.
Yeah. He also, sir.
Yeah,
Not
you can
joined yet.
admit him.
Not joined, sir. Not joined.
Okay. Madam, can you verify the first 5 candidates whether they are there or not? Hello.
Hello, sir.
Can you verify the first five candidates?
Yeah, I have called to Ravindra, sir. I spoke with him and he told that within 3 minutes he will be joined, sir.
Okay. What about the candidates? First five candidates?
Yeah, candidates. First candidates is Brunda.
Yeah. What about the next
Yeah,
Umar
she's
Mukhtar?
joined, sir. Almost all the candidates have joined. We can see participants 21 here.
Okay. Dr. Umar Mukhtar.
Sir, if candidates are not joining us, then we are going to present their video or not, sir.
Okay. Very funny, sir.
Sir, good morning.
Oh, good evening, sir.
Good evening,
Welcome.
sir.
Welcome, sir.
Thank you.
Hello. Good evening,
Hello.
everybody.
Sir, good evening, sir. Welcome, sir.
Yeah.
Ravindra, sir, you have entered in the name of GLRAB, right?
Yes, GLRAB.
Okay, sir. Fine, sir.
Yeah. Thank you.
Welcome you, sir.
Thanks a lot. Yeah.
So GLRAB is Dr. Ravindra, sir. Good evening, sir. Good afternoon, sir.
Good.
Happy to meet you, sir.
Balaji, sir.
Yes, ma'am. Hello.
Sir, shall we start the session?
Yes, ma'am. I can start.
It's not audible, sir. Yes.
Can you
Shall
hear
I-
me, madam? Can you hear me?
Yeah. Bit audible, sir. Bit
Can you
more.
hear me, ma'am? Now?
Yeah. Shall we proceed?
Yes, ma'am.
Okay, sir. Over to you, sir.
Good evening to all. I welcome our esteemed judges, presenters, and everyone to this session. This is Hall C, 3:30 to 4:30 session of ISA Tamil Nadu PG Conclave 2020. I would like to introduce our judges for this session. Dr. GL Ravindra, Consultant Anesthesiologist, Janani Anesthesia and Critical Care Center, Shimoga. Dr. N. Periyasamy, Senior Assistant Professor, KAPV Government Trichy Medical College, Trichy. Welcome, sir. Can you hear me?
Yeah.
Yes, sir. We will see first 5 posters, sir, 5 videos. It will be followed by discussion, sir.
Okay.
We will see the videos now. First 5 videos. Over to you, madam. You can start playing the video.
Balaji sir, kindly call upon the name, sir, one after the another.
Okay. Yeah, first name Brinda, Dr. Brinda. You can play the video, madam. Now.
Everyone, I'm Dr. Brinda from Mandya. So I'm presenting to a case of perioperative management of patients with Down syndrome posted for elective jubilase procedure. And to introduce, Down syndrome is a congenital disorder with trisomy 21 most commonly, an incidence of 1 is to 800 to 1,000 live births. It may be associated with many system involvement in the body, and we report a successful conductance of anesthesia with the patient with this Down syndrome. Case report is here is a 5-year-old male child weighing 20 kg and with the flat faces and all these features suggesting more towards Down syndrome. His karyotype revealed trisomy 21 and he was now diagnosed with hydrocele. He is a known case of hypothyroidism on thyroxine supplementation since infancy. Under examination, he had mouth opening of 2 centimeters, malnutrition 1, and gross spinal abnormalities were ruled out, and 2D echo was done, which was normal, and all the routine blood investigations, including TFT, were normal. Case was accepted under ASAPS2, and adequate preoperative fasting was advised with 6 hours for solids and 2 hours for clear liquids, and he was also advised to take thyroxine supplement on the day of surgery 2 hours before shifting to OT. The patient was managed with subarachnoid block. First, he was shifted to OT. Baseline vitals were noted. All the anesthetic equipments, including difficult airway kit and emergency drugs, were checked, and the patient was sedated with injection ketamine, 40 milligram IM, and 5 puncture was done, pre-medicated, and the patient was put in left lateral position, and subarachnoid block was performed with using 0.5% bupivacaine heavy, 10 milligrams. And then the sensory level attained was T10, and the surgery went on for 30 minutes, and the patient remained stable throughout the procedure. He was monitored, and he was discharged on the first post-operative day. Down syndrome is a chromosomal disorder with an extra 25th chromosome. The clinical features which possess perioperative challenges to an anesthesiologist are flat facial profile, large tongue, high arched palate, as in this patient had, difficult airway, congenital heart diseases. 40% of the cases will have endocardial cushion defects. The patient also had hypothyroidism. Atlanto-occipital or occipital subluxation may be there. Cervical spine manipulations may cause neural compression. So repeated lower respiratory tract infections may also be common in this syndrome. So meticulous antibiotic cover should be given. And anesthetic goals here is to avoid cervical spine handling, to avoid airway handling whenever possible, but should be ready for emergency intubations, and meticulous monitoring has to be done. So to conclude, in our case, detailed perioperative assessment and optimization was done. Anesthetic management was planned with subarachnoid block, as the surgery was intraumbilical, also to avoid manipulations of the airway. So the meticulous anesthetic management resulted in a good perioperative outcome. So my references are Miller's, Harrison, and Opigai. Thank you.
Yeah. Next, Dr. Omar Mukhtar's video poster.
Good afternoon, everyone. I'm Dr. Umar Mukhtar PB. My topic for today is anesthetic management of a case of dilated cardiomyopathy undergoing proximal femoral nailing under sole epidural anesthesia. The incidence of DCM in India is 6.5 per lakh population per year, with male to female ratio of 2:1. Anesthetic management of a patient with DCM undergoing surgery poses a challenge for anesthesiologists due to pre-existing or risk of precipitating CCF. We hereby report the successful use of epidural anesthesia for this patient. A 75-year-old female came to the emergency room with complaints of injury to the left leg following self-fall at home. She was diagnosed to have left intertrochanteric fracture of femur and was scheduled for surgery, which is close reduction in fixation with proximal femoral nailing. She was also diagnosed to have DCM based on 2D echo findings and was started on tab echo sprint, tab torsemide and spiral leptin, and tab remifenol. On examination, her baseline parameters were heart rate of 85 per minute, BP was 110/70. There were no features suggestive of CCF. A 12-lead ECG was normal except for biphasic TVS in leads V3, V4. Chest X-ray showed cardiomegaly. The 2D echo revealed DCM with mid and apical anterolateral, anterior and anteroseptal areas hyperkinetic with the ejection fraction of 36%. Rest of her investigations were normal. After obtaining high-risk consent, we started monitoring under all aseptic precautions. Sole epidural anesthesia was administered through epidural catheter fixed at L1, L2 space. Titerated dose of injection bupivacaine 0.5%, 10 cc was administered, and sensory level of T10 was attained. Surgery lasted for 45 minutes, and there was no significant hemodynamic variations. Her postoperative pain was managed with continuous infusion of injection bupivacaine plus fentanyl. Her immediate postoperative period in ICU and subsequent stay in the ward were uneventful. DCM is primarily a disease characterized by left ventricle or biventricular dilatation, systolic dysfunction, normal wall, LV wall thickness. DCM is the most common type of non-ischemic cardiomyopathy, the third most common cause of heart failure, and the most common indication for cardiac transplantation. In patients with DCM, left and or right ventricular systolic pump function is impaired, leading to progressive cardiac enlargement, a process called remodeling, and often but not invariably producing symptoms of CCF. Although no cause is apparent, in many cases, DCM is probably the end result of myocardial damage produced by a variety of toxic, metabolic, or infectious agents. Mural thrombi may be present, particularly in the LV apex. Perioperative issues in such patients include precipitation of CCF, arrhythmias, and systemic embolism from pre-existing mural thrombi. All these were absent in our patient. Anesthetic management goals in such patients consist of maintaining normolemia, prevention of increase in afterload, and avoidance of drug-induced myocardial depression. Epidural block was planned in our patient because it provides predictable anesthesia, which might not have been possible with sole spine anesthesia. Prevention of undue sympathetic system simulation, which might have occurred with use of GA. There is also an option to increase the level or duration of the block if required, and it also provides good post-operative analgesia. Anesthetic management of patients with DCM poses a challenge for anesthesiologists, but meticulous planning, vigilant monitoring, judicious use of drugs according to patient's general conditions, and judicious use of technique of anesthesia depending upon the surgery and depending upon the surgery site and type of surgery and surgical requirement can lead to a favorable outcome.
Next video, Dr. Suchitra.
Good afternoon. I'm Dr. Suchitra P. The topic for my e-poster is anesthetic management of a patient with dilated cardiomyopathy undergoing an elective cesarean section. Dilated cardiomyopathy is a primary myocardial disease of unknown etiology characterized by left ventricular or biventricular dilatation and impaired contractility. Here, we present a case report of a 28-year-old parturient who was a medically managed case of dilated cardiomyopathy, was scheduled for an elective cesarean section. She was also a known case of hypothyroidism and hypertension and was on medical treatment. Patient was asymptomatic and had already undergone 2 previous normal vaginal delivery without any complication. Baseline investigations to be normal, echocardiography revealed dilated left ventricle and left ventricular global hypokinesia with an ejection fraction of 50%. With adequate preparation for anticipated complications, the surgery was conducted under combined spinal epidural anesthesia. After obtaining informed consent, the monitors were connected and injection noradrenaline was started prophylactically at 1 microgram per minute rate and tapered according to blood pressure. The patient was put in left lateral position and epidural catheter was inserted in L3-L4 interspace and fixed at 8.5 centimeter from the skin. Injection bupivacaine 0.5% heavy 1.2 cc with an additive of injection fentanyl 25 microgram was given intrathecally at L4-L5 interspace. The level of anesthesia achieved was up to T6 level. Throughout the intraoperative period, the blood pressure was around 120/70 millimeters of mercury and the heart rate was maintained around 98 to 100 beats per minute. Later, the injection noradrenaline infusion was tapered and stopped post-operatively. A continuous epidural infusion of 0.125% bupivacaine was given over a period of 24 hours. So, anesthetic management goals in a patient with dilated cardiomyopathy consist of maintaining contractility, avoiding increase in the afterload, minimize the use of drugs that induce myocardial depression, and to maintain normovolemia. Here we use combined spinal epidural anesthesia, which reduces afterload and also improves the cardiac output. Apart from this, it also provided post-operative pain relief, which itself contributes to hemodynamic stability. So to conclude, maintenance of adequate preload, tachycardia, sinus rhythm with prophylactic inotropic support were the main concerns in this case, which was successfully managed by combined spinal epidural anesthesia. Thank you.
Next video, Dr. Sandeep Shindre.
Good afternoon. Myself, Dr. Sandeep Shindre from MIMS, Mandya. My topic is perioperative management of pediatric patient with a Merkel syndrome, postoperative elective herniatomy. Merkel syndrome, it is also known as a mucopolysaccharidosis type 4. It is an autosomal recessive disorder caused by the deficiency of the N-acetyl-galactosamine 6 sulfate. Here, the degradation of creatine sulfate is affected. It will accumulate in the accumulating inside, and the clinical features like large tongue, enlarged tonsil, small widely spaced teeth, short neck, coarse facial features, prognatism, and broad mouth, which affect the mask ventilation and intubation. The skyposcoliosis decreases in the lung volume, and when it causes the ventilation perfusion mismatch, which leads to pulmonary hypertension and pulmonary. The accumulation of glycosamine of glycans in the liver and other organs causes the it affects the drug metabolism, and hypoplasia of the podental process is common, and it causes the atlantoaxial instability and cervical spine cord compression. In anesthetic goal, you have to avoid the active airway management, and using the titrated dose of drugs, and the monitoring the patient to prevent the any airway obstruction. In our case, the surgery was lower abdomen surgery with a mild sedation with subarachnoid block. We conduct the herniatomy was conducted. It was patient throughout the procedure. It was stable. No complications were occurred. The Merkel syndrome, it is a challenging case for us due to airway challenges, pulmonary challenges. It may also involve the cardiac involvement also. In our cases, because of cautious use of drug and the continuous patient monitoring, the potential complications were avoided. And thank you.
Next video, Ranjita Pulikeshi Karmadi. Dr.
Hello
Ranjita
all,
Pulikeshi
I'm
Karmadi.
Dr. Ranjita. I would like to report a case of acute fatty liver of pregnancy in the postpartum period. Acute fatty liver of pregnancy is a potentially fatal metabolic disorder of the liver, the incidence being 1 in 13,000 pregnancies and the mortality rate being high. It is an autosomal recessive disorder which affects the mitochondria. There is deficiency of long-chain 3-hydroxyacyl-CoA dehydrogenase enzyme, which results in the accumulation of medium and long-chain fatty acids. As we can see in the image, there's accumulation of the fatty acids in the hepatocytes when compared to that of normal. Our patient here was a 30-year-old female in her second pregnancy. She was a known case of PIH and hypothyroidism on medication, which was well controlled. At 38 weeks of gestation, she was admitted for elective cesarean section in view of previous LSCS. The intraoperative period was uneventful, and after 24 hours, she presented with fatigue, vomiting, and decreased responsiveness. She was detected with hypoglycemia and was treated. But after an hour, she presented with similar complaints with associated tachycardia and hypotension. She was started on continuous infusion of dextrose as well as noradrenaline was started. And she was shifted to intensive care unit. After a few hours, patient started gasping and there was fall in saturation. So endotracheal intubation was done and she was mechanically ventilated. Routine investigation which was sent showed fall in platelet as well as coagulopathy. Hence, we transfused platelet and cryoprecipitate. The other investigations showed increase in the total counts with deranged RFT and LFT. According to Swansea criteria, there should be 6 or more features out of 14 to fulfill the criteria of acute fatty liver of pregnancy. And our patient had more than 10. It is quite confusing and similar to that of HELP syndrome, but some of the features which differentiated include the first being that the patient had normal range of blood pressure during the entire perioperative period. Then the patient had persistent hypoglycemia, which is usually not seen in HELP syndrome. There was no evidence of hemolysis in our case, and the bedside ultrasound which was done showed fat liver changes. Also, the disease presentation was quite acute. which is usually not seen. So these were some of the features which made us diagnose acute fatty liver of pregnancy. Patient had further deranged LFT and RFT. She went into MOTS and passed away after 48 hours. So to conclude, acute fatty liver of pregnancy is usually diagnosed by biopsy, and hence it is a diagnosis of exclusion and requires a strong index of suspicion. We have to diagnose it early, and aggressive management should be given to reduce the mortality, and it can be life-saving. Thank you.
The meeting is open for discussion for the first 5 cases. We can start the discussion for the first 5 cases.
Excellent presentation by all the 5. If Ravindra sir is prepared to ask questions, he can. I will follow.
Candidate number
First one.
1, Brinda.
Brenda.
Yes, sir.
Yeah, you have a case of Down syndrome.
Yes, sir.
What is the most important thing that you keep in mind in a case of Down syndrome when you are administering either regional anesthesia or maybe recovering a patient from general anesthesia in a Down syndrome? What is the most important thing that you need to keep in mind in a Down syndrome? Because I didn't see you mentioning it. It's the sedation. So when you sedate a patient, the obstructive sleep
Hello.
apnea. Did you hear?
Yeah.
Sir, yes, sir.
No, you answer.
Sir, I didn't hear the question part, sir.
What is the most important thing that you remember, but you keep it in mind while administering a regional anesthesia in a case of a Down syndrome, or while you are recovering a child from general anesthesia?
Sir, they because of the difficult airway and sir, they may be highly sensitive to the anesthetic agents which we give, sir, inhalational drug agents. So the dose has to be, they should be very much monitored, sir, keenly.
Okay. So it is the obstructive sleep apnea history is very important. Apart from the airway obstruction, you didn't hear me. Probably I answered it earlier. Okay, right. Yes, sir. Dr. Periyasamy, please.
Yeah, I feel that the dose you have given for this patient is 10 milligram per ppm, 2 ml, isn't it?
Yes, sir.
In which position you have given? Why do you want to give this much dose for this patient? This is a lower bottom surgery.
Sir, I calculated at a dose of...
Based on your body weight, patient body weight you have given, huh?
Yes, sir.
What is the underlying cardiac problem this patient was having?
No, sir. He had no cardiac issues, sir. But we had ruled out with 2D echo anyways.
No cardiac. What cardiac anomaly you expect out of this? What cardiac anomaly is common in Down syndrome?
So theoretically, they will 40% of Down syndrome patients might end up with endocardial cushion defects, sir.
Okay. ASD, VSD. Okay.
Yes.
That's okay.
We can move on. We can move on to next candidate.
For Omar Mukhtar, I would take the first.
Yes, please.
Yeah. You have given epidural anesthesia for femoral nailing with dilated cardiomyopathy. With what is the? You said what is the cardiac problem? Will the patient will be having in a dilated cardiomyopathy? What dysfunction will be there? In this case, what dysfunction is there?
Sir, usually in patients with DCM, sir, they can have 3 issues, sir. One is pre-existing CCF, sir. In this case, we didn't have CCF, sir. And there is second complication is a risk of embolism, sir.
Okay, what is the function, the systolic function, diastolic function, or both?
Ejection, in our case, the ejection fraction was reduced, sir. It was like 30%, 35%.
Ejection fraction is the test
and
for what?
Patient had global hypokinesis.
Ejection fraction is the parameter
LV.
for systolic dysfunction or diastolic dysfunction?
Systolic dysfunction, sir.
What is the EF?
EF was 35, sir. 35%.
Do you feel this epidural is safe for this patient with this much of EF? Why you have chosen? Why don't you go for a general anesthesia as gold standard?
Like we didn't want to stimulate sympathetic system, sir. And further, with general anesthesia drugs, sir, there is a risk of cardiac depression. Like many of the anesthesia drugs, they're cardiac depressants, sir. So that's why we didn't want to use general anesthesia. So we went ahead with epidural anesthesia alone, sir. With combined spinal epidural, there will be risk of hypotension, sir. We didn't want that also to happen. That's why I underwent only with sole epidural anesthesia, sir.
Yes.
Ravindra, sir.
I think we'll move on. Now,
Yes, sir.
Yeah.
Thank you, sir.
Dr. Suchitra.
Now, this is a case of peripartum cardiomyopathy, right?
Yes, sir.
Again, this is another similar to the previous case.
Yes,
now,
sir.
What was the anesthetic choice for you in this case?
Sir, it was combined spinal epidural anesthesia, sir.
What was the dose of the spinal component of the anesthetic?
Sir, 1.2 cc of bupivacaine with 25 microgram of fentanyl was used, sir.
Okay, why did you give such a low dose?
Sir, firstly, patient was little short statured, sir, depending on the patient. And the low dose anesthesia was preferred to maintain hypotension should be avoided, sir. So,
did you have to supplement epidural for anesthetic purpose, for the surgical
sir,
purpose?
mainly for post-op analgesia, we provided epidural anesthesia, sir.
Okay, so this case, CSE is probably the ideal technique. I agree with you, but 1.2 ml, I feel, is a little low dose. But since you have a backup epidural, it's okay. It is all right. 1.2 ml, you may not be in a position to complete a surgery in the ideal situation. It's okay. You have added fentanyl, right?
Yes, sir. Yes, sir.
Then I think that is what has played the role. Fine. Thank you.
Thank you.
Suchitra.
Yes, sir.
You have taken some precautions to prevent hypotension with the inotropes, isn't it?
Yes, sir.
The goal is to reduce the afterload. Will this drug will increase the afterload?
Sir, actually, in order to avoid the hypotension, we started with the inotrope support, sir. In order to maintain the blood pressure around 120/70, we added the inotrope support, sir.
Okay. So next to
Dr. Sandip Shintra.
Marguerite syndrome. It is a very rare problem. Elective hernioplasty done under spinal. What is the problem, commonest problem you expect in this case, Sandeep sir?
Sir, large tongue, sir. Sir, upper airway obstruction, sir. And they will have voluntary process will be low, sir, small, sir. So cervical neck instability will be there, sir. So during intubation, it will be problematic, sir. It may compress the cervical spinal cord, sir.
So with all this much of problem, you have prepared to go for regional, but you anticipated the difficulty in intubation in this case, isn't it?
Yes, sir.
What precautions you have taken before you start the case to manage this airway difficulty?
Sir, we've arranged the difficult airway trolley, sir, like Buji who kept and Miller blade who kept, sir, and sir, with video laryngoscopy also we kept, sir, kept ready, sir.
Okay, that's fine. We'll move on to the next case, sir.
Dr. Ranjita. Dr. Ranjita.
Acute fatty liver pregnancy. Sir, Ravindra sir, please, sir.
So, acute fatty liver of pregnancy is a relatively a rare condition, right?
Yeah.
To make a diagnosis of acute fatty liver of pregnancy, other than its acute presentation, Did you have anything else? Why don't you say that it is HELP syndrome? Why it's a severe preeclampsia? Why it is not severe preeclampsia? You're not audible. You're muted.
Dr. Ranjita.
You're muted. Unmute yourself.
Dr. Ranjita.
Yeah.
Yes.
Go ahead.
Hello.
Go on.
Sir. Yes, sir. There was hypoglycemia in this patient and it was persistent. So she presented with repeated episodes of hypoglycemia. Her blood sugar was around 30 to 50 most of the time.
Okay.
It is one of the major factors differentiating HELP and acute fatty liver of pregnancy.
Hypoglycemia. Yes.
Yes, sir.
Right. So,
okay. Acute fatty liver pregnancy in postpartum, what is the mechanism? What is the cause of acute fatty liver in a pregnancy?
Sir,
Where is the pathology in
it is
this
rarely
case?
seen in postpartum period. It is rarely seen in the postpartum period and usually seen in the third trimester, where there is abnormal fatty acid metabolism in the fetus. So there is deficiency of a particular enzyme, long chain, 3 long chain.
Yeah, it is a fetal part or maternal side? Where is the pathology?
It's fetal part.
Okay, we'll move on.
Yeah, right, sir.
Yeah.
Thank you.
Next video.
All of you did fairly well.
Yeah.
Thank you.
Next 5 videos, Dr. Upasana Tiwari. Next video, madam.
Good afternoon. I am presenting a documented case of ruptured aneurysm of valsalva. Sinus of valsalva aneurysm is an enlargement of aortic root between aortic valve annulus and sinotubular ridge. Diameter of sinus of valsalva in males is 4 centimeters and in female it is 3.6 centimeters. Most of the time, this aneurysm of sinus of valsalva is an incidental finding and it occurs due to weakness of elastic lamina at the junction of aortic media and annulus fibrosis. Prevalence in general population is 0.09% and it can either be congenital or acquired. If it is congenital, it can be associated with various syndrome, that is Marfan syndrome and Ehlers-Danlos syndrome, etc. Here I am presenting a case of 35-year-old multigravida who underwent cesarean section 4 years back, which was uneventful, and a normal delivery 2 years back, that was also uneventful. In current gestation, patient is asymptomatic but gives history of retrosternal discomfort and mild breathlessness post normal delivery 2 years back, which was conducted at home and which subsided without any medication. Here in examination, we found continuous murmur in left parasternal area for which 2D echocardiography was advised, and 2D echocardiography report showed evidence of rupture of aneurysm of right coronary sinus of valsalva. Coming to anesthetic management of this patient, here right subclavian central venous catheterization was done for IV fluid resuscitation and right radial artery cannulation was done for invasive blood pressure monitoring, and patient was preloaded with 0.9% Ringer's lactate at 10 ml per kg, and patient was pre-medicated with injection midazolam 1 milligram IV and injection ondansetron 4 milligram IV and injection ranitidine 50 milligram IV, and epidural anesthesia was given at L3 L4 intervertebral space with 15 ml of 0.5% injection bupivacaine, 5 ml of 2% lignocaine, and injection sodium bicarbonate 2 ml in a graded manner. That is 5 ml of solution was injected every 10-minute interval till T6 level was achieved and hemodynamics was maintained between 20% of the baseline. And then post-operative analgesia was given with 0.125% bupivacaine with injection fentanyl 1 microgram per kg at the infusion rate of 5 ml per hour for 2 days, after which catheter was removed. Intraoperative period and post-operative period for this patient were uneventful. To conclude, these patients can present with congestive heart failure, cardiac tamponade, dysrhythmia, and coronary ischemia. So we should be adequately prepared for any anticipated and unanticipated complications. Thank you.
Next video, Dr. K. Vinod Kumar.
Hello all, I'm Dr. Vinod Kumar. Today I'm going to present a case report on misplaced central venous catheter and the importance of natal valve orientation in redirecting it and its usefulness in correct placement. So a 60-year-old female, ESRD patient needed a central line cannulation for the purpose of central venous pressure monitoring. So a plan was made to cannulate the right subclavian vein. It was cannulated using landmark technique without any complication. The CVP reading were erroneous and the bedside chest X-ray taken showed the catheter was misplaced in the right internal jugular vein. A simple plan was made to redirect the catheter using the needle bevel direction. Now over the misplaced catheter, guide wire was inserted and the catheter was taken out. Now over the guide wire, needle with marked bevel side was inserted in a manner that the bevel is oriented inferiorly towards the SVC. Now the guide wire was taken out. Free flow of blood is aspirated from the needle and the guide wire was once again inserted and the catheter was over it. Now the bedside chest X-ray confirmed the catheter tip at the superior vena cava, as you can see in the chest X-ray here. So the problem with the catheter migration is associated with thrombosis, perforation, catheter dysfunction, obstruction of upper venous system. Ambach et al. Suggested the internal jugular vein occlusion test to identify the correct position over the subclavian vein. It is by applying the external pressure over the interjugular vein for approximately 10 seconds and observing the changes in the central venous pressure waveform pattern. Manual compression of the ipsilateral IJV during subclavian vein cannulation decreases the chances of advancement of central venous catheter into the ipsilateral IJV. Excessive length of guide wire is also considered as risk factor. Tirupati et al. Suggested initial orientation of the J-type guide wire tip during the subclavian approach can influence the final position of the catheter tip. Needle bevel and guide wire J-tip orientation might be directed upwards, which could be the reason here for the misplacement. Venous valves also tend to misplace the catheter. Conclusion. This case illustrates the simple needle bevel and guide wire orientation, which can minimize the misplacement of central venous catheter. As you can see here, these are my references.
Next we need Dr. Praveen.
Good morning, everyone. I'm Dr. Pravina, second year postgraduate. My topic is a perfect oxygen de-escalation pathway can escalate the recovery of a COVID-19 patient. A long-haul COVID case report. Introduction. Patients diagnosed with COVID-19 have a broad range of presentations from asymptomatic carriers to those with severe critical illness with pneumonia, ARDS, and multi-organ failure. In this case report, we describe the trajectory of recovery in a young, healthy patient diagnosed with COVID-19 who developed ARDS. We suggest the importance of oxygen therapy in ICU and importance of follow-up of patients who are on long-term ICU stay for COVID-19. Case presentation. Our patient was a 35-year-old man with an unremarkable medical history. He first noticed symptoms of dry cough, body aches, and low-grade fever. 5 days later, he had notable shortness of breath with minimal exertion with progressive dry cough, pain, and profuse sweating. On day 7, he was referred to a hospital and admitted in ICU for room air oxygen saturation reported between 80% and 88%. The result of his respiratory viral panel was positive, and his chest CT demonstrated multiple vexed opacities, ground glass opacities in bilateral lung fields, consistent with bilateral pneumonia, and his CORAD score was 23/25. And the inflammatory markers were also in higher range. The patient's family reported no travel history or exposure risk. Discussion. We present a case report of a young, previously healthy patient who developed ARDS due to COVID-19. The purpose of this report is to demonstrate the clinical trajectory and suggest the importance of oxygen therapy in ICU and role of follow-up visits. Oxygen therapy is the first-line therapy for treating COVID-19-induced respiratory distress and hypoxia. Goal of treatment should be maintenance of oxygen saturation more than 90%. Our patient responded well to supportive treatment in the ICU, including non-invasive ventilation for 7 days and a total ICU stay of 30 days with supplemental oxygen support. Our patient continued to improve with oxygen requirements gradually reducing, and he was discharged to home after 2 negative test results. 2 weeks after discharge, he returned for his first follow-up. His repeat CT score was 15/25 and complained of general fatigue and exhaustion. And on day 90, his PFT is shown restrictive disease pattern and echo was of normal study, and he reported significant improvement overall. Conclusion, we present this case report to suggest that oxygen therapy playing an important role in patients' recovery in ICU, and patients serving COVID-19 with subsequent development of ARDS will require more intense ICU recovery follow-up. We suggest that even younger patients with no known comorbidities can also develop severe COVID-19 related complications. Thank you.
Dr. Ramya, next video. Dr. Ramya.
Good morning, one and all. I'm Dr. Ramya, second year postgraduate, Kanyakumari Government Medical College. And my topic is Rescued from the Death's Door, the Journey of an Octogenarian in COVID Crisis. Introduction: an outbreak of respiratory disease was first reported in Wuhan, China in December 2019, and the causative agent was discovered to be novel beta coronavirus and named as SARS-CoV-2. Owing to the vulnerability and multiple comorbidities in elderly people, they are the most commonly affected sector with COVID-19 infection, with high risk of progression to severe infection and higher rate of mortality. Case presentation: an 8-year-old female patient came to the hospital with complaints of fever, dry cough, and loose stool for 2 days. She had a previous history of hypertension, cavernous sinus thrombosis, transient ischemic attack, and chronic bronchitis. Laboratory examination revealed hyperleukocytosis, hyperneutrophilia, and hypolimpemia with an elevated inflammatory marker status. CT chest showed a Corrad score of 23/25 and a 95% lung involvement with bilateral subsegmental opacities and patchy consolidation. Patient was started on antiviral therapy with injection remdesivir and injection methylprednisolone and other supportive measures were taken. However, the patient deteriorated, and on day 9, the patient became drowsy, cyanosed, and saturation dropped to 40%, and the patient was immediately connected to HFNO. Her procalcitonin levels were checked, and she was started on single dose of injection tocilizumab. She improved clinically, and her vital signs stabilized with saturation improving to 92%. 1 day later, again she desaturated, and the patient was connected to CPAP mechanical ventilation and maintained till day 15. On day 18, patient developed aphasic CVA, and the patient saturation still maintained at 92% with HFNO. On day 24, patient developed high-grade fever with chills, and urine culture sensitivity was positive for Pseudomonas, and higher antibiotics was started. Till day 40, patient was maintained with HFNO, and later, since the patient improved symptomatically and the patient was changed to non-rebreathing mask, and proper de-escalation of oxygen therapy was followed, and patient was discharged on day 57 with the room air saturation of 97%. Conclusion: elderly patients with COVID-19 are more likely to develop into severe type with unfavorable prognosis. There were several risk factors associated with the poor outcomes in this patient, which included the presence of multiple comorbidities like TAA, cavernous sinus thrombosis, chronic bronchitis, hypertension, or COVID complications such as ARDS, septicemia, and septic shock. The experience in this case suggested that elevated inflammatory markers are poor prognostic factors which needs to be alerted. Meticulous monitoring of oxygen requirements of the patient and planning of oxygen therapy accordingly improve the outcome of the patient. Thank you.
One more.
Dr. Kirtinath.
Good morning, respected all. Here I present a case of recurrent SVT in third postnatal day with hemodynamic instability. She was given multimodal therapy with vagal maneuvers, cardioversion. Nearly 5 cycles of DC shock was given, inodrops, antiarrhythmic agents, and mechanical ventilation, which ended successfully in improving patient prognosis. A case of 38 years female, P2L2, post-labor natural, postnatal day 3, GDM on insulin, developed sudden onset respiratory distress and hemodynamic instability. Patient was, on examination, patient was irritable. Heart rate was around 260 per minute. Carotid pulsations alone was present. ECG showed supraventricular tachycardia. Right external jugular vein was secured. Carotid massage was tried, but only a transient fall in heart rate was noticed. In view of hemodynamic instability, patient was given synchronized electrical cardioversion with 100 joules biphasic DC shock. Rhythm reverted to normal, but subsequently developed another 4 episodes of SVT, reverted using DC shock. Meanwhile, patient was intubated and mechanically ventilated, and in view of persistent hemodynamic instability and recurrent SVT. Right femoral vein cannulated, vasopressors was started, amiodarone loading dose was given, insulin infusion started as CBG showed high, bedside echo suggestive of moderate mitral stenosis with left atrium grossly dilated. The patient, subsequent hours, patient developed acute kidney injury for which fluid challenge was given, and gradually renal parameters got normalized. After 10 to 12 hours of mechanical ventilation, patient was gradually weaned and extubated. Management of SVT in postpartum period is similar to that of non-pregnant patients. Amiodarone is a drug of choice in an acute setting of acute refractory SVT. To conclude, vigilant monitoring of postpartum patients with underlying heart disease is required, especially in the initial 48 to 72 hours. Thank you.
Time for discussion.
Yeah, very nice presentation by all five. The first question, the first presenter, aneurysm of sinus of Valsalva, multigravid undergoing. She has mentioned it as a ruptured. What is the normal finding that the patient will have in a ruptured aneurysm? Rupture means, how will you say unruptured and ruptured?
Hello,
ruptured
sir.
So you said it is a ruptured aortic aneurysm, isn't it?
Yes, sir.
Rupture is most commonly on which side? And
yes, sir. Sir,
in this
usually,
case,
sorry, sir.
In this case, you said ruptured. What is the finding to say? You have to say it is a rupture.
Yes, sir. Sir, like while auscultation, all general physical examination was normal, sir. Only on auscultation, we found a murmur in the parasternal area, sir. So that is why we had asked for 2D echo. And then in 2D echo, we found out it was mentioned in 2D echo, sir, that patient has one evidence of ruptured sinus of Valsalva, sir. But patient did not have any complaints.
So in a ruptured aortic aneurysm, why you have chosen regional anesthesia? What is the ideal anesthetic management?
Yes, sir. Like in general anesthesia, we will have better control of hemodynamics, sir. But here we didn't want to manipulate her airway, sir. That is why we have selected sole epidural, sir. And even
I think we'll move on, sir, but that is a highly confusing situation.
But the second case is very interesting, sir. The misplaced central venous catheter, the Vinod Kumar. It is very nicely managed by Vinod Kumar and team. What is the Vinod Kumar? My question is, what you have to do to prevent this IJV entry of the catheter before you, at the time of putting the catheter?
So we can occlude the IJV itself, sir, at the time of inserting the subclavian catheter.
What should be the positioning of the neck?
Positioning of the neck, so we can extend the arm, and we can also use the shoulder roll under the patient, sir. So that's how we can extend
the head will be turned on the same side or opposite side? That is my question.
Head is turned away, sir. Turned away, sir. No.
No. You have to turn on the head at the same side. If you turn opposite side, the likely entry into the IJV is common.
It's common.
Yeah.
Oh, okay, sir. Thank you.
Whether this bubble turning, choroid or cephaloid, I don't know. I'm skeptical about the direction, but the head turning to the side of placing the subclavian definitely prevents. This has an evidence actually. There's a lot of reports on that.
Okay.
Anyway, I think this is also we tried. It's not a, but whatever said and done, you have to take an X-ray to confirm that it is there. That's a very important. Yeah.
Okay, sir.
Yeah. Right. Good.
Thank you.
Pravina and Ramya, the two cases is almost similar case management in COVID-19. Very well managed. One is 35 years, another one 57 years. And see, the Pravina said it is a long haul COVID case report. When will you say the case is a long? After how many days you will say it is a long period?
Yeah, unmute.
12 weeks, sir.
1 week. Good. And the another case, 57 days management, 80 years old. It is really very good, very well managed. I want to congratulate both the PGs from the institution and the head of the institution.
No, I
Very well
would like to ask one question.
Yes, sir.
The person who spoke about the CORAD score, who spoke on CORAD scoring? One of you mentioned the CORAD score.
Yeah, my patient had a CORAD severity of 23/25, sir.
Yeah, can you please tell me what is CORAD scoring and what is CT severity scoring? Is there any difference? See, CORAD scoring is not CT severity scoring. What you spoke is the CT severity scoring. Now that is 5 scores for every segment of the lungs, 3 lobes on the left side and 2 on the right side. Sorry, the vice versa is true. And CORAD scoring is to make a diagnosis of COVID-19 by HRCT only. That is CORADs 1, 2, 3, 4, and 5, and 6 is with HRCT positive. So you understand that. So what you said is not CORAD scoring, it is the CT severity scoring.
Yes, sir.
Okay, but both cases are very well managed. I really congratulate the institutes for that.
Thank you, sir. Thank you, sir.
Yeah,
and this
thank
question
you.
is to Kirti Nath, management of recurrent SVT
Good
in
evening,
early
sir.
postpartum period. Yeah, good. Why the SVT is more common in postpartum period? It is reported many times SVT is more common in immediate postpartum period. Why?
Actually, in normal patients, the cardiac output, there will be increase in cardiac output during the labor time. So 20% during the first stage of labor, second stage 50%, and 80% during the third stage of labor, sir. And this will be reverting to the normal pre-labor values within another 24 hours, sir. Whereas in the case of a cardiac patient underlying structural heart disease, sir, it will take another 40 to 72 hours, or it can be up to 1 week for these changes to get normalized, sir. So there'll be there'll be increased stretching of the cardiac myocardium. Stretching will be there. So these patients are more prone for
Does this
arrhythmia.
patient is having any underlying cardiac problem?
Yes, sir. Patient actually on table after the 4th cycle of DC shock, we have taken a bedside echo, sir, 2D echo, which was suggestive of mitral stenosis moderate, and left atrium was grossly dilated, sir. There was no LA clot, sir.
It was unnoticed prior, isn't it?
Yeah, yes, sir.
Good. What vagal maneuver you do commonly? How will you do? What are the vagal maneuver you have?
Actually, commonly we'll be doing with carotid massage, sir. Apart from that, we can go with oculocardiac ocular massage also can be done, sir. Apart from that, Valsalva maneuver. But in this patient was highly irritable, sir. Patient was not able to respond to our comments, sir. So we didn't do Valsalva maneuver. Carotid massage alone was done, sir. But only a transient fall in heart rate was seen, sir.
You said cardioversion is given for this case.
Yes, sir. Actually,
under anesthesia or?
Yes, sedation was given, sir. Midazolam 1.5 mg IV was given, sir. Following which we gave direct electrical cardioversion. 100 joules were given. All the 4 cycles of SVT, we have given electrical cardioversion with 100 joules, sir.
Yeah, fine. Over to Ravindra, sir.
Right, sir. Thank you. I think she has done a wonderful job.
Yeah.
Good job done.
Thank you, sir. Next video, Dr. P. Lipika. Next video can be played.
Good evening, I'm Dr. P. Lipika, first year postgraduate, Neurologic and Medical Sciences. I'm going to be speaking on the anesthetic management for polytrauma patients. Introduction: hemothorax is a collection of blood in the peripheral cavity and occurs often after trauma, resulting from blood penetrating injury to thoracic structures, including the heart, mediastinum, lungs, great vessels, lung vasculature, and chest wall. This is associated with pneumothorax 25% of the time and with extrathoracic injury 73% of the time. We report a case of traumatic pneumothorax due to fracture of ribs with a fractured lower end of the right humerus in the 34-year-old male. The 34-year-old male patient presented the casualty with a history of pain and swelling of the right arm for 3 days following a road traffic accident. X-ray revealed a fracture of the lower end of the humerus, chest X-ray revealed fractures of 5th and 6th ribs on the anterior aspect. On the left side, HRCT chest revealed fractures on the anterior and posterior parts of the right, 4th, 5th, 6th, and 7th ribs associated with bilateral hemothorax and right oblique fissure effusion. bilateral posterior base epistaxis and coraz-1. Laparotomy test.
Audio is not clear.
ECG showed normal sinus pressure. On pre-anesthetic evaluation, the patient with anesthesia.
Not at all clear, sir.
Yeah.
It's recorded one reason.
SpO2 was 95% at room where it passed 86 per minute. Blood pressure was 135/80. Investigations were within normal limits.
Sir, that audio is not clear, but Lipika is in line. Shall we?
Then we can move on to next video.
Okay, okay,
Yeah,
fine.
we'll catch her in discussion. No problem.
Okay, fine.
Dr. Kavya. Yeah.
Good afternoon, everyone. I am Dr. Kavya. My topic is retrospective analysis of type of oxygen therapy in COVID-19 patients in COVID intensive care unit at Government Vellore Medical College and Hospital. Introduction. The coronavirus has rapidly spread and swept across most countries worldwide. Severe cases rapidly deteriorate within 1 week after onset and develop into COVID acute respiratory distress syndrome and respiratory failure, often requiring treatment in intensive care unit. Oxygen therapy and supportive care are the main form of therapy. In our hospital, different kinds of oxygen therapy were used for patients admitted in COVID ICU. This presentation is about the statistical analysis of different type of oxygen therapy given to patients in our hospital. The different type of oxygen therapy were initiated to patients like mechanical ventilation, continuous positive airway pressure, high flow nasal oxygen, non-rebreathing mask, and simple face mask. Escalation and de-escalation was done based on clinical condition, oxygen saturation, and ABG. Materials and methods. The patients tested positive for COVID-19 by RT-PCR who were admitted to COVID ICU were included in the study. Although most of the patients remained asymptomatic, only few patients required oxygen therapy. A retrospective analysis was done by collecting details from 100 random cases of COVID-19 patients who were admitted over a period of 5 months from May to September. Information regarding the oxygen therapy on admission and during the course of ICU stay was studied. This picture shows number of patients on different mode of oxygen therapy on admission. The bar graph explains the outcome of patient on oxygen therapy, in which orange color shows admission, blue color shows escalation, and red color shows de-escalation. Results. Out of 20 patients on NRM, 14 patients required higher mode of oxygen therapy, in which 7 required CPAP and 5 required HFNO. 6 patients weaned off. Out of 37 patients on HFNO, 30 patients required higher oxygen, 21 requiring CPAP and 2 mechanical ventilation. 7 patients weaned off. Out of 36 patients on CPAP, 28 patients required escalation, in which 3 patients were put on mechanical ventilation and 8 patients weaned off. Out of 7 patients on mechanical ventilation, 2 patients were successfully recovered and discharged. Out of 100 patients, 24 patients could not be revived. Rest of them were shifted to step-down ward and discharged. Conclusion. The patient who had severe disease during admission required higher form of oxygen therapy and had poor outcome. In our study, patient who required mechanical ventilation on admission had poor prognosis, and those who required other mode of oxygen therapy had better prognosis. Limitation of the study. The timeline of escalation or de-escalation of oxygen therapy was not studied. Only 100 random cases of patients admitted during the 5 months were studied. Thank you.
Next video, Dr. Ayuva Prashant.
Good morning. I'm Dr. Prashant Tahivade, anesthesiology resident. I will be presenting a rare case of association of tuberculous meningitis with dengue. Dengue infection is one of the most common mosquito-borne viral infection in India and also worldwide. It can be mild with few symptoms like fever, headache, maculopapular rash, orbital and joint pain, with blood picture showing thrombocytopenia and leukopenia, to serious complications like dengue hemorrhagic fever, dengue shock syndrome. There are very few case reports that discuss the laboratory characterization of dengue infection in CNS. Hence, we report an evaluation of an IgM seropositive case of dengue who showed neurological manifestations of tuberculosis meningitis in course of the infection. So we had a 23-year male with complaints of fever, difficulty in talking, disorientation, neck stiffness since 2 days. On examination, his vitals were stable. His GCS was 12/15. He was drowsy, disoriented with pupils bilaterally reactive to light. We did his routine investigations, which were normal. His CSF examination was sent, which suggested viral meningitis. Dengue profile was done, which suggested IgM positive, IgG and NS1 negative. Also, we did a CSF ADA that suggested tuberculous meningitis. Along with this, we had done his MRI brain. It suggested meningitis. He was treated with acyclovir, ceftriaxone, vancomycin, anti-tubercular treatment like isoniazid, rifampicin, pyrazinamide, and streptomycin, along with other symptomatic treatment. So discussion, dengue and tuberculosis sometimes have an abnormal presentation. The serotype, along with other factors like age, ethnicity, interval between first and second infection, and presence of other chronic diseases are associated with more severe forms of the disease and may be responsible for the increase in incidence of neurological manifestations. Dengue antibody IgM usually appears in serum 5 to 10 days from the onset of infection. The patient presented with fever and neurological symptoms. Also, his MRI brain suggested meningitis. When dengue antibody testing was done, IgM was positive with IgG NS being negative. This is not a classical clinical picture of dengue. Anesthetic implications. The risk of neurological puncture in patients with increased ICP can result in tentorial herniation. To prevent further increases in ICP, excessive coughing and gagging during emergence from anesthesia should be avoided. In dengue, there can be highly diminished platelet count that is absolute contraindication to regional anesthesia. So my conclusion is dengue and tuberculosis are a major public health problems, especially in the rural sections of our country. One should keep in mind that it may present with wide range of neurological manifestations. Hence, a case of dengue exhibiting neurological manifestations must initiate a suspicion in one's mind. The best aid for diagnosis of neurological manifestations associated with dengue infection may be done by a combination of CSF and immunological tests. Hence, one should not avoid considering a CSF examination, especially in patients belonging to dengue endemic areas. Thank you.
Next will be Dr. Kavya.
Good evening all. I am Dr. Kavya. I am presenting a poster on hypokalemic periodic paralysis with respiratory failure in pregnancy. Acute hypokalemic paralysis is a clinical syndrome characterized by attacks of reversible flaccid paralysis with low serum potassium. The attacks may range from a mild weakness at a single muscle group to rare complete quadriplegia with respiratory paralysis and death. It is a rare but treatable cause of acute weakness. Here we report a case of 27-year-old preemie with gestational age of 13 weeks presented with sudden onset weakness of all 4 limbs. She had difficulty in swallowing and speech. She had fever, vomiting, and diarrhea for 3 days prior to the onset of weakness. On examination, patient was conscious oriented. Pulse rate was 110 per minute. Respiratory rate was 30 per minute. Saturation was 90% with case mosquito. BP was 130/80 mm mercury. Neurological examination revealed flaccid paralysis of 4 limbs with intact sensation. Investigations revealed potassium of 1.7 milliequivalent per liter, T4 of 1.9 nanogram per deciliter, TSH of 0.027 milliunits per liter. Patient was intubated and connected to mechanical ventilator for impending respiratory failure. IV potassium chloride 40 milliequivalents in 500 ml is given through central venous line at a rate of 6 milliequivalents per hour. After IV potassium replacement, muscle power improved gradually and potassium level increased from 1.7 milliequivalent to 3.6 milliequivalent per liter. On day 3 of mechanical ventilation, patient had crepitations and diminished air entry on right side, for which bronchoalveolar lavage was done on next day. After 7 days of mechanical ventilation, patient was extubated and put on non-invasive ventilation. Patient was gradually weaned from ventilator. Serial used monitoring for fetal viability was done and fetus was found to be healthy. This chest X-ray was taken before bronchoalveolar lavage. There is easiness in the right lower lobe. This chest X-ray was taken after bronchoalveolar lavage. Hypokalemic periodic paralysis is the most common periodic paralysis with the prevalence of 1 in 1 lakh population. Familial hypokalemic paralysis may occur sporadically or as a result of autosomal dominant inheritance. Acute paralytic episodes are treated with potassium replacement. Thyrotoxic periodic paralysis occurs in the settings of hyperthyroidism. Any cause of hyperthyroidism can be associated with thyrotoxic periodic paralysis, but Graves' disease is the most common. Beta blockers may prevent the attack, but the definitive treatment is the correction of underlying thyrotoxicosis. Hypokalemic periodic paralysis can result from GI or renal losses. In these cases, total body potassium will be depleted and requires aggressive treatment. To conclude, periodic paralysis should be considered when patients present with sudden onset of weakness, especially those with no history of other disease and no significant risk factor for stroke. Failure to diagnose and treat periodic paralysis can be fatal. Correction of potassium level can completely resolve the symptoms. Thank you.
Next poster, Dr. Aravind.
Good evening, everyone. I'm Dr. Aravind from PHG Hospital. We are presenting a case on fallacious cuff pressure monitoring related to life-threatening complication. We had a 60-year-old female who had acute and chronic renal failure and recent cerebrovascular disease, and they had received mechanical ventilation for past 8 days, and they referred here for further management. On examination, she had a visible neck swelling. As a part of routine ICU investigations, we had taken a chest X-ray, which grabs attention by an abnormal tracheal shape, which is like to evaluate with CT. As you see, we corroborated the findings of the chest X-ray. The transverse diameter of the trachea was found to be around 5 centimeter, which is usually 2 to 2.5 centimeter. So, what is causing this tracheomegaly? Probably an over-distended cuff which attributed to this tracheomegaly, but the cuff pressure seems to be around 30 centimeter. Hence, it is unlikely. So we have to go to other causes of tracheomegaly through bronchoscopy, but it's unremarkable. And due to persistence of the subnormal shape and air leak, we decided to change the tube, and the tube changed after complete deflation and was found to be still inflated. This is the so there is an over-distended malformed cuffing. This is the tube cuff when it is compared with the normal cuff here. And the cuffing in the new electrical tube was also to more than 200 ml. Hence, cuff has to be inflated up to 80 centimeter of water to ensure adequate silver ventilation. This time we did it intentionally, and usually tracheal necrosis is at 40 centimeter of water. So we have posted a patient for emergency tracheostomy. The tracheostomy has been low tracheostomy, difficult for surgeons, and the tract was filed to bystander. Against there is a strong suspicion of tracheal fistula. And later the radioscopy was done to confirm it, and there was large esophageal tract at 18 centimeters, which is not amenable to stenting. Our patient had a post-intubation tracheal fistula, which is an acquired benign complication, occurs between 12 to 200 days of ventilation. In our case, it occurs much earlier, that is 10 days. Probably due to two reasons. One is over-distended cuff, which was showing falsely low cuff pressure values. This false acoustic is seen in kinked parent balloon and malfunction one-way valve. And patient risk factors also attributed to earlier TF. That is excessive motion of the tube due to transport and high cuff pressures and presence of rigid nasogastric tube and prolonged immunosuppression, small nutrition, and advanced age. And the take-home point is though cuff pressure monitoring is an essential part of ICU care, it is not fail-proof. Hence, physical examination, radiological evidence, and high vigilance aids in diagnosis of this over-distended cuff and thereby preventing this life-threatening complication. And studies suggest that inflation with lignocaine compared to the area has a much more safety profile in regards to variation cuff pressure. And also helps in preventing post-operative sore throat. And these are our references, and thank you for patient listening.
Thanks for discussion. Dr. Lipika.
Yes, sir.
Sir, unmute yourself.
Yes, sir.
What is that, sir?
Polytrauma patient. I'm sorry, I just couldn't hear anything in that. I don't know how. Dr. Peresome, can you ask some question on that? Yeah.
Yeah. As you said, I'm not able to hear, but I want to ask one question. Polytrauma case with head injury. Usually our people will ask for CT brain before we proceed. Polytrauma with abdominal injury or chest injury, head injury along with that, limb injury. Will you give priority to head injury, ask for CT, or will proceed for surgery or stabilizing the patient? Will you push the patient inside the OT? Which to be given the
First, we'll
priority?
stabilize. First, we'll secure the airways. Then only we'll proceed to the next.
Good.
Why do you want to do like that? Don't you think that the head injury is important?
Yes, so with the airway is more, we need to secure the airway first. Head injury, well, it's in list of priorities. The airway is more important. So.
Why it is priority? Why do you want to stabilize the patient before putting the patient in for CT brain?
Because well, we should like the saturation should be maintained, so because otherwise cerebral oxygenation will also not happen. So.
See, the point is, I'm not getting the correct answer. See, brain damage already has occurred. If you're not stabilizing the patient with vitals and pushing the patient to correct other problems, you will do secondary damage to the brain. So
Yes, sir.
instead of waiting for CT brain, you have to stabilize, you have to proceed for surgery. That is the point I'm expecting from you. Okay, otherwise it's okay. Thank you. Sir, over to you, sir.
No, that's okay, sir, because that's the most important thing. In fact, in polytrauma, even I wanted to ask the same question. Number one, the airway. Number two, hemodynamic stability. If you don't do that, secondary problems will always be there.
Yes, sir.
And Dr. Kavya.
HFNO, she said, how much of O2 she was, from her study, the average O2 the liter they have used to bring the patient out. What is the HFNO oxygen requirement for overall patient, Dr. Kavya?
Sir, in basis of severity, we had given up to 60 liters, sir. Later, depending on patient saturation and clinical features like where they their tachypnea or dyspnea, it was reduced up to 20 liters, sir. 15 to 20 liters.
What is the target SpO2 level to be achieved? From what is the range we have in HFNO oxygen supply? What is the range?
88 to 90.
88 to 90 SpO2 is a target SpO2. And you are telling, isn't it? You said 60 liter. Do you keep 60 liter for all patients or depending on the patient? What is the minimum oxygen amount can be given with HFNO available machine? Okay.
What is actually, what is ROX index in HFNC? Okay, forget about. Go ahead and just refer it, because I can't tell you what ROX index is now. Anyway, in the essence of his question is, in HFNC, high flow nasal oxygen, even though it says that it is high flow nasal oxygen, it is not 100% oxygen. The oxygenation, the total flow is high flow, but the oxygen is only a fraction of it. Starts from room air 21% to even 100%. And most of the times you go by the ROX index to, decide that. Yeah.
Dr.
Ahiwala combination of the tuberculosis meningitis and with the dengue is very interesting and something different. Very well managed. I don't have any question for him, sir.
Yeah, because it's not a very common thing, I feel, but it is very well managed. Keeping that in mind, the possibility of tubercular meningitis is always a wonderful thing. Thank you.
Dr. Kavya.
Yeah. The next one is hypokalemic periodic paralysis, right?
Yes, sir. Yes, sir.
Now, so this is one atypical presentation, like, a total respiratory paralysis in a periodic hypokalemic paralysis. But how does this case present normally? How do they present? Hypokalemic periodic paralysis, how do they present?
Single muscle group weakness to paraplegia.
You're not audible. I couldn't hear anything.
Can you repeat, ma'am?
It will present as single muscle group weakness to paraplegia. Some cases it may go for respiratory muscle weakness.
What triggers their paralysis? The weakness is triggered by certain things. What triggers it?
Due to GE losses or
low potassium value?
No.
Serum low.
No. They don't precipitate at all. What precipitates is a very high carbohydrate rich food that he or she takes. And the second thing is a severe exercise. These are the only two such things which precipitate familial periodic hypokalemic paralysis patients. And pregnancy complicated by this is a relatively uncommon situation. Okay, anyway, move on to the next one. Sir, you have any questions, sir? Periyaswamy, sir? Yeah.
Dr. Aravind.
Good evening, sir.
Dr. Aravind.
Sir?
Sir?
Dr. Periyaswamy, you unmute yourself and ask the question, yes.
Sir, I missed the last presentation, but hypokalemic periodic paralysis with the respiratory failure in pregnancy is a very rare situation. You rightly mentioned about the triggering factors, and pregnancy with a fetal outcome and I think the glycemic status will be hyperglycemic status is more common in pregnancy. That may be the cause, and otherwise the management is okay. I don't have any more questions, sir. And I missed this last presentation. Please, you ask.
So the cuff pressure monitoring. Do you use the cuff pressure monitoring routinely?
Yes, sir. As ICU care, we will use as every 4th hour we will measure cuff pressure, sir.
Okay. Now, under anesthesia, is there any possibility? What is the, now, if you take across India, now every anesthetic that is done, general anesthetics that is done, what is the incidence of cuff pressure monitoring, and what is the incidence of complications for not having measured it? ICU is a different setup. I agree with you, because prolonged ventilation.
Yes, sir. Sir, even though we didn't measure in OT, we don't measure cuff pressures. The incidence of complications is very low, sir.
Extremely low.
Extremely low, sir.
Yes, but because in ICU there is prolonged ventilation, the intubation time is extremely high, and it is proportional. The pressure versus time.
Yes, sir.
A high pressure for a prolonged period will definitely cause problems.
Yes, sir.
Okay, that's a good case discussion, because this was spuriously, you never realized that the pressure was high and still went ahead. I agree with you. Right, thank you.
Thank you, sir. That concludes our session.
Yeah.
I thank our judges and presenters for sharing their time and knowledge. Thank you, sir.
Thank you, Dr. Periyaswamy. Thank you, everyone, for a wonderful session. Thanks a lot.
Thank you. Thank you. Next session will be taken over by Dr. Malini.
Thank you.
Thank you, Dr. Balaji. Good evening to all. I welcome you all to the second session of ISA PG Conclave 2020. It's my privilege to invite our esteemed judges for the session, Dr. Vasudevan sir, Professor, Head of the Department of Anesthesiology and Critical Care, JIPMER, Pondicherry, and Dr. Brinda ma'am, Professor and Head of the Department of Anesthesiology, Kribananda Variyar Medical College and Hospital, Salem. Welcome, sir. Welcome, ma'am. Am I audible?
Yes, thank you, Dr. Malini, for the kind introduction. We can start the session.
Yes, sir. Yes, sir. Yes, sir. Please play the first 5 participants' video. First one is Dr. Krishna Aravind.
Good morning. My case is obstructive sleep apnea complicating the management of a case of dengue-associated ARDS in ICU. Obstructive sleep apnea is common in patients admitted to ICU, but OSA is not studied in detail in ICU setup. Most of the articles published in PubMed are related to complications surrounding surgery, anesthesia, and postoperative period. As per our knowledge, this is the first case of OSA complicating ARDS in ICU settings. We present a case of 65-year-old female presenting to our casualty with high-grade fever and vomiting. She had a history of hypertension and on medication. She was examined and diagnosed as suffering from dengue fever with positive test of IgM antibody. On the second day of admission, patient became tachypneic and desaturated even with supplemental oxygen through Hudson mask. On examination, bilateral clefts were present and ABG showed pH of 7.3 and increased PaCO2 levels. Later diagnosed as early ARDS associated with dengue. Patient was initially given a NIV trial, but it failed and she was intubated and put on mechanical ventilation. She was sedated by midazolam infusion. She was treated symptomatically and recovered well. She was extubated on the 5th day of admission after successfully achieving weaning criteria. But post-extubation, ABG report showed an incremental increase in PaCO2, so the patient was kept on NIV in spontaneous mode with pressure support of 10 centimeters of H2O and PEEP of 6 centimeters of H2O. On the 6th day, NIV was removed during the evening. On patient's request due to discomfort, ABG done after an hour showed severe acidosis, high PaCO2 values, and the attending physician did bicarbonate correction. From 6th day onwards, there were multiple episodes of ABG showing fluctuating PaCO2 levels. After taking detailed history from the family, we gathered the history was fitting into a stop bank questionnaire of OSA. We documented the history and advised the attending physician not to do bicarbonate correction. We observed that the raise of PaCO2 was exactly coinciding with the patient's sleep for approximately 1 hour. We want to highlight that the patient was being documented with a severe acidosis, high PaCO2 levels, as well as low bicarbonate levels immediately after going to sleep. After an initial attempt at bicarbonate correction, we quickly suspected undiagnosed OSA in this patient, and use of questionnaire-based history helped us to arrive at a provisional diagnosis. The gold standard for confirming OSA still remains polysomnography, but in an ICU setup, it is not always easy to get a polysomnography study done to conclude at a concrete diagnosis, especially in patients who have recently been weaned from a mechanical ventilation. In such cases, episodes of desaturation and high PaCO2 retention will always favor a diagnosis of premature extubation and hence end up in reintubating and reinstituting mechanical intubation, which will definitely complicate and prolong ICU stay. An intensivist should keep a strong suspicion of OSA in such clinical pictures. Apart from widely accepted stop bank questionnaire, there were few other modalities for screening for OSA. As per the study of Chang et al., overnight oximetry can be used as screening tool for diagnosing OSA in more objective manner. Our patient was successfully managed and discharged from ICU with adequate counseling to patient and family and sent home with a CPAP support. With this case report, we want to emphasize that the OSA can be very tricky in ICU settings, and the intensivist has to keep this as a differential diagnosis. Polysomnography cannot be done in most of the patients in ICU, hence adequate awareness and use of screening method of OSA need to be used to successfully manage such patients. Thank you.
Okay. Next, Dr. Penmatsa Swati.
Good morning. This is a delayed death following injection of lethal dose of paraquat. Coming to the introduction, paraquat is a herbicide, one of the most lethal agents used for self-inflicting injuries like suicide. It causes multi-organ dysfunction, especially lungs are main target organs. Coming to the case report, a 26-year-old female with alleged history of consumption of unknown quantity of poison mixed with soft drink, she became unconscious and relatives rushed her to nearby tertiary hospital within 3 hours of consumption. Due to unavailability of the sample bottle of the poison at the time of presentation, gastric lavage was done, and later it was found to be approximately 100 ml of 24% paraquat dichloride, which is 24 grams, and treated symptomatically for 20 days. Patient's condition improved, but later patient developed acute breathlessness with palpitations and gradually became drowsy. Then patient was referred to our hospital. On arrival, patient was in altered sensorium and labored breathing with hypotension, tachycardia. The saturation is around 85% with 10 liters of oxygen. And investigation showed severe metabolic acidosis, raised serum creatinine and blood urea levels, and electrolytes hyperkalemia, and LFT all enzymes are elevated. The patient was intubated and kept on mechanical ventilator with assisted control pressure control ventilation with FiO2 of 80%. Patient maintained saturation of about 92% and was started on injection methylprednisolone, injection vitamin C, and ceftriaxone, calcium gluconate, and N-acetylcysteine and IV fluids for maintenance. Chest X-ray showed ARDS with pleural effusion. ECG showed sinus tachycardia with occasional premature ventricular complexes. One session of emergency hemodialysis was done with 1 unit of PRBC transfusion. Post-dialysis creatinine levels came down and ABG was also improved. Patient status was same till day 2 afternoon. In the evening, patient developed sudden cardiac arrest, and despite of all resuscitative measures, patient couldn't be revived. Coming to the discussion part, self-poisoning with pesticides account for 14 to 20% of global suicides, of which paraquat has high case fatality rate of about more than 50%. Overall survival post-paraquat consumption ranged between 10 hours to 25 days. Lethal dose is around 30 to 50 mg per kg. Within 12 to 24 hours, 90% is absorbed and rapidly eliminated in urine as unchanged form. Measuring the plasma paraquat concentrations and urine diethionate level is useful in both confirming the poison and predicting the prognosis. In our case, the patient seems like improving clinically initially. She deteriorated with multi-organ involvement after a while with elevated parameters. Elimination methods such as hemodialysis and hemoperfusion are unlikely to change the outcome, but early hemoperfusion may improve survivability. Antioxidants might be beneficial through free radical scavenging, and in acute paraquat poisoning, omega-3 fish oil emulsion is advantageous in attenuating the inflammatory process. Coming to the conclusion, no specific anterior or multi-system involvement makes it highly lethal and needs close follow-up for longer periods. Thank you.
Dr. Swati Sri.
Good afternoon, respected professors. This is Dr. G. Swati, second year postgraduate from Siddhartha Medical College, giving a case presentation on impalement injury of the lower abdomen and pelvis. We report a case of 45 years old female sustaining a penetrating injury of the lower abdomen and pelvis with a metallic rod after a road traffic accident. Our role in the emergency room. As soon as the patient presented in the casualty, her general condition and vitals were noted. She was in severe pain and was in hypovolemic shock, bleeding profusely from the entry and the exit wound. Though it sounds very simple, but the most important step here was to secure IV access and to start IV fluids. In my case, ringer lactate was available, so we started with ringer lactate. For analgesia, injection fentanyl and injection tramadol was given. Meanwhile, complete physical examination was done so as to rule injury to the other body parts, and routine blood investigations were all sent. To know and to control the source of bleeding, patient was shifted to the OT for exploratory laparotomy. Our role in the theater. Shifting and positioning the case was a difficult task because disturbing the rod might lead to further damage to the internal organs. Patient was intubated and maintained in deeper planes. Vigilant monitoring of the inhalational agent was done so as not to exacerbate hypotension. Surgery began, and intraoperatively we found that the foreign body had hit the posterior iliac arteries, injured the bladder, and had cut the left ureter. For the whole surgery to take place, it took nearly 6 hours with more than 2 liters of blood loss. Intraoperatively, we had to face certain complications, primarily hemodynamic instability. Here, our aim was to maintain a minimum systolic blood pressure of 80 mm of mercury. So the patient was resuscitated with nearly 1 liter of crystalloids, 1 liter of colloids, 2 units of packed RBCs, 2 units of FFPs, and 2 units of platelets without any use of inotropic drugs. Next was to prevent hypothermia. So the fluids which were given to the patient and the fluids used for irrigation were all pre-warmed. HME filters were used. Patient was completely covered throughout the surgery, and the theater temperature was kept close to the room temperature. As the patient had massive transfusions intraoperatively, ABG and coagulation profile was sent, which were all within normal limit. Then the patient was kept on elective ventilation for the next 12 hours and later extubated. At the end, I would like to conclude that the main key in managing a trauma case will be, number one, appropriate resuscitative care, that is, administering fluids without increasing blood pressure and administering anesthesia without exacerbating hypotension, and all this without disturbing the hemostasis of the body. Number two will be prompt diagnosis. And finally, immediate surgical intervention by a multidisciplinary team. Thank you.
Dr. Vyas.
Good afternoon, this is Vyas, second year postgraduate of Siddhartha Medical College, presenting a poster of ICU management of COVID-19 patient with intravenous fetal prednisolone pulse. Co-authors are Dr. T. Sureshri and Dr. I. Kiran. Introduction. The solitary trial published interim results on 15th October 2020 found that all treatments including remdesivir, hydroxychloroquine, lopinavir, ritonavir, interferon had little or no effect on overall mortality, initiation of ventilation, duration of hospital stay. So far, only corticosteroids have been proven effective against critical and severe COVID-19 cases. Case report: a 40-year-old female patient was brought to Government General Hospital, Vijayawada, casualty presenting with cup low-grade fever. Baseline vitals are blood pressure 120 by 70, pulse rate of 79 beats per minute, respiratory rate of 22 breaths per minute, and saturation of 94% on women. No significant past medical history was given. Patient denied the history of smoking and drug abuse. Nasal swab was positive. The following day, patient developed shortness of breath after shifted to ICU. Vitals are blood pressure 130/70, pulse rate of 90 beats per minute, saturation of 78%, respiratory rate of 28 beats per minute, and GCS of 15 out of 50. On O2 support of 15 liters per minute through non-rebreathing mask, SpO2 was 88 to 90%. ABG showed low PaO2 levels. Equivalent investigation was 7. CRP levels of the patient is 30 milligram per deciliter. Chest X-ray showed bilateral lower lobe pneumonia. CT demonstrated bilateral lower lobe volume loss with ground glass opacity. Corat specified severity score of 20 out of 25. Support to treatment was started, which included antibiotics, antiviral, anticoagulant, and multivitamin, along with intravenous methylprednisolone of 250 mg pulse therapy once a day for 3 days given. Awake proning was advised to the patient on day 5. Saturation was 92% with per liters of water to non-rebreathing mask. ABG showed improved PaO2 level. Conclusion: intravenous methylprednisolone pulse therapy administration at early pulmonary phase of illness improved remarkable O2 saturation and decreased use of mechanical ventilation. Keywords are methylprednisolone pulse therapy and early pulmonary phase. This is the chest X-ray of patient showing bilateral lower lobe pneumonia, and this is the CT of the patient showing ground glass opacities in lower zones and electric zones. The patient, after given intravenous methylprednisolone, is advised for proning. As early pulmonary phase at which we will give IV methylprednisolone pulse therapy. Thank you.
Dr. Rachana. Hello.
Yes.
Yes, Dr. Rachana.
Yeah.
Please play the video of Dr. Rachana. Technical team.
Good evening. Today I'm going to present a case report on lithium toxicity due to attempted suicide drug overdose. Lithium is used to treat bipolar disorder as a mood stabilizer. Having a narrow therapeutic index, it has a potential for the toxicity. A 20-year-old female presented to our ED with multiple episodes of vomiting, irritability. 6 hours after ingestion of 16 tablets of lithium. She was on lithium 400 mg for mania depressive psychosis for 1 year. On examination, patient vitals were stable. She was conscious, irritable with impaired judgment. She had tremors and she was not able to stand without support. Gastric lavage was done and isotonic saline was started. The initial blood levels of lithium was found to be 3.7. Hemogram revealed TLC of 12,000. Platelet count, serum electrolytes, and ABG was normal. Patient had one episode of seizure on day 2, which was managed by injection lorazepam 4 mg. So dialysis was started because of a grade 3 neurotoxicity. Patient received 2 cycles of dialysis with a daily intake of 3 liters of IV normal saline and daily monitoring of serum lithium. She responded to the above on the day 4. The serum lithium levels dropped to 1. A complete psychiatric evaluation was obtained and patient was discharged once she was stabilized. Serum lithium levels varies from 0.8 to 1.2. Toxicity occurs if the is more than 1.5. Patient present with a multisystemic involvement with CNS is predominantly involved. The relation between the serum lithium levels and the neurotoxicity depends upon the type of the poisoning. In acute poison, there may be little or no neurological symptoms initially despite of high serum concentration levels because of the delayed diffusion of lithium into the brain. In chronic poisoning, the symptoms are in a linear correlation with the serum concentration. In acute and chronic toxicity, symptoms occur rapidly with the serum concentration of 3.4. Neurological symptoms are the most common. A CNS compartment already contains lithium. A small amount of lithium is required to distribute to that space to cause neurotoxicity. Our patient clearly falls into grade 3 severity. The principal management of the toxicity is to stabilize the airway, breathing, and circulation, followed by seizing factors promoting increase in the poison concentration in the body and promoting its excretion. The renal excretion can be promoted by administration of IV 0.9 NS, which increases sodium load, which decreases the lithium reabsorption in the proximal tubules. Whole bowel irrigation or gastric lavage with the PEG solution can reduce absorption. Method of rapid
Is the presentation going on? It looks like
No,
it's
sir.
stuck.
Yes, sir, it's struck, sir. I think her network is not okay. Shall we move on to the discussion, sir?
She finished?
No, sir. She was halfway.
No, she has to finish. No, that is not fair. Okay, just give a minute. Later join back, and then we'll on to the discussion.
Yes, sir. Yes, sir. Okay, sir. Yes. Dr. Rachana?
Can we combine our presentation with the next set of 5? We can have the 4 available now.
No, sir. We will proceed with our discussion, sir. The session is open for discussion. Let her join. She's the 5th member. Let her join the discussion, sir.
Maybe you can ask her to present in the end just a minute and
Yes,
then ask the queries. Okay,
yes, sir.
please.
Okay.
The
Yes, sir. The
first
session is
candidate,
open to discussion. Yes, sir.
Dr.
Dr.
Brinda,
Krishna
what
Arvind.
is
Yeah.
the question?
Yes, sir.
Yes, sir. Was your patient obese?
Yes, ma'am. She is obese. Her BMI is around 39.
39.
Yeah.
But you didn't suspect it earlier. Only when you got the history.
We didn't suspect it earlier. Yeah, ma'am. We didn't suspect it earlier. Even we are having patients in ICU with obese, but this is an ARDS case which was complicated, no, ma'am.
Okay.
Until now, we didn't have this complication.
Dr.
Was the airway difficult?
Yes, sir. Ma'am.
Was the airway anatomically, when you see, was it difficult?
No, ma'am. It is easy.
It was easy.
Easily intubated, but because of heaviness, it's little difficult, but not so bad.
Okay.
Dr. Arvind, why do
Yes,
you
sir.
say this is OSA complicating a patient with dengue ARDS? Is it not the other way around?
Yes, sir.
Does OSA develop all of a sudden? Does OSA develop all of a sudden? Is it an acute condition?
No, sir. It's not
Is
an
it
acute.
not a
She might be having
chronic
OSA from.
condition? A patient who is prone to OSA happen to develop dengue ARDS, correct?
Yes, sir.
Okay. Why do you say this is because of hypercarbia? Is because of OSA and not just hypoventilation?
Hypocarbia, sir. Hypercarbia is because of.
What was the criteria of your diagnosis of OSA in this patient?
I didn't get you, sir.
How did you diagnose OSA in this patient?
Oh, by only questionnaire, sir.
Sorry?
Banks questionnaire we diagnose, but there is multiple episodes
Okay.
of
No worries. No worries.
increased
You
hypercarbia in
said
this case.
no worries. No worries. You said you gave bicarb correction for this patient. Why was it?
Yes, sir. There is a hypocarbia in this. Bicarbonate is decreased, sir. Decreased to around 9 millimoles.
So why was it? Why was bicarbonate low? Relatively low, you mean? Correct?
Maybe, sir. Maybe
The
because of
bicarb was relatively
hypoglycemia.
low. You expect a higher bicarb, right? If it is a chronic condition.
No. Yes, sir. Yes, sir.
What was the cause for that low bicarb in this patient?
Maybe she until then she was intubated, no, sir. Maybe because of hypoglycemia.
Hypoglycemia. Okay. It must be some form of associated acidosis, correct?
Associated
It
acidosis
may
might
be
be
of
there.
renal origin, maybe of hypoperfusion. Was there any coexisting condition in this patient?
No, sir.
Okay, thank you.
Hypertensive, except hypertensive.
No problem. Thanks a lot. Thanks a lot. Next is Dr. Swati. Is Swati there? Lethal dose of paraquat. Is
Dr.
she
Swati?
online? Okay, Dr. Swati Shri. What happened to the candidates? Are they disappeared?
Is there, sir?
Dr. Arvind, you can disable your video. We can save some bandwidth. People who are not presenting or talking, please disable the video. Some of them are not able to get a good bandwidth. Is Swati or Swati Sri available? Okay, is Dr. Vyas available? There is some type of problem. Dr. Malini?
Yes, sir.
Yeah, what happened?
Yeah, I'm just checking, sir.
Okay.
Dr. Vyas,
Any one of them is available, you can ask.
Dr. Rachna.
Hello.
Hello.
Is it Dr.
This
Vyas?
is Vyas. Yes, sir.
Yeah. Dr. Brinda, you want to ask something?
Sir, you go ahead, sir.
Okay. Dr. Vyas, what was the indication for giving steroid in this patient? What were the criteria that were employed?
We have selected certain criteria for patients for administration of pulse therapy. Those are the age more than 18 years and CRP more than 30 and interleukin 6 more than 6. And
Okay. Why did you choose methylprednisolone and not other steroids like dexamethasone? Is there any specific reason?
Methylprednisolone is taking of little mineralocorticoid action, and there are no specific treatment protocols. And
What's the reason you're using steroids in COVID patients? What is the action you desire?
Immunosuppressive action.
So why do you need a mineralocorticoid activity for that? How does it really matter? Dexamethasone is much cheaper.
It's more of a glucocorticoid action. 5 to 6 times of potential.
That's why my question is, when other steroids can provide similar activity, why are you choosing a drug which is more expensive? Is there anything specific that is peculiar about this drug?
No, we usually use a pulse therapy while with methylprednisolone only, mostly for patients.
For what type of patients?
Autoimmune diseases, we use a methylprednisolone.
Okay, you are used to methylprednisolone in non-COVID patients. Is that what you're saying routinely? Okay, yes. Thanks. Is anyone available?
Swati Sri.
Good evening, sir.
Is it Swati Sri?
Yes, sir.
Okay. So your patient, while presenting, was in hypolimic shock?
Yes, sir. When she presented to the casualty,
what was the grade? What was the grade of shock?
2nd degree, sir.
What was the basis of that diagnosis?
She was
what were the symptoms, signs?
She was actively bleeding, sir. She was tachypneic, and she had a BP of 70 by 60, sir. 70 by 50.
No, but that is not sufficient, isn't it? There are more parameters and factors you have to take into account before grading. Okay, class 2, what percentage of blood loss you expect?
40 to 40%.
Oh dear. No wrong. Did you employ invasive monitoring?
No, sir, I didn't.
Because in this patient, we don't know what's going to happen when they remove the foreign body. It's injured a major artery. Is it not important to secure an artery line as early as possible so that you can have more reliable blood pressure monitoring? Probably that should have been done. Is there any reason why you didn't do? Was it availability or any other problem?
The case presented in the late night, sir, so we didn't had access to our...
Come on, you're an anesthetist. You in sleep should be able to put artery in. Okay. That should be done at the earliest opportunity. Secure artery line, because when the vasoconstriction sets in later, if it is not already there, your NABP isn't going to be reliable at all. Okay. Madam, Dr. Brinda, you want to ask something?
What is the difference in this penetrating injury and perforating injury? Is there any?
Perforating injury, they perforate the hollow viscous organs, ma'am.
No, this one also is perforating the hollow viscous, no? So anything which has an exit wound, that is a perforating. One which just goes in is a penetrating.
Okay, Dr. Swati, thanks. We'll move on to the next candidate.
Dr. Penmatsa Swati.
Yes, ma'am.
Yeah.
Swati?
Yes,
Is
sir.
it Swati who presented the case on lethal dose of paraquat?
Yes, sir.
Paraquat is an insecticide. The incidence of insecticide poisoning is very common in our country. What is peculiar about your presentation? Why did you present this?
Actually, there are less reports regarding the follow-up of the case.
Can you please speak up loudly?
Actually, these cases on long-term follow-up, there is increased mortality rate in these cases, sir. Usually on long-term, like 30 days mortality rate and 60
What
days
is the
mortality.
mechanism?
This is
What is
pre-radical
the
injury.
mechanism of toxicity of paraquat?
Pre-radical injury is the main mechanism of the toxicity of this patient. Of this pre-radical injury.
Does it not have any other action, toxicity, other than free radical injury?
Like free radical injury, mitochondrial toxicity, lipid peroxidation, and
What type of chemical is paraquat?
it's a herbicide, sir.
Okay.
Dipyridinium compound.
Okay. Okay, Dr. Swati. Madam?
What is the cause of death usually due to?
Mostly, primarily it is kidney injury, ma'am, and lungs, and lungs are also mainly targeted, and one of the cause. Mainly kidney and lungs are mainly affected, and main cause of the death in these patients.
Lung is more than the kidney. The lung fibrosis occurs.
Yes, ma'am. Lung fibrosis.
Okay.
Dr. Rachana?
Yes, ma'am.
Dr. Rachana, we missed your presentation, the later part. So, the last part, can you just quickly present again? Is it available? Okay, no worries, no worries. So, this is lithium toxicity, isn't it?
Yes, sir.
So, what is the cellular mechanism of lithium toxicity? What happens at the cell level?
Sir, usually in lithium, usually it inhibits the release of the monoamines, sir, and it at the nerve endings. And
Does it compete
releases
with any other cation? Is lithium cation or
sodium.
anion? Sodium. Okay. Does it have any impact on the toxicity?
Lithium, sir. Sorry, I didn't get your question, sir.
Okay. Okay. Lithium is a metal, right? Technically.
Sir?
Lithium is classified as a metal, right, in periodic table?
Yes, sir.
So why are we not using chelators here? Is there any reason?
No idea, sir.
Is it just a metal or heavy metal?
Lithium
what is the atomic weight? Come on, man. You should know everything about lithium. You get to the root. If any new poisoning happens, how do you find the solution? You get to the root of the action. How does it act? Everything you should know. Okay. Madam?
Nothing, sir.
Okay. Thank you. That's
Thank
it
you,
on this session?
Yes, sir. Yes, sir.
Okay.
5 candidates over, sir. We will move on to the next session, sir. Please play the set of videos. Dr. Sanmati. You're not audible, doctor. Dr.
Please
Sanmati.
enable your microphone, Dr. Sanmati.
Sensitively non-depolarizing muscle relaxants. The case report, a 45-year-old female who is a case of neck rabies of Cosaman type 3, came with history of dysphagia, weakness on exertion, and drooping of eyelids with past history of hypertension. On examination, she had roses and grade 3 power in all her 4 limbs. She was on pyridostigmine, prednisolone, and amlodipine. Her airway examination revealed a malambity of grade 2. Her weight is 54 kg. The routine pre-op investigations were normal, and anticholinergic antibody titer showed 5.2 nanomole per liter. CT neck and thorax revealed thymoma of this size. She was posted for transternal thymectomy and advised to continue her routine medications till the day of surgery. Monitors connected, IV line secured, and thoracic epidural was secured with catheter tip at T5 level. Under local anesthesia, artery line and center line were placed. She was pre-medicated with the injection glycopyrrolate 0.2 mg, midazolam 1 mg, and fentanyl 100 mg. Started induction with thiopentin 250 mg and atracurium 20 mg in titrated doses with off monitoring and intubated with 7.5 mm in tube. Anesthesia was maintained with oxygen, nitrous oxide, sevoflurane with 1.2 to 2 mg. Surgery was performed in supine position.
I think we lost her.
Yes, sir.
Is she still on? Is Sanmati still online? We can't hear you.
Dr. Sanmati? Yes, sir. We will move on to the next presentation, sir. Let her come back for the discussion. Yeah, yes.
Okay, please go ahead. Go ahead.
Let her come for the discussion, sir.
Sure,
Dr. Imaya Tensing. Imaya Tensing?
One second. Dr. Brinda. Dr. Himaya is my candidate. Dr. Himaya is my student. So I will ask her many questions.
Okay.
Tell me whatever scores you are putting, I will copy and put it.
Okay.
Or I will leave it empty. Dr. Malini, did you hear me?
Yes, sir. Yes, sir. Yes,
Dr.
sir.
Himaya is my student, so I can't put marks for her. So you have to multiply
Yes, sir. Yes,
Dr. Brinda's this thing.
okay. Yes, sir.
Okay, go ahead.
Play the video, please.
Cardiac surgery in hypothermia and cardiopulmonary bypass. So cold agglutinin disease is essentially characterized by autoantibodies, IgM class against their own RBCs. So they're typically activated between 20 degrees Celsius to 31 degrees Celsius. So here we're going to report a case of 52-year-old female. She's a known case of rheumatic heart disease with severe MS, MR, and PR. She had underwent balloon mitral valvulotomy 10 years ago. She has been on cardiac medication ever since. She had defaulted on her medications for 3 months and she presented to the OPD with failure symptoms. So investigations were showing HP dropped from 12 to 8 and total leukocyte counts were doubled. So this was suggestive of active infection going on, which could have triggered, retrospectively thinking, this could have triggered the cold agglutinin disease. And blood urea, creatinine were also elevated and LFTs were also elevated. This was also suggestive of active hemolysis going on. And coagulopathy was within normal limits and ECG was showing atrial fibrillation and echo was showing severe MS and MR with mitral valve orifice of 0.8 centimeters square and RVSP of 60. So in view of worsening cardiopulmonary status and class 4 NIHA dyspnea, patient was posted for emergency mitral valve replacement and tricuspid valve repair. Intraoperative period, induction was uneven full and invasive arterial line and central venous lines were secured and trachea intubated. Median sternotomy was done after systemic heparinization. The ACT was targeted about 480 seconds and cannulation of aorta and IVC feces were done. When cooling was started below 30 degrees Celsius, we noticed clots and clumps in the cardiopulmonary bypass circuit, cannulas and tubings. So we had a high index of suspicion for cold agglutinin disease and we ordered an emergency immunohematological workup. So it was showing the presence of telltale presence of IgM autoantibodies which are characteristic for cold agglutinin disease. In order to support this, we also have direct Kuhn test positive and anti-complement antibodies were positive. EDTA samples were showing autoagglutination and clotted samples were showing hemolysis. So the hemolysis as well as autoagglutination were suggestive of cold agglutinin disease and we have confirmatory diagnosis made by the IgM autoantibodies presence. So this cold agglutinin disease has to be reversed by warming the patient. So warming was immediately started. Simultaneously, the surgical repair was also concluded. This warming will reverse the autoagglutination. And moreover, to wash out all the microemboli, we have to give warm cardioplegia in the anterograde as well as the retrograde manner, which was subsequently done and patient was successfully weaned off. And sternotomy was closed. After that, patient was having severe hypertension and PE probe was showing severe RV dysfunction. So after that, we again opened it and we placed the patient on a normothermic CTP because this time we know that patient is having cold agglutinin disease. So after redo tricuspid valve repair, patient was weaned off successfully and shifted to CT-based ICU. So the challenges faced here being the IgM auto antibodies, we have to always have a high index of suspicion because whenever we see clumps or clots in the CPP pulmonary bypass circuits, in spite of adequate heparinization, we should always have a high index of suspicion for cold agglutinin disease. So on top of that, preoperatively, if diagnosed, we can go for plasmapheresis, IVIG antibodies. So you have to avoid always cold hypothermia, and as well as we have to go for normothermic CPVs, anterograde and retrograde cardioplegia, and to wash out the microembolia and calm cardioplegia should be given. Thank you.
Next, Nazreen Shiralia.
Good morning, everyone. Myself, Dr. Shiralia, postgraduate at Institute of Anesthesiology, Madurai. I am going to discuss the anesthetic management of a case of myasthenia gravis post-operative tenosynovitis. Myasthenia gravis is an autoimmune or congenital neuromuscular disease, has many implications for the safe administration of anesthesia, particularly in respect to the use of muscle relaxants. Here we describe the anesthetic management of a myasthenia patient avoiding muscle relaxants. Our patient, 40 years male, diagnosed to have myasthenia gravis with typical clinical features and serology. The patient was initially having Osman classification score 3 and symptomatically improving after medical management. CT chest showed mass in the anterior mediastinum, no selective thymoma. The transsternal thymectomy was planned. After careful preoperative evaluation, the patient was planned for inhalational anesthesia with sevoflurane combined with thoracic epidural anesthesia for thymectomy. After securing IV lines under sterile precautions, thoracic epidural catheterization was done at T78 phase and tip kept at T4. Test dose was given. After attaching the standard monitors, the patient was pre-oxygenated. After adequate remedication and stress attenuation, the patient was induced with sevoflurane 2 to 8% and intubation was done without any difficulty. The patient was maintained with 50% mixture of oxygen and nitrous oxide and sevoflurane 0.8 to 2.5% and maintained at spontaneous or assisted ventilation. Soon after induction, epidural bolus of 12 ml of 0.25% bupivacaine along with 3 mg morphine was given. The patient received 8 ml of 0.25% bupivacaine via epidural catheter for the second hour and 6 ml of 0.25% bupivacaine for subsequent hours. The patient was hemodynamically stable during intubation, sternotomy, and during surgical procedure, which lasted for 5 hours. This score was maintained between 40 to 45. At the end of procedure, the surgeons have planned for elective tracheostomy as they have encountered sudden respiratory failure in many myasthenic patients after thymectomy. Post-operatively in the ICU, the patient was hemodynamically stable without any subjective or objective impairment of respiratory function. The patient was in coma. Analgesia was maintained with thoracic epidural post-operatively. Myasthenia patients are sensitive to the effect of muscle relaxants, and it is difficult to determine the optimal dose of muscle relaxants required. Hence, the above-mentioned method suppressed hormonal and metabolic response to pain, allowing stable hemodynamics during surgery and good post-operative analgesia without compromising pulmonary function. We conclude the above method is better alternative for thymectomy for myasthenia gravis patients. Thank you.
Dr. Hema.
We are getting dropped out.
Yes, sir.
It's in red and yellow.
Dr. Hema.
It just got disconnected. Others probably will take this. Please speak up loudly, please.
A 14-year-old boy with complaints of vomiting and abdominal.
Dr. Hema, you have to speak a little louder.
Have acute appendicitis with seal perforation. Underwent emergency appendicectomy under general anesthesia. During induction, he vomited and aspirated, but the surgery was proceeded. During post-extubation, he desaturated and was re-intubated. He was on ventilator for 24 hours. The next day, the ABD showed severe respiratory acidosis, persistent hypoxia, PYF of less than 100, PaCO2 of 80 millimeters of mercury, and Murray score of 3.5.
Hello. Hello, sir. Is this audible video?
No, not
No,
audible.
ma'am. Ma'am, so we'll catch it in the discussion, ma'am. We'll move on to the next video.
Okay, okay then.
Is it fine now? Okay.
Dr. Deepshika.
She candidate. I think she'll be best.
It's already recorded. Vocalic hernias are post-viral congenital diaphragmatic defects usually presenting in neonates and young children. They are rare in adults. A 70-year-old diabetic and hypertensive male came with a compressive type of chest pain and a worsening grade of dyspnea. So he had his preoperative vitals were normal. Auscultation showed systolic murmur over the aortic area and decreased breath sounds over the left thorax. Visual left ventricular hypertrophy, but 2D echo revealed a severe aortic stenosis of 0.8 centimeters by valve. The peak gradient of 79 and gradient of 46 millimeters of mercury. Ejection fraction was normal and there was no regional wall motion abnormality. Chest X-ray showed airfill bubble loops in left hemithorax and CD thorax. It correlated to a left postural diaphragmatic hernial defect size of 10 centimeters containing fundus, proximal body of stomach, splenic flexure, and part of spleen in the thoracic cavity, the passive atelectasis of the left lower lobe. So for this management, a transcendental approach to the pre-cardiopulmonary bypass repair of Boctalic hernia, followed by aortic valve repair on bypass was planned. We planned a one-lung ventilation for this patient. A severe aortic stenosis goals were to maintain normal heart rate. A main concern in one-lung ventilation is hypoxia. Hypoxia can cause sympathetic stimulation and tachycardia. So this will lead to decrease in the diastolic perfusion time index and decrease in coronary perfusion and increased risk of myocardial and cerebral ischemia. Normal sinus rhythm to be maintained. Hypercarbia can increase the risk of arrhythmias. Hypoxic pulmonary vasoconstriction can increase the pulmonary vascular resistance and decrease the venous return, which can affect the left ventricular preload. And systemic vascular resistance can be affected in response to hypoxic the contractility. Adequate depth of anesthesia to be maintained with the MAC of 1 and this less than 40. Adequate analgesia with injection fentanyl. Tachycardia has to be controlled with regard to this. Frequent blood gas monitoring for early detection intervention to manage hypoxia and hypercarbia. So apart from standard ASA monitors, invasive blood pressure, bispectral index, and arterial blood gases monitoring were done. Post-induction, a double lumen tube 39 French Melling clot left side bronchocath was inserted. So during surgery, once the midline stenotomy was done, left pleura was open and adhesions were released, and the hernial sac structure was identified, and during which there was a hypotension which was managed with IV fluids, phenylephrine boluses, and reduction of rotation. Left lung was isolated during reduction. After defect was closed with mesh, patient was taken on bypass, aortic valve was replaced, and later the patient was weaned off bypass and shifted to ICU. So with coexisting severe aortic stenosis in Boctalic hernia, severe aortic stenosis considered priority. But when there are strangulated bowel loops, hernia needs urgent intervention. Because of underlying lung collapse, increased chance of bowel strangulation for better postoperative ventilator management, a simultaneous repair was planned. Thoracotomy approach better facilitates the release of adhesions between the hernial sac and thoracic structures. Initiation of bypass and reduction of contents can cause hemopuritium and hemothorax. Transcendental approach before bypass initiation can cause hemodynamic disturbances, as I mentioned. Hypoxia and hypercarbia were monitored with blood gases. So to conclude, posterior Boctalic hernia and valve involvement is rare in adults. So when a simultaneous repair is planned, general anesthesia with one lung ventilation is favorable for a transcendental approach to defect closure, followed by aortic valve replacement on bypass. So anesthesiologist should be aware of the concerns and goals for appropriate management. Hello. Hello.
Okay.
The session is open for discussions.
Okay, who is available?
Dr. Sanmati.
Good evening, sir. Good evening, madam.
Dr. Sanmati.
Yes, sir.
Your patient was on pidostigmine, right?
Yes, sir.
Did the patient receive pidostigmine on the morning of surgery?
Yes, sir. She continued the routine medication with 60 mg, sir.
Okay. And when was the next dose administered? During surgery or after surgery?
Intraoperatively, not, sir.
Not
after extubation only, yes, sir.
Okay. You said you had used TOF monitoring.
Yes, sir.
You probably meant a neuromuscular transmission monitoring, correct? TOF is a mode of neuromuscular monitoring, right? So what is the difference between trainer 4 and double burst stimulation? Why would you choose trainer 4 in this patient and not double burst stimulation? This for Sanmati.
Yes, sir.
Okay, no worries, no worries. Next, we'll move on to next candidate, Emia.
Okay.
Emia will ask questions but not score the marks. Only madam will score the marks. Okay. Emia, are you there?
Yes, sir. Yes, sir. I'm here, sir.
What is the incidence of cold agglutinin disease?
So the incidence in India, it ranges from 1 to 2 million per million cases, sir.
It's a
1
rare
to 2
disorder,
cases
right?
per million
It's a rare
population.
disorder.
Yes, sir. That
So
is.
when you see
Yes,
clots
sir.
in the circuit, what is the first thing you suspect?
Inadequate heparinization, sir. So
So how
usually
did
we
you rule
tend
that
to.
out?
Sir, we gave a initial heparin dose of 400 units per kg, sir, and we had an activated clotting time,
The reason
which
I'm
was more than
asking,
480, sir. Hello, sir. Hello, sir.
Hello, sir.
Sir, the activated clotting time was targeted above 480, sir, and it was above that, sir. So we were sure that it was not due to inadequate heparinization, sir. Am I audible, sir? Hello?
Imaya? Imaya?
Yes, ma'am. Yes, ma'am.
Supposing your
Yes, ma'am.
supposing this was not due to cold agglutination antibodies, and suppose you find clots in the bypass during bypass, how will you manage?
First,
was slow. Your ACT was low.
ACT was low. It means that the heparin which we gave was not adequate, ma'am. So
Yes.
we give extra doses of heparin and to target it above 480 seconds, ma'am.
That's okay, but clots are already starting to form. So how will you manage?
I'll wash this. I'll wash the circuit, ma'am. I'll get rid of all the clots, and I'll also run a anterograde cardioplegia as well as the retrograde cardioplegia to wash out all the emboli which might be present in the coronary artery circulation, ma'am. So I will wash out the tubings, extracorporeal tubings as well as the patient's coronary arteries. I'll run a cardioplegic solution, ma'am. Wash out all
You
the
have
clots.
to change the whole setup. It is a nightmare only.
Yes, ma'am. Yes, ma'am.
who is the next candidate? Nasreen? Thank you, Mia. Nasreen is available? What about Hima?
Yes. Hello, sir.
Is it Nasreen or Hima?
Hima, sir.
Okay. People who are not talking, please disable your video. Hima, you did echo for aspiration pneumonitis, correct? ECMO, sorry.
Yes.
What was the dose of heparin used? You mentioned more than 35 units per kg per hour. But what's the actual dose used? More than 35 has a huge range.
Sir, yes, sir. Initially, we used 10 to 20 units per kg per hour, but the ACT and APTT levels were not maintaining. So we increased, and there was
So what
visible
I'm
clots in the
pointing to
oxygenator.
is probably you should have mentioned the range of doses you had used throughout the course. It had been for 25 days, right?
No, sir. He was in ECMO for 7 days only.
7 days. Okay.
Okay, sir.
So just mentioning only as more than 35 units doesn't convey the full picture. How many oxygenators are used in that 1 week?
Sir, 2 oxygenator. In the day 2 itself, there was visible clots in the oxygenator. So we removed that oxygenator with a 30 seconds pause in ECMO.
Is there any other? Do you replace oxygenator only when you see clots, or there are other parameters you can look at, and that will help us to decide when to change oxygenator?
Sir, delta P value was around 100. So we suspected clots, and it may be due to heparin resistance, and we suspected antithrombin 3 resistance. It came out the value of antithrombin 3 came out.
What type of pump was used?
Sir,
what is the type of pump?
cardio help ECMO, sir.
Mechanism action. I mean, not the brand name.
Sir, VV ECMO, sir. Venovenous ECMO. For
Okay.
aspiration
No,
pneumonitis,
the
sir.
ECMO pump works by different methods, different physical principles. I know
Sir,
only one method is commonly used. I just want to hear from you.
Sir, I didn't get you, sir.
What are the different types of cardiopulmonary bypass pumps?
Sir,
They employ different technologies, correct?
Sir, roller pump and centrifugal pumps.
Okay, fine. That's what I want to hear. Thank you.
Okay, sir.
Madam? Sorry. Madam, you want to ask anything?
Nothing, sir.
Okay. Next, Deepshika.
Yes, sir. Evening, sir.
Okay. So, this patient, did the patient have any symptoms of buccal hernia?
He had intermittent epigastric pain, sir. That
Okay.
was the only
Was
symptom.
it not diagnosed prior?
No, sir. Actually, when we took a CT chest X-ray, it showed bowel loops in the left hemithorax, sir.
Fine,
Then we
fine, fine.
went ahead.
See, you have a disease which is coexisting, which didn't cause much trouble to the patient.
Yes,
On the
sir.
other hand, you have severe aortic stenosis for which you're doing repair.
Yes, sir.
Would it not be prudent to do the hernia surgery later? Is there any reason why it had to be done immediately?
Yes, sir, because the sac orifice was small, so it was very narrow. So there was a risk of strangulation, sir. So then we proceeded with both hernial repair first, pre-bypass, and then we took the patient on bypass and we went ahead with aortic valve replacement, sir. So the only issue here was why we went with hernial defect repair first was if we take it after bypass and then after heparinization, then there is a risk of hemothorax and hemoperitoneum, sir.
Okay, madam.
But there was a hemoglobin drop also, you said, no?
No, ma'am. There was a
What was
hypotension
it?
that was present during manipulation of the thoracic contents to identify the sac of the hernial, ma'am. So that time
That
we
is
managed.
okay. Pre-op was.
No, ma'am. The
No,
hemoglobin was
was there any?
normal.
No.
Yes.
Okay. But anyway, when you open the thorax, isn't it better to do it there? Hemoperitoneum is going to be such a problem when you compare it with using a WMN tube and then doing a one lung answer when already there is severe aortic.
Yes, ma'am.
Isn't it?
So first we went ahead with one lung ventilation. We put ahead with double lumen tube. We first proceeded with hernial defect closure, followed by on bypass aortic valve replacement, ma'am. And in between, we did frequent ABGs to monitor for hypoxia and hypercarbia, and we managed the electrolyte disturbances that may occur during the surgery, ma'am. And we also managed hypotension that can occur during the manipulation of the sac while trying to identify the sac, and also while rotating the heart, we managed that with IV fluids and phenylephrine boluses.
Okay.
Okay, then we'll move on. 5 more, right?
Sir, Dr. Nasreen, sir. Dr. Nasreen.
Okay, Nasreen, we didn't ask.
Yes, sir.
Dr. Nasreen, are you there?
Yes, sir.
What is the novelty about your presentation? Myasthenic gravis surgery is not that uncommon.
Sir, I couldn't get you. Hello?
Thymectomy for myasthenia gravis is not uncommon. It's done routinely. Why is it presented as a poster?
We done the procedure. We did a transdermal thymectomy avoiding muscle relaxation, sir.
Okay. You said you used a spontaneous assisted ventilation, correct?
Yes, sir.
Was
Yes,
it
sir.
done with the hand or with any ventilator?
With manual only, sir. Hand ventilation.
Okay. Okay. When did you restart the pyrostigmine of this patient?
Sir, immediately post-operatively, it was switched to neostigmine, sir. As the patient was not started on oral, we switched to injection neostigmine. The patient was taking pyridostigmine.
Did you not place a RIDES tube for this patient?
Sir?
Did you not place a RIDES tube, nasogastric tube?
Yes, sir.
The common practice is to put a RIDES tube and give the same medication. Why would you change the medication which you have not titrated before?
Yes, sir. We placed the RIDES tube, but the immediate post-operative period.
Fine. No. What was the? Did you employ neuromuscular transmission monitoring?
Sir?
Did you employ neuromuscular transmission monitoring?
No, sir.
Is it Because of non-availability? Or
No,
it's not an
as we
expensive
didn't use
equipment?
muscle relaxant, as we avoided the non-depressing muscle relaxant, we didn't use
What
neuromuscular.
antibiotics were given to the patient?
Sir,
What antibiotics were given to the patient?
so avoiding aminoglycosides,
Okay, so
we
you're
gave
certain there is
injections.
not going to be any neuromuscular blockade. Okay, madam?
Yes.
Apart from transsternal approach, is there any other approach?
Sorry, ma'am.
For thymectomy, apart from transsternal approach, is there any other?
Other approaches. Other approaches. I couldn't get clearly, ma'am.
Is there any other approach to do thymectomy apart from sternotomy?
Your microphone is muted. Dr. Nasreen, please unmute your microphone.
Sir, BATS and trans-cervical approach, ma'am. We can do thymectomy by we can do thymectomy by trans-cervical approach or through video assisted
Fine.
Okay.
Yes.
Is this
Shall-
session over?
Yes, sir. Yes, sir. Shall we move on to the next session, sir?
Okay. Please go ahead.
Yeah. Play the video of Dr. V. Madhumati.
Good evening. I'm Dr. Madhumati, second year postgraduate from Narayana Medical College, Nellore, Andhra Pradesh. My title for the poster is Anesthetic Management of a 5-year-old child of Moyamoya disease for GAM surgery. Moyamoya disease is a progressive stenosis of the intracranial vessels with the secondary development of an anastomotic capillary network. These patients present with the ischemic strokes. 5-year-old child weighing 16 kgs has acute onset of left upper and lower limb weakness, and MRI showed the acute infarct in right middle cerebral artery territory involving the motor cortex, and digital subtraction angiography showed the moderate attenuation of the right internal carotid artery from its origin and complete obliteration of the right internal carotid artery just distal to the ophthalmic artery. She is posted for the encephaloduro-arteriomyosynoangiosis under GA. My goals of anesthesia is to avoid the hypotension or hypertension, avoid hypercarbia, maintain euvolemia, maintain the balance between the oxygen supply and the demand in the brain, maintain adequate analgesia, maintain normal thermia, and careful and smooth extubation to avoid any increase in the blood pressure. Coming to the anesthetic management, after the patient shifted to the operation theater, we connected the basic monitors and bolus ringer-actor solution was given. Patient was pre-medicated with the midazolam 0.05 mg per kg body weight and pre-oxygenated with oxygen for 3 minutes. Induction was done with the propofol 2 mg per kg body weight, analgesia with the fentanyl 2 mg per kg body weight. To avoid the stress response, Loxicod 1.5 mg per kg body weight was given. Muscle relaxant vecuronium 0.1 mg per kg body weight is given. Smooth and gentle intubation was done with 4.5 mm ET tube. Intraoperatively, we managed the case with the total intravenous anesthesia with propofol 0.1 mg per kg body weight and bolus doses with the vecuronium 0.01 mg per kg body weight. We reversed the case with the glycopyrrolate 0.01 mg per kg body weight and neostigmine 0.05 mg per kg body weight at the end of the surgery, and smoothly extubated. Postoperatively, paracetamol infusion 15 ml per kg body weight was given. Patient outcome was good. Intraoperatively, we managed the normal thermia, normovolemia, adequate depth of anesthesia. Patient was shifted to the new surgery ICU for further management. My conclusion, Moyamoya disease is a rare disease presenting for surgery and poses a great challenge to anesthesiologists in view of its multitasking and also the complicating intraoperative management. Thank you.
Good evening, myself Dr. Prajna from Kalinga Institute of Medical Sciences. My topic is autologous transfusion strategies in a patient of Bombay blood group. Autologous blood transfusion aims to decrease the incidence and severity of complications associated with allogenic transfusions. It also reduces the risk of transfusion transmissible diseases like hepatitis. It constitutes 3 distinct procedures: preoperative autologous donation, acute normovolemic hemodilution, intraoperative and postoperative blood salvage. A 75-year-old male patient came with complaints of headache and pain in the lower back since 4 to 5 months after a history of fall in the bathroom. The lower back pain was radiating to the lower limb and gradually patient was found unable to walk. No history of any chronic illness was given. On examination, patient was found to be conscious, alert, and well oriented to time, place, and person. Cranial nerve examination was normal. Skeletal muscular system examination showed a decrease in power in the right lower limb to 3 out of 5. CT scan of lumbar spine showed soft tissue thickening in pre and paravertebral region at L3 and L4 level, causing erosion of upper end plate of L4 and lower end plate of L3 vertebral bodies with bilateral psoas abscesses, which was suggestive of port spine. CT brain showed a well-defined non-enhancing hypodense lesion along the left trigeminal nerve with extension and causing the scalloping of the petrous epiphysis of left temporal bone. Routine preoperative laboratory investigations showed hemoglobin 7 gram per deciliter with packed cell volume of 21.7%. Blood group was found to be O positive with Bombay phenotype. As the patient requires port spine correction and trigeminal schwannoma excision, patient will be posted for surgery in 2 different settings. Patient initially had been planned for correction of anemia, which will be followed by preoperative autologous donation. At present, patient is on oral iron therapy at a dose of 200 mg per day, which he is well tolerating, and now is being planned for erythropoietin therapy at a dose of 50 units per kg. We intend to achieve our target hemoglobin of 12 gram per deciliter in around 4 to 6 weeks. Once the desired hemoglobin level is achieved, autologous blood will be collected 72 hours prior to surgery. Intraoperatively, we are planning to give tranexamic acid at a dose of 20 mg per kg, followed by 2 mg per kg per hour to decrease the blood loss, and acute normovolemic hemodilution technique is also being planned as bleeding during surgery might exceed the allowable blood loss. Autologous blood transfusion, when used appropriately, can provide a safe alternative to allogenic transfusion. However, there is an important need to balance the use of resources in ensuring safe blood transfusion for all those who need it. Thank you.
Good evening, everyone. I am going to present anesthetic management of awake craniotomy, a case report. Introduction. Awake craniotomy is an intracranial surgical procedure where the patient is deliberately awake during the surgery for localization and resection of epileptic focus or for the resection of tumors located near eloquent areas of brain such as Broca's speech area, Wernicke's speech area, or motor strip region. Our case is a case of 27-year-old male, Mr. Karthik Raja, who presented with the complaints of headache for 6 months and 1 episode of seizure 1 week back. Basic blood investigations are normal, ECG normal, chest X-ray PAV normal. CT showed a space-occupying lesion of left posterior frontal lobe just in front of precentral gyrus. MRI imaging confirmed with the diagnosis of CT brain imaging. Diffusion tensor MR imaging and tractography was done to see the effect of tumor over the motor strip region and speech area, whether it is infiltrating or displacing. In our patient, the tumor was displacing the motor strip region and has less influence on the speech area. Now we plan for anesthesia. Anesthesia for awake craniotomy. Preoperatively, patient was assessed. Awake cycle of anesthetic technique was planned. Patient was shifted to OT on the day of surgery. Standard monitoring connected. Invasive blood pressure monitoring was done with arterial cannula. Pre-medication was given with 2 mg of IV midazolam and injection ondansetron 4 mg intravenously. Scalp block was given and surgical site was infiltrated with local anesthetic, and sedation and analgesia was maintained with dexmedetomidine infusion dominantly at a dose of 0.3 to 0.5 mg per kg per hour, which is supplemented with propofol infusion at the dose of 20 to 50 microgram per kg per minute and fentanyl infusion at a dose of 0.5 to 1 microgram per kg per hour intermittently. Cortical mapping was done with the help of neurophysiologist and his gadgets. The tumor resection was done without disturbing the eloquent and motor functions of the patient. Postoperatively, patient was monitored in ICU for 24 hours and then shifted to ward and then discharged without any neurological deficits. So, on conclusion, appropriate selection of the patient, understanding the procedure of surgery, and judicious use of sedatives and anesthetics, and along with proper coordination between the team members inside the OT are the key to success for awake craniotomy as a procedure. Thank you.
Dr. Sandeep Kumar.
Hello everyone, myself Dr. Sandeep Kumar,
PG residents, Bhubaneswar, and I am here to present case of VHL syndrome and its anesthetic management. One hippolymph is an autosomal inherited disorder. It's characterized by tumors in the cerebral hemispheres, retina, brainstem, and spinal cord. Here I am presenting a case of VHL syndrome, which is not associated with pheochromocytoma. A 21-year-old male presented with complaints of loss of vision in the right eye since 6 years and decreased vision in the left eye since 1 month. Previously, he underwent embolization, following which he developed weakness in the right upper limb and the lower limb. And further, on ophthalmic examination revealed bilateral retinal angioma and papilledema. An MRI brain has been done, and the right showed right cerebral hemangioblastoma as shown in the figure. And there is cervical hemangioblastoma at the level of C6 and hemangioblastoma at D10 and D11. Further workup on patient was provisionally diagnosed as VHL syndrome. So on 24 hours urine and meta-reference were done, and which came to be negative. So patients posted for posterior tumor excision under general anesthesia. Patient is pre-medicated with glycopyrrolate, midazolam, nalbuphine, propofol, nalbuphine. Propofol is used as an induction and rocuronium as muscle relaxant. Intubated with fiber optic bronchoscope in view of cervical hemangioblastoma. Neck is stabilized and turned prone position, and Mayfield head clamp is applied. Anesthesia is maintained with isoflurane and 1:1 ratio of air, oxygen, vecuronium, and dexmedetomidine infusions were given. Phenytoin given as a seizure prophylaxis. Surgery lasted for 9 hours. And the fluid management is challenging. ABC done at the end of the procedure was with the acceptable limits. So patient is shifted to ICU for overnight elective ventilation and extubated next morning. Concluding, undiagnosed pheochromocytoma carries high risk of perioperative mortality and morbidity. Untreated cases results in blindness and permanent brain damage. So early detection and treatment gives better prognosis. Thank you.
Dr. Pavitra.
Good morning, everybody. I'm presenting to you anesthetic management of a child with single ventricle with pulmonary atresia coming for emergency barrel tapping. A 5-year-old female child of weight 15 kg presented to us with complaints of worsening in difficulty in breathing and fever for past 1 week. She was a known case of congenital cyanotic heart disease, and the child was irritable and agitated at the time of presentation. Echo at birth showed single ventricle pulmonary atresia with hypertrophied ventricle and a mild aortic regurgitation with dilated aortic root and the patent foramen ovale and AST. Echo was repeated on admission. It showed multiple collaterals in addition to previous echo findings. CT brain showed multiloculated abscess in the right temporoparietal lobe causing midline shift. The child was started on antibiotics and tablet digoxin. Her baseline saturation was 50 to 60%. She was started on infusions, dobutamine and milrinone. Our plan of anesthesia was general anesthesia and tube intubation with controlled ventilation and arterial line for hemodynamic monitoring. Our concerns were single ventricle with pulmonary atresia, cerebral abscess, and increased intracranial pressures with midline shift. Our goals was to prevent myocardial depression, maintain adequate saturations, to prevent embolism, thrombosis, maintain adequate depth of anesthesia, prevent increased ICP and paradoxical embolization. Prior to induction, all the standard ASA monitors were connected. 20 gauge Gelco was secured in left radial artery and 20 gauge IV cannula was secured in left cubital vein. After pre-oxygenation, anesthesia was induced with fentanyl, ketamine, and vecuronium, and trachea was intubated with 4.5 millimeters uncuffed endotracheal tube. Anesthesia was maintained with air oxygen mixture with sevoflurane and ventilated with a tidal volume of 6 ml per kg and respiratory rate of 20 breaths per minute. Airway pressures were maintained below 20 centimeters of water. FiO2 was titrated to achieve saturations between 75 to 85%. A pulmonary to systemic blood flow rate of approximately 1.3:1 with saturations ranging between 75 to 85% and a hematocrit of 45 to 50% were considered optimal. After completion of surgery, the child was extubated with infusions dobutamine and milrinone, which were later tapered and stopped, and child was started on antiepileptics. These patients with single ventricle are prone to systolic and diastolic dysfunction under the stress of anesthesia and surgery. So we aim to prevent myocardial depression and maintain systemic vascular resistance, maintain adequate saturations, and to prevent air embolism, thrombosis, and paradoxical embolization. It was a delicate balance, maintaining the oxygenation at lungs and delivering the same to the tissues without increasing the intracranial pressures. Used opioids and avoided myocardial suppressing drugs to prevent myocardial suppression, maintain saturations between 75 to 85%. We avoid high tidal volumes and high peak. Dobutamine and milrinone infusions were used to maintain SVR-PVR ratios, and cholecalciferin were also used to maintain SVR in relation to PVR. In this case, we aim to maintain the SVR-PVR ratio without increasing the intracranial pressures.
The session is open for discussion, sir.
Yeah, the first candidate, Madhumati, right?
Yes, sir. Good evening, sir.
This is Moyamoya disease.
Yes, sir.
What are the specific challenges that we face in this disorder other than routine challenges? While anesthetizing the patient with this disorder, what are the specific challenges we encounter?
Sir, mainly the to avoid the hypercarbia, sir.
Why is that? Because you mentioned a lot about intubation response. Otherwise, everything was non-specific. Okay, so you used only paracetamol for post-op analgesia, right? What was the route of administration?
IV, sir.
IV.
Infusion, sir.
What is the weight of the patient?
16 kg, sir.
Okay, what was the dose of paracetamol given?
To 180 ml we have given, sir.
180 ml means how many grams, milligrams? Can you be a bit specific? What is the dose limit of paracetamol in a child?
10.
Okay, thank you. Next, madam, you want to ask anything? Okay. Next is, thank you, Madhumati. Pragya?
Good evening, sir.
Yeah, good evening. Did you actually do autologous transfusion in this patient?
No, sir, we haven't done. We are planning to do.
Oh, the patient is yet to be posted.
Yes, sir.
Okay. So what is the expected blood loss in the surgery in your setup?
Sir, around for Potsman correction, around 400 ml, sir.
Oh, you
And
must be having very good surgeons. Okay. And how much are you planning to collect well in advance, or are you going to do ANI?
sir,
ANH.
While doing preoperative autologous donation, we are planning to collect
No,
1
what is
unit.
your plan for this patient? You have a patient, right? You're going to manage.
Yes, sir.
What is your plan?
Initially, after correction of anemia, we are going to collect one unit of blood, sir. After that, like.
Are you going to collect well in advance, a few days or weeks before? Or are
Yes,
you
sir,
going to do right before the start of surgery?
No, sir, 72 hours prior to surgery, sir.
Why 72 hours?
Because guidelines say the minimum like the last donation should be at least 72 hours before the.
Why not do it a week before? Why 72 hours? It will be still better, right? Patient gets more time to recuperate the hemoglobin.
Yes, sir.
Is there any reason you pick 72 hours?
No, sir. Actually, the minimum time gap will be 72 hours, sir.
Oh, so you want to maintain the minimum. What's wrong if I collect a week, maybe 10 days in advance? What might go wrong?
No, sir, nothing. Nothing.
Will the oxygen carrying capacity remain the same if you collect a blood at 10 days in advance or 3 days in advance? Rather, let me rephrase it. Will the blood be able to deliver the same quantity of oxygen?
Yes,
when
sir.
you collect at different time points?
Yes, sir.
What are the changes that happen in blood when you store externally over a period of time? Quickly tell them.
Sir, over a period of time, the pH of the blood will get decreased. Then,
Okay.
The thrombotic factors will get diminished, sir.
Why is
Anything
that
else?
problem? Okay. Well, madam, anything else you want to ask, madam?
You're saying it's spot spine and patient is not able to walk now. You think is it okay to wait for so long when bladder might get involved, no? Bladder and bowel.
Yes.
The surgeon is okay to wait for so long, is it?
Yes, sir. Yes, ma'am.
Okay. Okay.
Thank you.
Okay. Dr. Vishnu, are you there?
Yes, sir. Good evening, sir.
Good evening. So you have done the case under local anesthetic with the dexmed and fentanyl, is that correct?
Yes, sir. Yes, sir.
Did you give a dexmedetomidine any loading dose?
Yes, sir. We gave a
No, you didn't mention it. You mentioned only 0.3 to 0.5 mics per kg per minute or per hour, was it? Vishnu, we lost you there. Are you still there? Okay. Vishnu is not there. Mr. Dr. Sandeep Kumar?
Yes, sir. Good evening.
Yeah. Good evening. You did VHL syndrome, right? What was the type in this patient?
Yes, sir. So type
What
1,
type
sir,
was
without
it?
pheochromocytoma. It's
How
a
do you
type 1, sir.
classify VHL?
Classified with type 1, type 2, sir. Type 1
Okay.
is with
Subtype?
associated.
What are the subtypes?
Subtype 1 and 2, sir. With pheochromocytoma, without pheochromocytoma.
No, you said type 1 and 2. There are subtypes, right? Which type
Yes,
has
sir.
subtypes?
Type 1
or type 2?
So type 1 has renal carcinoma and meningioma.
Okay. Yours had the pheochromocytoma?
Sir?
Did your patient have pheochromocytoma? No,
Sir,
no.
in this case, no, sir. We work up for pheochromocytoma. It came negative, sir.
Okay. Did the patient have renal cell carcinoma?
No, sir. Only patient has hemangioblastoma and cervical hemangioblastoma and retinal angioma, sir.
So what type and subtype you will fit the patient in? Becomes difficult now.
Sir, actually, it's presented due to its rare case.
Okay,
and,
this is a syndrome, right? It's
yes,
a syndrome. So
Yes,
what
sir.
are the possible combinations you get? Can you just list them?
Possible combinations, maybe it associated with pancreatic cell cancer and renal cell cyst. It may make renal cell carcinoma, and may associated with renal angioma, and it may also 10% chance of endolymphatic inner ear tumors.
Okay, was there any family history?
No, sir, there is no family history with this boy, sir. But it's an autosomal
Is
dominant.
it not familiar?
It's a familial autosomal dominant disorder, sir. But a family history
But
is
this patient didn't have a family
not given,
history.
sir.
Okay, okay. Madam?
Yes, sir. Yes, sir.
Nothing, sir.
Okay. Pavitra?
Feeling, sir.
Okay. So you had taken a lot of steps to prevent reversal of the shunt and not reversal, I mean further shunt and what is you listed?
Sorry, sir.
What are the problems you're worried about?
So the
in this
baby is
patient?
already a known case of cyanotic heart disease, sir, whose presenting saturations were already low.
Yeah. So
as
the
a concern
intro
that
concerns that you are listed nicely. Can you just repeat them for me?
yes, sir. I wanted to maintain the SVR PVR ratio, and
Okay.
along with that, the baby had a abscess in the brain.
So you want the PVR on the higher side, right, or lower side?
Sorry, sir.
PVR you want on the higher side or lower side? PVR, pulmonary vascular resistance.
I want a PVR on the lower side, sir.
So how did you ensure that?
Sir, we started the baby on dobutamine and milrinone infusion, sir. Dobutamine was started at 5 mics per kg per minute, and milrinone we didn't give a loading dose. We started with the maintenance dose of 0.5 mics per
But
kg.
they reduced the SVR. How did you maintain SVR?
Sorry, sir. I didn't get you.
Dobutamine and milrinone reduce the SVR, but here you want not to reduce SVR. You want to reduce PVR only. How did you ensure SVR is maintained?
We induce the baby with ketamine to maintain the sympathetic stimulation, sir.
What is the duration of surgery?
Sir, the duration of surgery was around 1 hour to 1.5 hours, sir.
Do you use ketamine throughout the surgery?
No, we used ketamine only for induction.
Okay, what was the other anesthetics?
We also used boluses of phenylephrine, sir, to maintain
Phenylephrine. Oh, okay. Did you boluses, not infusion?
No, we didn't use infusion, sir.
Okay. What are the FaO2 that you had used?
So FiO2 we titrated to, we didn't stick on to a particular FiO2, sir. We just titrated the FiO2 all throughout to maintain saturations between 75 to 85 and all
Does
ABGs were taken.
FiO2 has any impact on pulmonary vascular resistance?
Yes, sir. When we deliver excess of oxygen, there is pulmonary vascular dilatation can be present, sir.
So did you not want that here?
Yeah, we just wanted the pulmonary vascular resistance to come down, sir. That means vasodilatation is warranted in our case, sir.
Okay. Well, then why do you target only SpO2 of 75?
So the baby had a baseline saturations of 50 to 60, sir. So
Okay. Okay. Fair enough. Fair enough. Fair enough. Thank you, madam.
You said the surgery done was burr hole, is it? But there is multiloculated. There were many abscesses or just?
There was only one multiloculated abscess, ma'am.
And they drained the. They
yes.
just.
Yes, ma'am.
What do you think was the cause for this?
Ma'am, the baby is a known case of cyanotic heart disease, so the baby will be prone for polycythemia because of chronic exposure to hypoxia. Because there was a polycythemia, the baby is prone for stasis, and that could have been led to infections, ma'am.
And polycythemia leads to?
A stasis and thrombosis.
Stasis. Okay. Okay, ma'am.
Thank you, ma'am.
I think our session is over.
Yes, sir. Yes,
okay.
Sir. Yes, sir.
Dr. Malini, I will give the marks for all the candidates except EMEA. So
Yes, sir.
whatever marks madam is giving, you just double that.
Yes, sir.
That should be sufficient.
Yes, sir. Yes,
okay.
Sir.
Thank you.
Thank you so
Can
much.
we sign
Thank
off
you
now?
so much, sir. Yes, sir. Yes, sir. Sure,
Thanks
sir.
a lot
Thank
for
you,
the
judges.
opportunity.
Yes, sir.
And,
thank you,
I thank
participants.
all the participants and Dr. Brinda. Thanks a lot.
Thank you, sir. Nice session.
Thank you, ma'am. Thank you, sir. We come to the end of the session. The session is handed over to Dr. Yoga Satya. Over to you, Yoga.
Thank you, ma'am. Good evening, all. Am I audible? Good evening, all.
You're audible, ma'am.
Am I audible? Yes, yes. Thank you. Thank you. I'm welcoming our respected judges for this session, Dr. A.L. Meenakshi Sundaram sir, Dean of Government Perambalur Medical College, and he was honored by our government as a Best Doctor Award and Tamil Chamal Award, and also is ex-Vice President of ISA National in the year of 2016. And Dr. Srinivasulu sir, a professor in Vijayanagar Institute of Medical and Science, Ballari, Karnataka, is ex-president in ISA Karnataka chapter. Sir, our warm welcome for you, sir. We'll directly go to the session due to the lack of time. And madam, please play the video of Dr. Saravanan.
Good evening, sir, madam. Today I will be presenting a poster on the anesthetic management of a severely stunted congenital hypothyroid patient presenting for a giant intra-abdominal ovarian tumor. The patient was 20 years old. Height was 118 centimeters, weight was 20 kg. She came with complaints of abdominal distension over the past 3 months. Patient had history of delayed developmental milestones, mental retardation, and hard of hearing. She has not attained minority yet. She was on variable dose of thyroxine over the years. Right now, she's on 150 mics thyroxine. On examination, her abdominal girth was 79 centimeters. Her resting heart rate was 137 per minute. BP was normal. Room air saturation was 99%. She had no respiratory distress or difficulty. On palpation, there was a mass palpating the abdomen, extending till the sternum. Preoperative pyrometric analysis for lung function could not be done as the patient was mentally retarded, and the preoperative echo was done to rule out cardiac anomalies. Upon receiving the patient on table, oxygen in the left lateral position, injection of fentanyl, propofol, atracurium were given. Epidural anesthesia was deferred. Central venous access was acquired in the right IJV. Standard monitoring of NIBP, ECG, SpO2 with CVP, ETCO2 and serial ABGs were done. The intraoperative blood loss was 40 ml. The patient was received with infusion noradrenaline, crystalloids, ploids, TRBC and FFP. Bilateral tap block was given post-operatively to allow EC extubation. Patient was extubated on table and was shifted to PSU for 48 hours for post-op observation. Injection fentanyl 20 mics per kg and injection infusion paracetamol were given for pain relief. The anesthetic goals in this patient were to maintain hemodynamic stability, adequate pain relief, reduce perioperative stress, appropriate ventilation, maintenance of fluid and electrolyte balance, and avoidance of thromboembolic episodes. Dysthyroidism concerns were dysthyroidism, mental retardation, pain relief, supine hypotension syndrome, acute fluid shift, deranged pulmonary function, ventilation, and pulmonary edema. Dysthyroidism in this patient was very difficult to manage. She required a high dose of thyroxine, led to the high resting heart rate, which is why noradrenaline was chosen as for inotropic support. Mental retardation and hard of hearing made it difficult for spirometric analysis, and regional anesthesia was deferred because of this reason. Fluid balance, there cystic fluid of 500 ml and ascitic fluid of 200 ml was aspirated. This was aspirated slowly to avoid massive fluid shift from the vascular compartment and to avoid hypokalemia, hypomagnesemia, and other electrolyte abnormalities. CVP was used as a guide for monitoring. Ventilation was done in the pressure control mode. Hemodynamic stability was maintained with adequate resuscitation and stop. Thank you.
Next video, Dr. Anne Xavier's video.
I am presenting a case of negative pressure pulmonary edema in a patient of CA thyroid recurrence who was positive for bilateral neck dissection. The recurrent laryngeal nerve and external motor branches of superior laryngeal nerve are in close proximity to thyroid gland. Morbidity from thyroid surgery approaches 13%, a common complication being nerve injury. Recurrent laryngeal nerve damage after thyroid surgeries are reported to be 0.5% in benign and 10.6% in malignant cases. Negative pressure pulmonary edema follows acute upper airway obstruction. In our case, patient was 48-year-old female, non-case of papillary carcinoma thyroid with lymph node metastasis, who underwent total thyroidectomy at central compartment clearance and received radioablation therapy in 2018. Now presented with recurrence of the disease and posted for bilateral neck dissection. Airway examination was unremarkable. Induction with propofol fentanyl attracurium. Intubated with 7-size ET2. Maintenance with isoflurane oxygen and air mixture. Intra was uneventful. Following extubation, patient developed a respiratory distress with stridor and labored breathing. With fiber optic scope, vocal cords were examined and found to have bilateral minimal cord movement with narrow glottic opening. Planned for tracheostomy, reintubated with 6.5 size ET2 followed by tracheostomy with 6 pence Shiley's tracheal tube. Post tracheostomy, she was conscious, comfortable. Saturation maintained at 90% with trach mask. Shifted to PSU. In PSU, after some 30 to 45 minutes, she again developed breathing difficulty. Saturation dropped to 90% on trach mask. Pulse rate 130 per minute. BP 170/100. Respiratory rate 34 per minute. Chest examinations revealed hoarse crepitations. Blood reach to watery discharge in tracheostomy tube also noted. She was started on 100% oxygen with vein circuit. Injection Lasix 40 mg, injection metoprolol 3 mg given and was shifted to ICU. She was kept on supportive ventilation CPAP for 18 hours. Pulmonary edema settled, ventilator wheeled to trach mask and then to room air. Repeat scoping done after 10 days revealed vocal cords still in midline position. Conclusion: in case of unilateral recurrent laryngeal nerve injury, patient experiences hoarseness, whereas in bilateral injury, patient experiences airway obstruction. Tracheostomy is the choice of treatment. Negative pressure pulmonary edema is due to development of high negative intrapleural pressure by vigorous inspiratory efforts against an obstructed upper airway. Usually it is self-limited. Maintenance of patent upper airway and administration of oxygen is the key in management. Mechanical ventilation for a brief period is occasionally needed. Thank you.
Next video, Dr. Vigneshwaran.
Anesthetic consideration in a patient posted for pheochromocytoma resection. Pheochromocytomas are catecholum and secreting tumors that arise from the chromaffin cells of the sympathetic nerve system. Incidence: less than 0.1% of all hypertensive cases in adults. Occurrence equally in both the sexes and in all races, but most commonly in the age group of 30 to 50 years. Associated symptoms: men and BHL. The only cure is surgical. Pre-op evaluation is key to a successful perioperative management. Is history. A 70-year male presented with a history of increased urinary frequency for 1 month, episodic palpitation with sweating for 2 years, seizure and hypertensive disorder for 13 years, planned for right adrenalectomy. On general examination, patient's general condition is good. In first assessment visit, patient pulse rate is 84 per minute, BP 110 with an SpO2 of 99%. Pre-operatively, patient advised to start on tablet phenoxypyramide and tablet atenolol 10 days prior to the procedure and to continue the antihypertensives and anti-epileptics till the day of surgery and BP to be monitored at least twice a day. On the day of surgery, pre-procedure, patient pulse rate is 63 per minute, BP 110 by 70 mmHg with an SpO2 of 99%. Systemic examination, CVS and RS were normal, routine and tumor-specific investigations were normal. Radiography abdomen suggested right atrial malignancy, which is shown in the image below. Anesthetic goals: perioperatively ensure adequate hydration. Preoperatively optimize the alpha, beta, and calcium channel blockers to give anxiolytics. Intraoperatively, invasive hemodynamic monitoring to be established. Avoid drugs which cause systemic delays. Avoid stress response to intubation. Prompt hemodynamic management during tumor manipulation, tumor removal. Steroid supplementation. Postoperatively, invasive hemodynamic monitoring to be continued. Hypertension managed with IV fluids and vasoactive agents. Avoid basal lung atelectasis. Anesthetic management. Injection midazolam 1 mg IV given 1 hour per year. Patient shifted to OT. 18 glass IV cannula secured. Monitors connected. Right IHAV catheter and left radial arterial line secured. CVP and invasive BP monitor. In right atrial position, epidural space entry at T10 to T11. Catheter fixed at 10 centimeters. Patient premedicated with injection glyco, midazolam, and fentanyl. Patient induced with injection propofol along with the xylocod and injection vicodin used as a muscle relaxant. Patient intubated with 8.5 mm of ETT and ETCO to monitor. Patient maintained with 60% N2O, 1 to 2% sevofluorine and injection vicodinium. In supine position with right subcostal incision, tumor approach, hypertensive crisis and tachycardia managed with injection SNP at 50 mics per minute, tapered and stopped. And injection metoprolol 5 mg IV stat, post-tumor resection, injection methylprednisolone given, and hypertension managed with IV fluids and low-dose noradrenaline. Since the patient has good respiratory efforts on minimal inotropic support, patient reversed and extubated after giving 2% IV lignocaine 2 minutes prior. Post-op management, patient general condition is bad. NORAD stopped on the day of surgery. 0.0625% bupivacaine with 50 mg tramadol. 6th hourly given epidurally. Nebulization with bronchodilators, chest physiotherapy, incentives spirometry used for better lung compliance. Patient started on antihypertensives and POD3. Histopathology revealed adenal masses pheochromocytoma. Discussion. Since alpha blockade is very crucial in pre-op preparation, Rosen et al. Used a criteria to gauge the efficacy. In hospital, BP should not be greater than 160/90 mmHg, not less than 80/45 mmHg. No ST or T-wave changes are more than 5 PC should be in the ECG. Conclusion. General anesthesia with epidural anesthesia provides a better hemodynamic control to avoid stress response to intubation, surgical manipulation, and extubation. Epidural analgesia in the post-operative period provides a good pain relief, helps in easy breathing and early ambulation.
Next presenter, Dr. Pimbarkar.
Good evening, everyone. Myself, Dr. Pranjali, resident of PNS Loni, will be presenting today on anesthetic management of patient with cardiac pacemaker posted for carcinoma tongue excision and reconstruction. Pacemaker, introduced in 1958, is a small medical device that helps control heartbeat through electrical stimulation. Patient with pacemaker posted for non-cardiac surgeries pose challenges for modern-day anesthesiology. The management of these patients include anesthetic implications perioperatively. A 33-year-old female diagnosed with carcinoma tongue was posted for composite resection with flap reconstruction. She had undergone Medtronic bipolar pacemaker insertion for complete heart block and was kept on BVIR mode. A general preoperative assessment of the patient with airway assessment and routine blood investigations and thyroid function test were within normal limit. ECG showed pacemaker rhythm and echocardiography was normal. Chest X-ray showed pacemaker with unipolar lead and the pacemaker was evaluated for competency and battery life by pacemaker assistant. A high-risk consent was taken and the patient was kept NBM overnight. All the monitors were established and the pacemaker mode was then turned to VO17 using a magnet by the pacemaker assistant. Transcutaneous pacemaker, defibrillator, and antiarrhythmic agents were kept ready in case of device malfunction. Patient was then pre-medicated according to her weight with injectable glycopyrrolate, midazolam, and fentanyl, was pre-oxygenated and induced on injection propofol and vecuronium, and right nasal intubation was done with flexometallic tube number 7. Anesthesia was maintained on volume control mode with oxygen, nitrous oxide, and isoflurane, and injection vecuronium intermittently. Intraoperatively, care was taken to maintain adequate analgesia, normotension, normocapnia, and normothermia. Bipolar quadri was used for dissection and hemostasis. Pacemaker mode was programmed back to VVIR mode by application of magnet at the end of the surgery and patient was shifted to SICU and ventilated overnight. Pre-anesthetic management of patient with pacemaker, including evaluation and optimization of coexisting disease. Interrogation with programmer is the most reliable method for evaluating battery life and impedance of the device. Reprogramming of the device to the asynchronous mode at rate more rapid than the patient baseline rate ensures that no oversensing occurs during the electromagnetic interference. Intraoperative patient monitoring include ability to detect pacing discharge by ECG. Ketamine, succinylcholine, and etomidate are avoided. Bipolar quadri is preferred over monopolar quadri. Temperature must be monitored and post-operative shivering is avoided. Pacemaker settings are to be reprogrammed back to original settings after the procedure. And the anticipation of thus this behavior of both the patient and the device is the key to the safe management of uncomplicated procedure. Thank you.
Next presenter, Dr. Prakash.
Good morning to one and all. I am Dr. Prakash, final year PG from Government Changalpattu Medical College. Today I am going to present my topic, fluoroscopic guided celiac plexus block for pancreatitis patient with chronic abdominal pain. Celiac plexus block and image guidance is an easy percutaneous procedure with good outcomes for pain palliation in pancreatitis or malignant disease in the upper abdominal viscera patients after failure of standard pain control therapy. Here we report a case of acute exacerbation of chronic pancreatitis treated with the neurolytic celiac plexus block. Case report: a 44-year-old male, non-diabetic on insulin treatment, chronic alcoholic and smoker, presented with a history of abdominal pain for the past 6 months and got severe for the past 2 days. It was a severe epigastric pain related to back, aggravated after food intake and then lying down. Epigastric tenderness was present. Visual analog scale score was 9, indicating severe pain. Routine blood initiation were normal. CT abdomen showed contracted pancreas with multiple calcifications and edematous peripancreatic fat standing, suggestive of acute and chronic pancreatitis. Patient had poor response to conservative multimodal analgesia management, hence planned for celiac plexus block. Pre-procedure vitals were normal. ASA standard monitors were attached and recorded. Under strict ASA precautions, patient in prone position with pillow under the abdomen, using monitor anesthesia care and nasal oxygen. Skin over the target area was infiltrated with 2 ml of 1% lignocaine. The 22 gauge spinal needle was advanced under fluoroscopic guidance along both sides of lumbar vertebra, one with the needle depth assessed in lateral view. Needle placement was confirmed with contrast injection, pattern confirmed in AP and lateral views, which were found to be satisfactory. Followed by administration of 5 ml of injection, xylocard 1%, given in each needle, observed for 5 minutes, immediate pain relief noted. Vitals were normal. Injection 100% alcohol, 10 ml given in each needle in aliquots, 2 ml of 2% injection lignocaine, and 1 ml of injection dexa given in both sides. Post-procedural VAS score was 0 at 30 minutes and 6 hours of post-op assessment. We followed the patient for 6 months and he had no pain up to 4 months. Conclusion: celiac plexus block shows a significant reduction of pain scores in patients with severe intractable abdominal pain due to pancreatitis or malignant disease in the upper abdominal viscera. It also decreases the overall opiate consumption and improve patient satisfaction. Hence, fluoroscopic guided celiac plexus block found to be both efficient and effective procedure for pain palliation when compared to other conventional pain management methods. Thank you all.
Good evening, sir. I'm handing over the session to discussion part for 5 minutes, sir.
Yeah, okay. Sharavanan is online?
Yes, sir.
Yes, sir. First
Good evening,
one,
sir.
Saravanan.
Yeah.
Good evening, sir.
Sharavanan, congrats. You have managed a very interesting and rare case. What are the post-operative complications you expect in this patient?
Sir,
yeah.
Sir, patient had lost around 450 of blood intraops, sir. So, anemia, sir, hypovolemia, sir. And we transfused around 250 ml of blood, sir.
Right, so, okay. My question is, what are the complications you expect in the post-operative period? It's a case of hypothyroidism, a big tumor. You said hypovolemia. Okay, next.
Sir, adequate pain, respiratory complications, sir. It was a relatively large incision, sir. So,
okay, right, agreed.
pain would inhibit adequate tidal volume, sir.
Okay. Okay. Respiratory complication next. Next. Hypothyroidism is a
hypothyroid patients usually have basal low temperature, sir.
yes. Yeah.
So
They are prone
hypothermia.
for
Hypothermia.
for hypothermia also. Okay, right. So how will you manage if at all? I think prevention is better than cure. How will you prevent hypothermia in the post-operative? And if you suspect hypothermia, how will you manage it? Okay. Be brief.
Sir, I couldn't get you, sir.
How will you manage post-operative hypothermia?
Sir,
Hypothermia.
yes, sir.
Yeah.
Sir, by using IV fluid in body temperature, sir, warmed IV fluid, sir, and using warmer, sir, we can prevent further temperature loss, sir, by radiating convection and convection, sir.
Dr. Saravanan, sir is asking if it is a post-operative hypothermia as well as perioperative hypothermia. I am adding that if you say warmer, what kind of warmer you will use? Be specific.
Sir,
warm the IV fluid means what? You will warm it in a sterilizer, you will warm it in the heater, or you will produce a co-warming?
Sir, warm it in the sterilizer and bring it to like room temperature, sir, as in like body temperature, sir.
I think you have not used it, so you are not getting the point. That is vital. What sir is asking is a vital. You are not aware of infusion warmers, fluid infusion warmers, which will maintain the temperature at 37 degrees centigrade. It will be warmed to 41. I think you have not seen it. Anyway, no problem. But I want to ask one question. You said you will give GA and epidural. You have given GA and epidural. That's what you said.
No, sir. We deferred epidural, sir. Post GA, we did not give epidural because patient had growth and developmental delay, sir. So we did not know the depth of insertion, sir. And regarding ultrasound,
Saravanan, let me be very clear. You have introduced GA, right?
Yes, sir.
Then you have attempted epidural, which is failed.
No, sir. We did not attempt, sir.
Then why you are saying that when you have not attempted it, why you unnecessarily included the word epidural? That is the reason this question comes. You have not attempted epidural. You have not performed epidural anesthesia or analgesia.
Yes, sir. Sir, in onco anesthesia, it is given, sir, like regional anesthesia is preferred, sir, because we need to reduce.
Saravanan, that will come under discussion. See, you had only 3 minutes. Unnecessarily, you have used that word. You have given general anesthesia. That is a case discussion. Then we will ask you why you have not performed epidural. That's fine.
I think we can move
Shall
on
we move to next patient?
Yes, yes.
Yeah, and
So shall we,
Xavier.
and Xavier?
Yeah, he's online.
Next candidate.
Yeah.
And Xavier?
Yeah, Dr. Anak Xavier. You have managed the case of negative pressure pulmonary edema, and you have used CPAP in the post-operative period, right? Can you hear me? Am I audible?
Technical team, please unmute and Xavier. She's I think mute her. Please unmute. Shall we move to next candidate, sir? We'll catch her later.
Yeah, Vigneshwaran.
Vigneshwaran.
Good evening.
Dr. Vigneshwaran, congratulations. You have managed a case of pheochromocytoma. Okay, rarely we will get to manage such cases. Okay, what are the preoperative requisites in a case of pheochromocytoma to accept the patient for surgery? So you have told you have optimized the patient. Normally, when you accept for the surgery, what are the prerequisites? When you say patient is optimized for surgery?
Sir, preoperatively, the patient should be optimized 10 to 14 days prior to surgery, sir. The patient should be given alpha block.
Okay, I am not asking about the treatment aspect. When you say patient is optimized?
Sir, we use Rosen's et al. Criteria to assess the efficacy of alpha blockade, sir. With the patient 24 hours prior to the procedure, the patient having the BP more than 160 or 90 mmHg or not less than 80 or 45 mmHg, sir. If it's more than 160 or 90 mmHg, that means it says that it's ineffective alpha blockade. If it is less than 80 or 45 mmHg, it says overcorrected alpha blockade, and there should not be ST or T wave inversions or VPCs more than 5 VPCs in the ECG in the last week prior to procedures.
Right. So what are the important specific complications that can occur intraoperatively?
Sir, intraoperatively, while the tumor is manipulated, there will be the release of catecholamines from the tumor into the venous circulation. May have hypertensive increase in BP, and it can precipitate hypertensive crisis too. And post and tachycardia and post venous light, the patient develop a hypotension due to the part of the sympathetic system being cut off from the.
How will you manage this hypotension? Post-operatively, there can be hypotension. How will you manage this?
Post-operatively, we used IV fluids and a low-dose noradrenaline. We have managed with a low-dose noradrenaline. So started at 8 mics per minute.
No. Will there be any issues with the sensitivity of this particular patient to the catecholamines? Does he require more dose or normal dose or lower dose in the post-operative period?
Sorry, sir.
You said you will use vasopressors, no?
Yes, sir.
Does this patient behave differently compared to other patients with regard to the sensitivity to the vasopressor? We have used noradrenaline.
Yes, sir. Usually, noradrenaline is preferred, sir, because there will be part of the noradrenergic receptors being sensitive to the. There will be part of the adrenergic receptors being sensitive to noradrenaline compared with any other drug like dopamine or adrenaline, sir. Because we have already done the alpha blockade completely with the phenoxybenzamine, sir.
My question is: does this patient behave differently to the noradrenaline? Will the sensitivity to the noradrenaline be less or more or same?
Sir, will vary, sir, based on the patient's.
Vigneswaran, tell you one thing. Your subject is perfect as far as phagocytoma is concerned, but your answers doesn't match with Dr. Sriniva's question. That is a problem. Your answer is right, not relevant to the question. Even though which college you belong to?
Sir, Keelpark.
Keelpark. I will discuss with you later, because if I discuss this time now, the way in which you manage will take minutes. See, you have presented it just like a child's play. I don't know whether it is really a phagocytoma or not. Which drug you have used to control the blood pressure?
Sodium nitroprusside.
Preoperatively, I am asking. Before bringing the patient to the theater.
Phenoxybenzamine and atenolol.
So you have not thought of this labetalol, which is an alpha and beta blocker. Because see, you are just like that. You are saying the preoperative heart rate is 88. I have never seen a phagocytoma presented with 88. However, it's a good control. Then you say preoperatively the heart rate on the table is 63 per minute. It is all surprising. Then you have used, your idea is to cut down the heart rate, is it? That is your idea. Your idea is to cut down the heart rate. Am I right? You want to reduce the heart rate?
No, sir. To made an effective alpha blockade and
Boss, I'm asking a simple question. You want to reduce the heart rate or not?
Sir, yes, sir. And I want heart to be maintained at a particular range intraoperatively.
No, right. You wanted to reduce the heart rate. Then why you have used glycopyrrolate as pre-medication? So, okay, we'll go to the next person if Dr. Srinivas agrees.
Yeah, yes, sir.
Next candidate, Dr. Pranjali. Yeah. Dr. Pranjali Bakar. Are you there?
Yes, ma'am.
Yes, please.
Your case is Dr. She is Your name?
Dr. Srinivas,
Dr.
pacemaker.
Pranjali, sir.
Pacemaker, I think.
Yeah, pacemaker. Yeah,
Yes, sir.
Okay, you said in the intraoperative period, the problem will be when you use cautery, electrocautery. Can there be some other interference with the function, interference, some devices or procedures in the intraoperative period that can interfere with the functioning of the pacemaker, apart from cautery?
None that I'm aware of.
You're not aware. Okay, okay, no problem. No problem. Okay. Can there be, see, sometimes you may need to use defibrillator, no, intraoperatively.
Yes, sir.
Is there any issue with the use of defibrillator in a patient who is on pacemaker?
So specific defibrillators like intracardiac defibrillator are used basically in pacemaker patients. And if not, a transcutaneous pacemaker is kept available so that in case of any need, if patient goes into any VFib or anything, we can use that.
No, we don't have cardiac internal defibrillators. We have got only external defibrillators. You may need to use that because of some complication intraoperatively. See what issues will be there.
I could not get you.
No, when you want to use a external defibrillator, you have to you have to make some changes with regard to the position of the paddles when the patient is already having a pacemaker.
Sir, I don't know, sir.
You don't know. Okay, with regard to electrocautery, there is unipolar and bipolar, monopolar and bipolar.
Yes,
Which
sir.
one will you prefer?
So we prefer bipolar cautery more than unipolar cautery because unipolar cautery interferes with the electromagnetic field more as compared to bipolar cautery.
Yeah,
and the best that
strength.
you can.
Yeah.
Yes, sir.
Yeah, it depends on the strength, no? Strength of the electrical current, energy.
Yes,
right?
sir. We can even use unipolar cautery, sir, but then the thing of unipolar cautery is that we have to place the current pad away from the pacemaker side, and we should make sure that the cautery is used accordingly.
Sorry, you want to ask a question?
Yeah, see, I see she herself is not confident. So what is the use of asking? I think whether you have done the case personally or you are presenting somebody.
No, sir, I have done the case personally when I was posted in the first month of my third month of my GIship.
The pacemaker was in VVI mode. Am I right?
Yes, sir. What
is VVI mode?
So it is ventricular sensing, ventricular pacing, and inhibitory rate.
Then how you have changed it by a magnet? To which mode?
We had changed it to VOO mode, sir, where it was just. Huh, sir?
What is that? You said that mode.
What do you mean by that?
We just set it. We just desynchronized it, sir. We synchronized the pacemaker to ventricular sensing, just ventricular sensing mode. The pacemaking mode and the inhibitory mode was then shut off.
Sensing and pacemaking, which is the sensing chamber and which is the pacing chamber. Once you switched off the pacemaker.
So I'm not able to get it.
That's what, whether you have done it or cardiologist has done it for you. Whether you have changed the mode of the pacemaker personally or cardiologist has done it for you.
No, sir, a pacemaker assistant we had called, he had changed it for us.
So you don't know how he has done it.
So he has done with a magnetic device and he had an external device with him with his.
Just to know curiosity whether you have seen it or not personally.
Yes, sir, we have seen it.
What he has done?
Yeah, we've seen him making the changes, but not exactly what he has done.
That's right.
Okay, we can move to the
next candidate, Dr. Prakash.
Yes, ma'am. Good evening, ma'am.
Good evening, Prakash.
Yes, sir. Good evening, sir.
We have given celiac plexus block. What complications do you expect after successful celiac plexus?
After successful celiac plexus block, we can expect diarrhea and hypotension, sir, because of unopposed parasympathetic activity. Other local pain may be there, sir. Hematoma can occur, sir. Maybe any injury to vital structures, visceral organs, or major vessels nearby, sir. Neurological complications also expected, sir. Rarely paraplegia can occur, sir. Also pneumothorax, injury to kidney may happen, sir.
Okay. How will you manage this diarrhea? See, patient will have frequent diarrhea. That is because of what is the mechanism behind that?
Sir, during celiac plexus block, sympathetic blockade happens, sir. So unopposed parasympathetic activity leads to bowel hyperactivity of bowel, hypersecretion. So it will cause lead to diarrhea, sir. Preoperatively, we have to preload with IV fluids, and postoperatively follow for 24 hours in bed rest, sir. We have to hydrate, and we can give atropine, octreotide can be given, sir.
Right. What advice you will give to the patient before discharging this patient? You have to tell him some advice, no? You will give.
Yes, sir. Immediately after the procedure, a patient can make the patient lie down for minimum 1 hour or 2 hours.
No, advice you will give to the patient. See, before discharging this patient, you have to give advise him and
yes,
say,
sir.
he will be a chronic patient.
Yes, sir. Please avoid alcohol and smoking if he is having continuing that, sir. Also, if pain is more than 4 like that, we have to review patient weekly for first month, sir. After that, every 2 weeks we follow, sir. During that, patient has any difficulty in doing day-to-day activities, routine activities, or intolerable pain. We ask patients to review, sir.
Okay. Sir, you want to ask something?
Yeah, Prakash, can you perform a celiac plexus block without a fluoroscopy guidance?
So image without imaging it is difficult, sir. We can do with ultrasound guided or CT guided also, sir.
So you cannot perform a celiac plexus block without a imaging. That is your answer. Am I right?
Sir, I don't.
What was the position? No. What was the position of the patient while you performed the celiac plexus block?
Sorry, sir. Unable to.
Which position you have adopted?
Prone position with the pillow under the abdomen, sir. We adopted prone position.
Whether you have mentioned it in your presentation, position of the patient.
Yes, sir. Mentioned, sir.
I think I have missed it. I was watching. Then what contrast you injected?
Sir, we used iodinated contrast like IXL 0.5, sir. Also, we use Conray 240. Also, we use, sir.
I am asking for this patient what you have used. I am not asking what all the things which can be used.
Okay, sir.
Which contrast you have used?
Then we use IOHexal, sir.
How many ml you have used? How many ml?
So we use 0.5 ml, sir. Initially.
Then you are confusing me. Then what was the neurolytic agent which you have employed?
100% alcohol, sir. Industrial grade alcohol we use, sir. We used, sir.
What is the volume?
Alcohol, totally 20 ml used, sir. In each needle 10 ml we give, sir.
So the patient didn't have any paraparesis after the alcohol injection?
No, sir. No, sir.
What was the postoperative blood pressure?
So, both of 90, 60, sir.
How you managed that?
So, patient was continuously monitored, sir. We already preloaded with the fluids, sir. Pre-operatively, patient BP was normal, so 110/70. Go little hypertension, it will happen, sir. After that, we correct with fluids and make them supine, sir. We give drug with atropine given, sir. And if it,
we are asking you, patient developed a blood pressure of 90/60 after the block.
Yes, sir.
And what you have done? What you have done, I must.
Sir, we observe the patient, sir, and ensure not going beyond this.
Next, I think next Anne Xavier.
And Xavier, sir.
Yeah,
Thank you, sir.
And Xavier.
Yes, sir. Good evening, sir.
Yeah. Oh, so.
Yeah, good evening, and you said you have used CPAP, no, during the management of this negative in the post-operative period, right?
Yes, sir.
How do you think the CPAP has helped the patient? What are the mechanisms by which the CPAP would have helped the patient?
Positive pressure. We are giving positive pressure ventilation, sir.
Okay.
It will open up the collapsed alveolus.
Okay, number one. Next.
And then it will open up the collapsed alveolus and
that you have already told. I am asking about the mechanism. How a positive pressure will help when patient is having edema. So you know one reason. Okay. One mechanism you know, right? How you would have prevented this?
Sir?
How you would have prevented this complication?
Usually negative pressure pulmonary edema occurs because of acute upper airway obstruction.
Right, agree.
In this case, obstruction is mostly due to bilateral abductor palsy, sir.
Okay. Do you think it is a complete or incomplete flow? Incomplete palsy of the recurrent laryngeal nerve?
Initially, the cord was moving.
No, you said abductor palsy, no? Bilateral abductor palsy.
Bilateral abductor palsy.
Is it a complete recurrent nerve laryngeal palsy or incomplete recurrent?
Complete recurrent laryngeal nerve palsy.
Okay. How you would have prevented it? It's not complete. Is it complete or incomplete? Are you confident it is complete? Sir? Are you confident it is complete?
Bilateral. No, sir, it's incomplete. It was in the minimal movement was there, sir.
It's okay. Don't get confused. Okay. How you would have prevented this? You have told the reasons.
Sir, shall we move on to the next presentation, sir, within the interest of time?
Yeah, lost chance for her to answer. How you would have prevented? What is the take-home message?
In upper airway obstruction, we should be in the post-op period. We should be careful. In case the patient develops desaturation, we should be cautious and we should treat it accordingly.
Okay.
Okay. So shall we move this?
Yeah.
Move to the next candidate. Yeah. Okay. Next part is for 5 videos of candidates, then 5 minutes discussion, sir. Next is Dr. Sobalan video. Please play.
Good evening, everyone. The topic for poster presentation is a case report of intraoperative neurolytic celiac plexus block for a case of carcinoma pancreas. Introduction. Intraoperative celiac plexus neurolysis is an excellent option of pain relief in a patient facing inoperable situation intraoperatively. This provides pain relief, decreases stress response, improves gut motility, and postoperative pulmonary function. Case report. A 74-year-old male diagnosed as carcinoma of pancreas was planned for laparotomy and proceed under continuous epidural with general anesthesia. Intraoperatively, the carcinoma was found to be inoperable. So, we planned to give celiac plexus neurolysis under direct vision. Abdominal aorta was palpated at the level of hepatic artery bifurcation where the celiac plexus is located anterolaterally to aorta. The intraoperative neurolytic celiac plexus block was performed with absolute alcohol and 0.5% bupropion along with added adjuvant dexamethasone. Aorta was palpated and 10 ml of 0.5% bupropion was injected into celiac plexus and then 10 ml of absolute alcohol was injected into the celiac plexus, 5 ml on each side carefully after repeated aspiration in order to avoid accidental intravascular injection. Immediately after the celiac plexus blockade, an episode of hypotension was observed which was managed with crystalloids and noradrenaline support. Hemodynamic stability was achieved by the end of the surgery. At the end of the surgery, patient was extubated on table and shifted to post-op ward for observation. The post-op pain score calculated using numerical rating scale was less than 3. On the third post-operative day, the gut motility was restored and inspiratory flow rate of 1200 ml per second was achieved in incentive spirometry. Post-op period was uneventful. The patient was followed up at the end of the first month and the pain score was calculated using numerical rating scale, which was less than 3. Discussion. Neurolytic celiac plexus block is typically performed for cancer-related visceral pain originating in the upper abdomen, hypertension and diarrhea are potential adverse effects. These adverse effects are transient and short-lived. The reason for these adverse effects is the parasympathetic drive, which is present after the sympatholysis produced by celiac plexus block. Conclusion. In inoperable surgical situations encountered intraoperatively, celiac plexus block, when performed under direct vision, ensures good pain relief. Thank you.
Next candidate, Dr. Priyanka Devi. Please play the video of Dr. Priyanka Devi.
Good evening, one another present here. This is Dr. Priyanka Devi, a case report of radiofrequency ablation of mandibular branch of trigeminal ganglia for trigeminal neuralgia. Trigeminal neuralgia is a neuropathic pain condition involving the face with the prevalence of 4 per 1 lakh in general population. It commonly affects the patients aged more than 50 years and occurs frequently in women than men. Case details: a 64-year-old female referred from dermatology OPD with complaints of excruciating, sharp, shooting, electrical shock-like pain with discoloration in the left side of the face, with history of multiple tooth extraction for the same. Mandibular distribution of the trigeminal nerve was involved. Pain was refractory to medical management. We took MRI and it showed vascular loop from distal part of the basilar artery in superior cerebellar artery on the left side, compressing over the root entry zone of trigeminal nerve, suggesting neurovascular conflict. Over the other techniques, patient gave consent for radiofrequency ablation of mandibular branch of trigeminal nerve after obtaining written informed consent, and overnight fasting. Prophylactic antibiotic were administered 1 hour before procedure. IV access secured with standard monitoring. Radiofrequency ablation was done under fluoroscopic guidance with the patient in supine position and head extended. Oblique submental view was taken to visualize the foramen ovale. After local administration, 2 to 3 centimeter lateral to the angle of the mouth, 22 gauge RF cannula with 5 mm tip was advanced in tunnel view towards foramen ovale. Depth of the cannula inside the Meckel's cave was ascertained with a lateral fluoroscopic view. After that, sensory and motor stimulation was done. Sensory stimulation caused a similar type of the pain in the area supplied by mandibular branch, which patient was experiencing before the procedure, and motor stimulation showed twitching of the muscles supplied by mandibular branch. Stimulation was done with the 0.2 Hz. After negative aspiration for blood, 0.5 ml of 0.25% bupivacaine was injected. Then RF ablation was done at 60 degrees Celsius for 60 seconds, and it was repeated for 3 times. During ablation, patient was sedated with the 30 mg propofol and 30 microgram fentanyl. Radiofrequency ablation is a viable, safe procedure with less morbidity and mortality. The peculiarity of this procedure is that, fascinating as it can be, repeated in the same patient if the pain recurs. It is important to rule out secondary causes of trigeminal neuralgia, even though the most common cause is idiopathic. MRI brain should be done to detect vascular compression of trigeminal nerve. Drug therapy remains the first therapy of choice, especially carbamazepine, but radiofrequency ablation remains better option for patients refractory to medical management and those who are unfit for microvascular decompression. Thank you, everyone.
Next one, Dr. Vivekanandan.
Good morning to all. I am Dr. Vivekanandan, resident at ESA Medical College, Chennai. And today I would like to share my thanks to the presentation committee and my professors and I could. Knee pain and unusual causes. A 39-year-old also but visited our pain clinic while bending the knee and back, and she had difficulty in getting the auto on car. Bending the knee produced pain and it relieved by stretching the knee. There was no history of back. There was no history of back pain. And pain is not radiating pain. Pain from the knee extend above back of thigh and below leg. Character like it's not electric shock, right? It's a pulling type of pain. And there was no issue of trauma to the knee and back. And issue of occasional headache. On evaluation, the pain score is about 5 to 6 by visual automatic scale. An examination over the knee is skin over the knee is normal. There was no swelling, no tenderness. And the investigation like routine hemogram is normal, and the X-ray also is normal. And we are ordered for MRI. At present, the patient diagnosis is put as patella-femoral syndrome. And when on going through the MRI spine or lumbosacral spine, it was found that there was a disc and herniation and impingement over L4, L5, L3, L4, and L2, L3, which is impinging under dural sac. On coronal section, this is at L3 level. This is the level of vertebra. This is the level of the disc. Disc normal pathology is lost, and there was a tear noted at the disc level. Condition like spinal stenosis, arthritis, or a disc herniation from L3 F4 can refer pain down to the knee. The nerve that exits the lumbar spine at certain level travels down to the knee. Thus, irritation of the nerve root in the lumbar spine can be achieved because of lateral, anterior, and medial knee pain. Once all specific subjective and objective tests are ruled out, it becomes apparent that dural mobility testing. It become apparent that dural mobility testing caused the knee pain. Palpated pain can be nothing to do with the knee. It could be referred pain from lumbosacral spine pathology. As such, this pain can be referred from the back of the thigh and up to the knee. The picture explanation. This is a disc impinging on the nerve roots can be cause of referred pain. And just annular tear, which breaks the nucleus pulposus and cause irritation of the nerve roots can be achieved because of referred pain. Thank you.
Next presenter, Dr. Lata.
Good afternoon, everybody. I'm presenting a case report on anesthetic management in a case of Ludwig's angina with kyphoscoliosis. Airway management is crucial and challenging in a patient with Ludwig's angina, whereas regional anesthesia is preferred in kyphoscoliosis. We present a case of incision and drainage of Ludwig's angina with kyphoscoliosis successfully managed with IV sedation, a secured airway, and avoiding general anesthesia. 60-year-old non-diabetic female presented with complaints of toothache, fever, swelling of the face, and difficulty in swallowing since 1 week, with productive cough since 1 day. Patient was afebrile, tachypneic, tachycardic with saturation of 94% at room end. Patient had difficulty in mouth opening and restricted neck movements. Patient had swelling over the left side of the face and submandibular region. Breath holding time was 10 seconds and the effort tolerance was less than 4 metabolic equivalents. Patient had a thoracic kyphoscoliosis with the left-sided decreased chest wall movements and decreased air entry. Blood investigations were within normal limit with chest X-ray left dorsal scoliosis with reduced lung volume and Cobb's angle of 55 degree. Patient was posted for emergency incision and drainage with tooth extraction. Patient was pre-medicated with IV glycopyrrolate 0.2 mg and oxymetazoline nasal drops were put in each nostril. Dexmedetomidine loading dose 1 microgram per kg over 50 minutes started, and patient was intubated with awake nasal fiber optic bronchoscopy with topical anesthesia using ET size 7 and connected to the T-piece with O2. Capnography monitoring was done. Dexmedetomidine infusion was continued at 0.5 microgram per kg per hour, and without exceeding the toxic dose of local anesthetics, infiltration was done during the stab incisions. Patient did not require any supplemental analgesics and patient was hemodynamically stable during the procedure. Dexmedetomidine infusion was titrated according to patient vitals, and post-operatively patient was not extubated, maintained on PPIs with dexmedetomidine infusion according to the sedation level. Patient was extubated with airway exchange catheter after clinical improvement, and post-operative recovery was uneventful. Coming to the discussion, thoracic kyphoscoliosis is associated with severe restrictive lung disease, and general anesthesia in these patients further worsens the pulmonary function, leading to post-operative mechanical ventilation and prolonged ICU care. Regional anesthetic technique with spontaneous ventilation is preferred. Dexmedetomidine is a highly selective adrenergic agonist that has a sedative and analgesic properties with no significant respiratory depression. In our case, patient airway secured with topical anesthesia, and dexmedetomidine infusion provided adequate analgesia and sedation at clinical dose range with maintained spontaneous respiration and stable hemodynamics. Hence, dexmedetomidine provides adequate sedation and analgesia with no significant respiratory depression in a clinical dose range, and hence helps to avoid general anesthesia in patients with respiratory comorbidities. Thank you.
Next presenter, Dr. Suganya.
A very good day to one and all. My topic is dexmedetomidine nebulization as a pre-medical and facial-maxillary surgery. My authors are Dr. Ramachandra Yasar, Professor and HOD, Dr. Netra, Assistant Professor, and myself, Dr. Sukanya, postgraduate at Bangalore Medical College. Introduction, facial-maxillary surgeries, often they have a difficult airway and there is blood loss also in such surgeries. And dexmedetomidine, which is an alpha-2 adrenergic receptor agonist, is sedative and it is effective in blunting the intubation response. And it also helps in controlled hypotension to avoid blood loss. So in this case report, we use nebulized dexmed to achieve the same. And methodology, 32-year-old male who has a left zygomaticofrontal, left zygomaticomaxillary and dentoalveolar fracture. He had no head injury, no comorbids, and airway mouth opening was 2 fingers. MPT was grade 2. TMJ and neck full range of movement was there. In cottonwool test, right nose was patent, and pre-op investigations were normal. Then intra-op, he was given pre-medication. He was given diazolometazoline nasal drops with nebulization lignocaine and nebulization dexmed 100 mics, which was given individually. And this reduced the opioid usage also intra-op. Total opioid which was being used was injection Fenta 60 mics as pre-medication and 20 mics intra-op. And induction was done with injection propofol, and injection scolin was the relaxant given. An 8 millimeter endotracheal tube, nasotracheal intubation was being done through the right nose. And maintenance was done with oxygen and air 50-50 at 4 liters per minute, and desflurane 2 to 6% was being used. And maintenance was done, maintenance relaxant was atracurium. And he was reversed on table with neostigmine and glyco to 2.5 and 0.4 mg. And post-op WAS score was 5/10 and Ramsay sedation score was 2. And in this case, the nebulized dexmed has helped to reduce the intubation response. And also it provided hemodynamic stability intra-op. That is, there was a controlled hypotension and MAP was maintained between 65 to 70. It also provided adequate sedation. It reduced the inhalation agent use, and opioid use also was being reduced, and post-op vomiting was also reduced, and it provided adequate analgesia, which was a VAS of 5/10 patient had. And these are my references. Thank you.
Coming to the discussion part for 5 minutes. Sir, please, sir.
Good evening, sir.
Dr. Sivabalan. Yes.
Good evening, sir. Good evening, ma'am.
Yeah, Dr. Sivabalan.
Good evening, sir.
Yeah. Even neurolytic celiac plexus problem.
Yes, sir.
What was the result in the post-operative period? How long the duration lasted?
Sir, I'm not able.
Duration of analgesia or pain-free period after the procedure.
Sir, the duration of analgesia for was about 72 hours. He was completely pain-free, sir. And then pain was started to come, sir.
No, this was a neurolytic block, no?
Yes, sir.
So you aim for a longer period of pain-free period.
Yes, sir. The surgery was done 1 month ago, sir, and we followed the patient. The post-op follow-up was made 30 days back, sir. last week, sir. He was pain free till then, sir. The visual unlock scale was calculated. Numerical rating scale was calculated, sir. The pain score was less than 3, sir. In the last visit, sir.
No side effects? No other side effects?
Sir, intraoperatively, we encountered hypotension, sir, which was managed with crystalloids and noradrenaline support, sir.
Okay.
We encountered
In the
hypotension,
follow-up? In the follow-up?
No, sir. We did not have any side effects in the follow-up, sir.
Meenakshi, sir.
Sir.
Good evening, sir.
Because of lack of time,
yeah,
let sir ask monitoring it. So only sir will ask. For very many people, I will not ask any questions.
Right, sir. Right. Okay, next.
Shall
we can move on to the next.
Priyanka Devi. Dr. Priyanka.
Dr. Priyanka,
good evening,
you are online? Right.
Yes, sir. Good evening.
Yes.
Okay, what are the complications of this trigeminal ablation, radiofrequency ablation?
It may produce numbness, sir, and if the ophthalmic branches involved, it may produce a corneal reflex will be gone, sir.
Okay, so because of this, if such patient comes for surgery.
Sir, sorry, sir.
If such patient comes for surgery and you are doing the case under regional anesthesia, some mild sedation, what complication can occur? So if corneal reflex is lost, is it a protective reflex or not?
Yes, a protective reflex, sir.
Yeah, so what complication can occur? The protective reflex is not.
It may produce dry eyes and.
So what care you will take to prevent that problem because of this?
While doing ablation itself, we'll check for the location.
No, you said there will be dryness of the
yes, sir.
And this protective reflex is.
Yes, sir. We will use during other surgeries. We'll use tear drops and we will close the eyes with gauze pad and so.
Yes. Okay. Right. Next candidate.
Thank you, sir.
Next candidate. Yes, Dr. Vivekanandan.
Yes, sir.
So, what is your take-home message? You have presented a case where the there was a problem at the spinal cord level, which has resulted in knee pain.
Okay. Sir,
why you have presented this?
Knee pain at the back of the knee and back of the thigh can be due to the annular tear and not particular to the pathology of knees. So that annular tear causes nucleus pulposus leak and chemical mediator can irritate.
No, what difference it will make to you? You are an anesthesiologist, no?
Yes, sir.
Yeah. What is your take-home message at least?
It can be treated by epidural steroid. One should keep in mind that you have to, if there is a lower limb pain, you have to keep in mind that you have to examine the spine also, sir.
Next candidate.
Dr. Lata. Are you there? Dr. Lata?
Yes, ma'am. Good evening, sir.
Good evening, Lata. So, what are the important issues? That is, to put it in a nutshell, what are the important issues while managing this case? What were your concerns?
Sir, initially, because it is a Ludwig's angina, we had to secure the airway, sir.
So,
because we didn't know the.
Right?
Yes, sir. Because the extent was not known because we could not do the CT or extent was not known. The second one is because the patient was having kyphoscoliosis, restrictive lung disease. Putting the patient on a mechanical ventilation would leave post-operative slow recovery and an ICU care. And being it's a short procedure of just the incision and drainage as well as the tooth extraction, limited time, we did not want to prolong the duration or give sedation with prevent positive pressure ventilation was prevented, sir, mainly. So we maintain the spontaneous ventilation.
Is it a oral surgery or not? Is it a ENT procedure or not?
Yes, sir. It's a OMF surgery, sir.
So what care did you take? What complication do you expect? The basic complication that usually we think of as anesthetician.
Sir, as an head and neck surgery, sir, there can be hypertension or because the oral.
It is a oral surgery. Okay, surgery in the oral cavity.
Yes,
okay. So what complication?
Yes, sir. The packing has to be done.
Yeah. Did you do that?
So aspiration and packing. Yes, sir. We did
did
that for the patient, sir.
Yeah, I don't think you have mentioned that in your presentation.
I didn't mention, sir. Yes, sir.
Yeah, that's very important.
Yes, sir. Sorry, sir.
Okay.
Yes, sir. Packing has to be done because more secretions and oral surgery. Yes, sir.
Right. Thank you. Thank you. We can move on to the next.
Next candidate, Dr. Sukanya. Dr. Sukanya.
Dr. Sukanya, are you online?
Good evening, sir.
Dr. Sukanya, are you?
Yeah. Good evening, Dr. Sukanya.
Good evening,
so
sir.
You said,
audible, sir?
Yeah.
Yes, sir.
You are audible.
Yes,
in the
audible.
presentation, you said desflurane reduced sedation produced by dexmet, right?
Yes, sir.
Yeah. What is that mechanism behind it?
Sir, desflurane, generally it can have, sir, there is increased vasodilatation, sir, with desflurane. So there is increased, sir, sir, the increased blood flow will be that to the coronary circulation, sir. So it can cause a hemodynamic stress response, sir, desflurane. So, and also it has a low blood gas partition coefficient, sir. So there is a faster recovery and faster induction, sir, with that. So it can promote faster recovery.
You said desflurane will take care of the sedation produced by dexmet. Right?
Yes, sir. Yes, sir. Sir, when we use dexmedetomidine, it causes sedation, sir. Yes, so even in post-op, slight sedation can be there during recovery time, sir. But since desflurane has a low blood gas partition coefficient, it can lead to faster recovery, sir. So it can cancel that effect of
recovery because of desflurane will be faster, but it will not affect the sedation
it won't
produced by
attend the full effect, sir, but partially it can help in patient regaining consciousness faster, sir.
Okay, thank you.
Okay, sir. Thank you, sir.
Yes. We can move on to the presentations.
Shall we move to the next video session, sir?
Right.
Dr. Robin Manidas. Please play Dr. Robin Manidas. Video.
Good evening. My topic is perioperative management of WPW syndrome. WPW syndrome is a ventricular pre-excitation arrhythmia by way of axillary pathway between the atrium and the ventricle. Premature activation of the ventricular tissue via the pathway produces delta waves. It has an incidence of 0.9 to 3% of the general population. Patient with WPW syndrome can be asymptomatic or may present with cardiac symptoms such as palpitation or dyspnea on exertion. WPW syndrome are of two types, type A and type B. I would like to present a case of a 47-year-old lady diagnosed with cystadenoma ovary, right side with bilateral hydroureteronephrosis, acute and chronic CKD, and systemic hypertension. NYHA grade 1 and meds of 4, Canadian Cardiovascular Society class 1. Clinically, the patient did not have any symptoms of WPW syndrome, with the examination revealing pulse rate of 94 per minute and grade 1 hypertension on beta blocker. Patient was anemic with RFT revealing elevated creatinine level. ECG showed WPW syndrome type B with normal cardiac function in echo. COVID RT-PCR was found to be negative. CT thorax showed thorax. One patient was posted for staging laparotomy with bilateral DG stenting to be done under epidural and general anesthesia. Drugs kept in ready in OT were adenosine, xylocat, amiodarone, esmolol, and defibrillator on standby. After placing epidural, patient was given 100 mg of fentanyl and induced by 100 mg of propofol, 8 mg of cisatracurium. Intubated with ET tube, maintained on volume control with MAC of 1.5% of isoflurane. Injection metoprolol 1 mg IV was given to blunt the intubation response. Patient was extubated with adequate reversal using TOF monitor. Coming to the discussion, the most important complication occurring in these patients are PSVT and atrial fibrillation or even cardiac arrest. The occurrence of supraventricular tachycardia is the result of premature activation of the ventricle by an accessory pathway known as the KEN pathway. Atropine glycopyrrolate ketamine precipitate tachycardia, hence it should be avoided. If PSVT is precipitated, then vagal maneuvers should be tried initially. In a hemodynamically stable patient, lignocaine, adenosine, or beta blockers like esmolol can be given intravenously to break the entrant tachycardia. When supraventricular tachycardia occurs with normal QRS complex, propranolol should be given. In urgent situation with supraventricular tachycardia, especially like atrial fibrillation or atrial flutter, BC shock is the treatment of choice. Patient developing AF with hemodynamic stability should be managed pharmacologically, whereas other situations should be managed with cardioversion with 150 to 200 joules. Conclusion: the goal during perioperative management of anesthesia is to avoid any factor that increases sympathetic activity such as pain, anxiety, stress response of intubation, lighter plane of anesthesia, or hypovolemia, as any increase in heart rate would result in PSVT or atrial fibrillation or even cardiac arrest. In this patient was maintained in sinus rhythm with heart rate of not exceeding 100 per minute by perioperative use of beta blockers. Since the patient was asymptomatic, patient was advised to undergo electrophysiological study for correction of aberrant pathway. So I conclude by saying prevention is always better than cure. Thank you.
Next presenter, Dr. Abhinath Kumar.
I'm going to present a case of toxic epidermal necrolysis posted for amniotic membrane transplantation. Coming on to toxic epidermal necrolysis, it is an example of type 4 hypersensitivity reaction where there are more than 30% of the total body surface area involved. And it is characterized by mucocutaneous involvement of the genital inner system, oral cavity, and GAT. The ulcerative lesions may be present all over the oral cavity, trachea, posing a great challenge in airway management. Coming on to our case, we received a 14-year-old girl weighing 40 kg with history of fever for 4 days. She was treated with oral NSAIDs such as paracetamol and IV antibiotics such as ofloxacin. After 24 hours, she developed ulcerative lesions all over the body and was started on IV steroids and was referred to our tertiary care center for further management. On arrival, the patient was hemodynamically stable. Bilateral corneal epithelial defect was diagnosed, and then she was posted for right amniotic membrane transplantation. Preoperatively, she had a mouth opening of 2 finger breadth and Malabati class 2, and there were no oral mucosal lesion involvement. IV access was also found to be difficult. The patient was shifted to operating table with adequate precaution. The patient was also explained about the intraoperative and postoperative complication. NABB was connected to left thigh where there was less skin involvement. And also the attachment of ECG monitor was found to be difficult due to widespread skin lesion. Right femoral central venous catheter was secured for fluid management. Pre-oxygenation was done with adequate padding and with gentle pressure with 100% oxygen. The patient was pre-medicated with injection midazolam 0.5 mg and fentanyl 75 microgram IV. The patient was induced with injection propofol 60 mg IV, and the neuromuscular blockade was achieved with injection atrakirum 20 mg IV. With direct gentle laryngoscope vision, the patient was intubated with 6-size cortex cupped ET tube and was confirmed with the ETCO2 confirmation. The ET tube was fixed with tube tie and attachment of tube plasters was avoided. The patient had a high chance of developing intraoperative hypothermia. So the OT temperature was maintained with 28 to 30 degrees Celsius, and IV fluid was connected with fluid warmer and adequate padding was done. Intraoperatively, there was no adverse reactions. The procedure went uneventfully, and the patient neuromuscular blockade was reversed, and the patient was extubated. Coming on to discussion, toxic epidermal necrolysis is an example of type 4 delayed hypersensitivity reaction with a lymphocytic infiltration of the epidermal layer. Toxic epidermal necrolysis was concluded due to the mucosal involvement and extensive skin ulcerations over the body. There are multiple etiologies involved. Here, paracetamol is suspected as the offending agent. Since difficult airway wasn't suspected due to lack of oral mucosal involvement, direct laryngoscope was performed and the patient was intubated. Other airway management includes awake fiber optic scope. Intraoperatively, the main anesthetic consideration of this patient includes the airway, electrolyte, fluid management, and of optimal.
Hello. Madam, shall we move to next page, next presenter? I think.
Good evening, everyone. I'm going to present a case report on anesthetic management of a retroperitoneal paraganglioma. Paragangliomas are extradental tumors of the autonomic nervous system. They usually occur as sporadic tumors. They are associated with high risk of morbidity and mortality from cardiovascular complications. Paragangliomas account for 5 to 10% of the pheochromocytomas. They can occur anywhere between the neck and base of the pelvis. Non-functional paragangliomas pose a significant diagnostic challenge. On abdominal CT, there are no unique imaging characteristics specific for paragangliomas. Case history: a 29-year-old male presented with abdominal discomfort and fullness for the past 2 years, and no other significant medical or surgical history were present. On physical examination, he was found to be anemic. An abdominal examination showed a firm mass of size 15 × 20 centimeters occupying the whole of the abdomen. Other systemic examination were normal. Investigations: complete blood count revealed anemia with an hemoglobin of 7.1 gram per deciliter, and all other blood parameters are within normal limits. CT abdomen showed extension of the tumor involving the mesenteric retroperitoneum, displacing the right iliac vessels and the left ureter. An echo showed left ventricular hypertrophy with an ejection fraction of 39%, and cardiac MRI showed features suggestive of amyloidosis. Management: the plan of anesthesia was combined epidural and general anesthesia with controlled ventilation and invasive lines. Adequate starvation guidelines were followed, informed consent were obtained, and blood reservation was done. And the patient was continued on alpha and beta blockers perioperatively, and standard ASA monitoring done. And epidural anesthesia was instituted at thoracic T8 and T9 level. Following an intubation, anesthesia was maintained with nitrous oxide and oxygen with sevoflurane, achieving a MAC of 1 to 1.3. And epidural infusion was continued. Prophylactic bilateral ureter stenting was done. And tumor was excised, partially excised, leaving behind the adherent part, and primary repair of the common iliac artery was done. The graph shows blood pressure variations during the perioperative period. Before the tumor excision, there was hypertension for which nitroglycerin infusion was treated according to blood pressure response at a rate of 0.5 to 1.5 mg per kg per minute. And during the tumor dissection and following excision, there was profound hypotension for which dopamine and adrenaline was started. A single dose of steroid was supplemented, and intraoperative blood loss was around 1.5 liters, for which 2 pack cells and 2 fresh plasma was transfused. Following the surgery, elective post-op ventilation was done, and epidural infusion was continued. The patient was extubated after 2 hours in the surgical ICU. And discussion: extradural paragangliomas synthesis stored and secrete catecholamines. They usually present with headache, sweating, palpitation, and hypertension. These catecholamines poses serious life-threatening cardiovascular complications like hypertension, myocardial infarction, pulmonary edema, arrhythmias, and cardiomyopathy. The major anesthetic concerns include preoperative optimization of blood pressure, safe conduct of anesthesia, and attenuation of the stress response both during intubation and extubation for maintaining hemodynamic stability, supplementation of steroids, and monitoring glycemic status to provide balanced multimodal analgesia. In conclusion, non-functional retroperitoneal paragangliomas are a rare group of tumors which are difficult to diagnose due to their silent and asymptomatic behavior. They are often misdiagnosed as GIST. Adequate preoperative workup and specialist opinions needed before surgery. And a multidisciplinary approach is suggested for the better outcome of the procedure. Thank you.
Good evening. My presentation topic is anesthetic management of a patient with Noonan syndrome undergoing emergency LSCS. Noonan syndrome is an autosomal dominant disorder representing the phenotype of Turner syndrome. The incidence is 1 in 1,000 to 1 in 2,500. It has a typical characteristic features of facial, cardiovascular, musculoskeletal, and developmental abnormalities. The challenges we may face during anesthesia may be due to congenital heart abnormalities, hemostatic disorders, and the airway abnormalities. We reported a case of 28 years old female, gravida 3 para to death 2 with 36.2 weeks of gestation, posted for emergency cesarean section in view of abnormal fetal Doppler findings. Though the patient was asymptomatic, during pre-anesthetic evaluation, she had a typical syndromic feature like short stature, hypertelorism, low set ears, down-slanting eyes with webbed neck. Her airway examination revealed mouth opening of 2 fingers with Mallampati grade 4 and thyromental distance of 5 cm. Her cardiopulmonary and spinal examination were essentially normal. Complete hemogram with platelet count and coagulation profile were also within normal limits. Her echocardiographic features showed mild pulmonary valve stenosis with normal biventricular function. Considering the anticipated complication of difficult airway with no significant spinal and congenital cardiac abnormalities, keeping the difficult airway cart ready, the surgery was conducted under regional anesthesia with adequate preparedness for the anticipated complications and close monitoring of hemodynamic parameters. The perioperative period was managed successfully without any adverse events. Several studies have reported difficult intubation in case of Noonan syndrome because of its limited mouth opening, web neck, with spinal and other craniofacial abnormalities. These patients also have pulmonary valve stenosis with other heart diseases such as hypertrophic obstructive cardiomyopathy, atrial septal defect, ventricular septal defect, and patent ductus arteriosus. These patients may also have hemostatic disorders as well. All these factors affect the decisions regarding the anesthetic management of these patients. Since our patient was posted for emergency procedure with facial abnormalities and insignificant cardiac and spinal abnormality with normal blood investigation, the surgery was planned to carry out under regional anesthesia. To conclude, though a rare clinical entity, thorough preoperative evaluation of a patient with unusual facial and skeletal abnormalities helps in early recognition and adequate preparedness of these patients to avoid anticipated anesthetic adverse events and to ensure a successful outcome. These are my references. Thank you.
Madam, please play Dr. Vamsi Krishnan's video, madam. This is Dr. Shubha Sundari video. Please play the previous video, ma'am. Ma'am, are you there, technical team?
Good evening. I am Dr. J. Vamsi Krishna, and the topic is opinion on anesthesiologist in medical practice before and after the COVID-19. Coming to introduction, I being an anesthesia postgraduate have noticed during my clinical postings during COVID-19 that the importance of anesthesiologist in managing emergencies has dramatically increased. Objectives: the study was done on population with different education levels to know pre-COVID and post-COVID change in opinion on anesthesiologist. Material and methods: 10 different kind of population have been selected based on their educational standards, ranging from uneducated people to surgeons. Each category consists of 30 members, and they were given same kind of questions, and the responses often were keenly analyzed. The questionnaire was about whether they know that there is specialist doctor for giving anesthesia during surgery, whether they know that anesthesiologist will taking care of patients before, during, and after the surgery, whether they met an anesthesiologist apart from the operations, and whether they know about the role of anesthesiologist in ICU's emergencies, and whether they have noticed that anesthesiologists have played a key role in frontline doctors during the COVID-19 pandemic. And do they still have the same opinion before and after the COVID-19? And the population selected were uneducated, non-graduated, graduated but non-medical, MBBS first year, second year, third year, final year, and internship completed people, and medical doctors as well as surgeons. And the responses given by them are tabulated, showing the comparison between pre-COVID and post-COVID opinion on anesthesiologists, ranging from perioperative to ICU to emergencies. And the result were plotted in a graph showing in x-axis, taking in x-axis different kind of population, and in y-axis different roles of anesthesiologists in clinical practice, ranging from perioperative, ICU to emergencies. The results: there is a dramatic change in public opinion on anesthesiologists, even in medical and surgical colleagues. But in fact, there is no change in certain groups, could be due to lack of awareness and lack of rapport between the anesthesiologist and them. Discussion: during COVID-19, anesthesiologists have been thrust to the front lines as we can take responsibility of our healthcare delivery and use our broad knowledge outside the operating room. This is not the first time an anesthesiologist being in the front line during pandemics. In the past also, our iconic anesthesiologist John Snow and John Ibsen have served the humanity during cholera and polio outbreaks in the past. Conclusion: the result of this study will help in the boosting of morale of upcoming anesthesiologists. And these are my references. Thank you.
I think it is over. No? Is it completed? Presentations? We can move on to the question and answer session. Yeah, we can move on to the question and answer session. First, I think Rubin.
Yes, sir. Good evening, sir.
Right. You have presented a case of WPW syndrome.
WPW.
How will you treat paroxysmal? You said one of the complications is PSVT, paroxysmal supraventricular tachycardia. How will you treat it?
So, supraventricular tachycardia, it can be treated by giving adenosine. The another option is what we can do is like we can give lignocaine, and esmolol can also be given. Esmolol, if it has to be given, it has to be given of a range of like a 50 to 300 microgram per kilogram per minute over 1 minute. And adenosine, if it has to be given, it has to be given at a dose of 6 mg, slowly followed by a flush of 20 ml NS. Then we have to see the rhythm and see if it has to be repeated again.
It will be repeated in the same dose or escalated dose?
It should be repeated in a 12 mg, sir.
Okay. Thank you.
Next, Dr. Abhinav Kumar.
Yes, sir.
We have presented a case of what is the SJ syndrome?
Sir, Steven Johnson syndrome, sir.
Steven Johnson
This is
syndrome. Okay. What is you said the main issue during the intraoperative period is one of the main issue is hypovolemia, right?
Yes, sir.
Can it be there? Then which is the induction agent you have chosen?
Sir, we have chosen propofol, sir.
What about propofol when you suspect or when the patient is already having some intravascular volume deficit or something?
Sir, the
was
patient
your patient stable preoperatively?
The patient was referred from other centers. Patient was hemodynamically stable when we received it, sir. We received the girl. So we planned to go on with propofol, sir, instead of ketamine. Ideally, ketamine would have been the choice, sir. But since the patient was already stable, we went for propofol, sir.
Okay.
I will ask one question, this Abhinandan Kumar. What is the dose of midazolam you said? You said 0.5 milligram. Am I right?
Yes, sir.
What is the age of the patient and what is your dose? You said?
Sir, 14-year-old girl, sir.
What is the dose? 0.5 milligram. Will it act?
No, sir. It is we have given many minimal dose, sir. We have given fentanyl, sir.
No, midazolam. Sorry, he's asking about midazolam.
I'm asking about midazolam. Anyway, next person.
Yeah, we can move to next person.
Vishnu Priyankan, Dr. Vishnu Priyankan.
Good evening, sir.
Yeah, good evening, Vishnu. You have presented a case of retroperitoneal paraganglioma, no?
Yes, sir.
Was your patient optimized before taking up for surgery?
Yes, sir. We started on prazosin and propranolol, sir.
Okay. What was the HB of the patient? You said patient was HB was how much?
7.1.
Yeah. Was it okay for that patient?
Sir, we transfused before 2 units before taking for surgery, sir. 2 PRBCs.
No, but still, if the HB is 7.1 before surgery, and this is a big tumor.
Yes, sir.
Is it okay?
No, sir. We have to improve the hemoglobin and take up for surgery, sir.
Yeah. And what precautions you have taken in case of there will be massive blood loss? How many units of were kept ready for blood transfusion for intraoperative?
4 PRBCs and 4 FFPs and 4 platelets were kept ready, sir. 2 PRBCs transfused and 2 FFPs were transfused, sir.
Okay. Can move on to the. Sir, you want to ask some question?
No. Vamsi Krishnan.
Dr. Vamsi Krishnan.
Yes, sir. Good evening, sir. Good evening, all, sir.
Good evening, Vamsi Krishnan.
Sir.
Thanks for. First, I want to congratulate the whole team of your college for doing this study because it is very important. Now everybody is talking about anesthesiologists, even the public also in our place. In fact, we are managing completely ICU, COVID ICU.
Yes, sir. Thank you, sir.
So, in nutshell, what was your conclusion?
Sir, COVID-19 has its own impact on public opinion, sir, definitely. But still, in certain populations like uneducated and some lower standards level people cannot differentiate the person who are staying in the operation theater. They are thinking that all the people are belonging to surgery only, and particular doctor will treat them, and the more total effort goes to the surgeon only, sir. But when we
what about the improvement in the opinion in educated public, educated general public? Was there any improvement in the opinion about the anesthetist or recognition about the anesthetist?
Sir, definitely, sir.
How much is the improvement as per your study?
So it's in lower standard educated level people are just trying to improve, sir. But
educated,
sir,
in educated public,
in educated there is definite changes in the opinion pre-COVID to post-COVID, sir. As one of their relatives are admitted in ICUs, they met commonly the intensivist, and they came to know that the intensivist only treated their patients, sir.
Nice idea, innovation. It is only an innovation. You have asked any medical students, sir?
Yes, sir. Yes,
medical
sir.
students included?
Yes, sir. I included MBBS first year to final year, sir. As first years are only pre-clinics, they didn't expose to the hospitals. And second years who are only paraclinicals, they only limited to the pathology, microbiologies only. And the third years who are just entered into the ENT and ophthalmic operation theaters, and I take final years also, sir.
Which year you have included?
All the 4 years are I have included, sir.
And what about the first year students? What about the first year students in pre-COVID and post-COVID?
Sir, there is no gross change, sir, but there is some change, sir. They don't know that emergencies are already, but they know that ICUs are employed by anesthesiologists, sir. But in emergencies, all they didn't yet know, sir.
Thank you, coordinator, hall coordinator, Dr. Yoga Satya.
Sir, thank you,
No,
sir.
no, one more person.
So one more person is there, sir. One
Shubha
more
Sundari.
person. Dr. Shubha Sundari, sir.
Yeah, last.
Yes, sir. Yes, sir. Noonan syndrome. Dr. Shubha Sundari.
Dr. Shubha Sundari, are you online?
Yeah. Yes.
Good evening,
Yeah.
sir.
Good evening. You said in Noonan syndrome, difficult intubation is one of the problems.
Yes.
And you have selected a regional technique. It's okay. But in the event of it will be anticipated difficulty during the airway management. What care did you take to overcome this problem? Or how you were prepared to manage this situation?
Sir, we kept extra large blades and McCoy blades, Bugy, Stillet, and we have even made ready for fiber optic intubation was kept ready.
Okay. Patient is in the middle of the surgery and
Okay,
the
sir.
patient is having some problem with, I think your level of blockade was inadequate. You need to induce the patient. You have to convert the patient to GA. So how you would manage with that type?
Sir, first I'll call for help. I'll ask my seniors, like my professors, to be present since it is an anticipated difficult airway. And
So one thing is you have to be well prepared to manage the situation. Giving a regional technique and without a proper preparation to manage a difficult intubation in the event of you may have to induce the patient in the middle of the surgery. You have to be ready for that, adequately prepared. Then only you can take up this patient for surgery.
Right, sir.
Right?
Yes, sir.
Right. Okay. Thank you.
Thank you, sir.
Now we can thank Dr. Srinivas and Dr. Yoga Satya. Fine.
Thank you.
Thank you, sir.
Thank you for your valuable time, sir. Thank you, sir. Thanks a lot.
Thank you, ALM sir, Srinivas sir.
Thank you.
Sorry, I hurried up you. Thank you so much, sir.
We will hand over to Dr. Gunala.
Yes, sir. Dr. Gunalan, sir.
Good evening.
Yeah, I think SAR will mail you the marks.
Yes, we will send
Okay,
it
sir.
immediately. Yeah.
Right, sir. We can double it.
Participate in one Tamil seminar, so I will send it at 8:30. Okay.
So we know you are a poet. Okay, sir. All the best. Thank you, sir.
Thank you.
Thank you, all the coordinators. Thanks for giving me this opportunity.
Thank you, sir.
Good evening. So good evening, Kumar sir.
Good evening. Move on to the next session. We are running late.
Yes, sir. Good evening. This is the last session for the e-poster presentation. I welcome the judges, Dr. Parthasarathi sir, who is the professor in Mahatma Gandhi Medical College and Pondicherry, and Dr. Pradeep Dongre is assistant professor in ESA Medical College, Bangalore. As we are running out of time, shall we move to the session, sir?
Yeah, sure. We should go ahead.
Technical team, can we play the video?
Good evening, everyone. Today, my case presentation is about renal artery transplantation in a patient with tracheostomy and its anesthetic management. Introduction. Tracheostomy is a large vessel vasculitis that primarily affects the aorta and its primary branches. This disease is characterized by granulomatous inflammation of vessel wall, and involvement of renal artery is common in tracheostomy. Incidence is 2.6 cases per million per year. This case report presents anesthetic management of patient with tracheostomy with uncontrolled hypertension posted for left renal artery transplantation. Case report. A 18-year-old female patient of weight 55 kg and presented with uncontrolled hypertension 230 by 120 millimeters of mercury because of renal artery stenosis. Patient is on medication like antiplatelets tablet ecosprin AV 75 mg, antihypertensive tablet Metexel 50 mg, tablet Alma 80 mg, tablet amlodipine 5 mg, tablet Arcomin 100 mg, tablet Presopris 2.5 mg, tablet Kenacort 4 mg. Patient underwent angiography by radial route showing bilateral renal artery stenosis. Renal angiogram showing right renal artery stenosed for a length of 8.8 millimeters from origin and left renal artery stenosed for a length of 4.8 millimeters. The stenotic segment is seen 2 millimeters away from origin. Anesthetic management. In view of uncontrolled hypertension, patient is posted for left renal artery transplantation. Goals of anesthetic management: to avoid hypotension or hypertension, to avoid stress response, to maintain urine output, to maintain normothermia or normocarbia. Management. Anesthetic management of patient with combined general and epidural anesthesia. Standard ASC monitors like pulse oximeter, non-invasive blood pressure, ECG, ETCO2 temperature are applied. Maintenance with CO fluorine 1 mg. Maintenance with injection cisatracurum infusion 1 to 2 micrograms per kg per minute. Analgesia is maintained with epidural infusion of 0.125% levoanavin and injection fentanyl. Urine output charting done hourly. Mean arterial pressure maintained above 110 millimeters of mercury. DTCO2 maintained between 35 to 45 millimeters of mercury. Patient extubated after adequate, regular, and spontaneous ventilation. Epidural infusion with 0.0625% levoanavin at the rate of 10 ml per hour for post-op analgesia. Surgery. During surgery, external iliac vein identified and dissected, internal iliac vein dissected and branches ligated. Kidney perfused and placed in left retroperitoneum. Left external iliac vein anastomosed to left renal vein by end-to-side anastomosis and left renal artery anastomosed to left internal iliac artery by end-to-end anastomosis. Results. Intraoperative period was maintained with normocapnia, normothermia, euvolemia with adequate depth of anesthesia. Surgery was uneventful. Patient outcome was good and smoothly extubated and shifted to ICU for further management. Patient is reviewed after 2 weeks and BP is 130 by 90 millimeters of mercury. Conclusions. Anesthetizing a patient with tracheostomy for renal artery transplantation is a challenge due to various pathological and hemodynamic changes involved. Successful outcome depends on pre-optimization, intraoperative maintenance of stable hemodynamics, invasive monitoring during perioperative period.
Epoch of robotic assisted surgery, anesthetic challenges in robotic assisted radical prostatectomy, a case report. Over 2 decades, the application of robotics in urological surgeries have increased enormously. Aim of this case report is to provide a brief background of the application of robotics in prostatectomy and its important implication for anesthesiologists. A 65-year-old male diabetic, chronic smoker, and obesity of class 1 presented with lower urinary tract symptoms of mild obstruction and decreased urinary flow. Further investigation revealed carcinoma of prostate necessitating its removal, and robotic assisted surgery was planned. Patient was assessed under ASA3. Preoperatively, patient was assessed for obstructive sleep apnea, restrictive airway distress, and difficult airway. Cessation of smoking was advised. Prophylaxis was given for anxiety, aspiration, infection, and deep vein thrombosis. Minimal starvation and oral carbohydrate was ensured. Once the patient entered the operation theatre, monitors such as ECG, blood pressure, and pulse oximeter were attached. Injection dexmedetomidine infusion was started at a rate of 1 microgram per kg for 20 minutes. Patient was induced with injection fentanyl 100 microgram, propofol 150 mg, and atrakirum 40 mg. Patient was intubated with 8.5 EPQ and fixed. Dexmedetomidine infusion was reduced to 0.3 microgram per kg and started with injection atrakirum infusion of 0.1 microgram per kg for continuous neuromuscular relaxant. Now, the patient was positioned in steep Trendelenburg position, which led to many complications. Increase in intra-abdominal pressure, which in turn leads to increase in mean arterial pressure, systemic vascular resistance, and mild decrease in cardiac output. Elevated diaphragm and pushing of the abdominal content upwards cause decreased lung compliance, decreased FRC, atelectasis, and hypercapnia. Reflex increase in vagal tone caused by peritoneal stretch. Central nervous system, it causes increased cerebral flow and increased ICP. Peripheral nerve injury is more common, most commonly brachial plexus nerve. Limb compartment syndrome is more common due to reduced limb perfusion. Deep vein thrombosis is due to increased abdominal pressure, which in turn decreases the venous return and increased venous stasis. In ocular changes, corneal and conjunctival edema is more common. Unrestricted fluid therapy leads to facial neck edema and airway edema. Gas-related complications such as venous gas embolism is very hazardous. Post-op patient was extubated after facial and neck edema assessment, and for airway edema, complete test was done. Post-operative period, strict post-operative nausea, vomiting prophylaxis was given, and adequate analgesia was ensured. Post-operatively, atelectasis was treated by early mobilization, breathing exercise, and incidental spirometry. Early nutrition helped in preventing paralytic ileus. Early removal of all drains were ensured. Patient was shifted to ward on post-operative day 1 and discharged on post-operative day 2. Day 3. Understanding the pathophysiological changes and complication in robotic-assisted surgeries improves management of these patients and reduce the mortality and morbidity. Thank you.
Next, Dr. Revati.
Good morning to all. I am presenting a case of symptomatic COVID positive patient undergoing emergency laparotomy. A COVID-19 is an emerging infectious disease caused by novel coronavirus that invades type 2 pulmonary alveolar epithelial cells, causes cytokine storm, leads to diffuse alveolar damage with resulting ARDS. A 38-year-old male patient taken up for emergency laparotomy for small bowel gangrene, for which emergency laparostomy was done under combined epidural and general anesthesia. And POD2 patient was diagnosed to be COVID positive with CT chest shows less than 25% of ground glass opacity involvement. On first laparotomy, CT chest was normal. This patient taken up for emergency re-laparotomy under combined epidural and general anesthesia. On investigation, lymphocytopenia with urea 50 serum creatinine, one with chest X-ray bilateral pulmonary infiltrates present. On pre-op, patient saturation was 86% with 10 liter oxygen, and via breathing mask and respiratory 20 p per minute, and bilateral capitations present. We took all personal protective measures and pre-medicate the patient with injection glycopyrrolic 0.2 mg, injection midazolam 1 mg, and injection fentanyl 100 microgram. Induction with the RSA, propofol, and Saxa. And DL-scopy was done, and intubation with 8.5 mm clamped cup to ET tube fixed at 21 centimeters. Circuit has been connected to ET tube, and unclamping of ET tube and position checked by auscultation. Maintenance with nitrous oxygen sevoflurane and epidural analgesia with bupivacaine. Intravital stable and intra medication injection hydrocortisone 100 mg and dexamethasone 8 mg IV given. Intra finding was gangrenous bubble and resection of gangrenous bubble with double parazystostomy and laparotomy closure was done. Patient was reversed after adequate spontaneous respiratory efforts and extubated after taking all personal protective measures. Post-op patient conscious oriented and saturation was 90% with closed mask and bilateral crepitation present. Respiratory rate 22 per minute. Patient was shifted to COVID ICU and connected to non-invasive ventilation. On POD2, changed to non-free breathing mask with 8 liter oxygen. On POD3, patient was maintained saturation in room air. Patient was intubated with RSC technique since patient with poor lung complaints and less time to exposure to COVID aerosols. We extubate the patient in view of adequate respiratory efforts and age factor less than 25% ground glass opacity involvement. Conclusion: patient was extubated even though preoperative saturation was low, since management of COVID-19 is to improving the ventilation perfusion mismatch by means of high flow nasal oxygen and non-invasive ventilation. Intubation and mechanical ventilation has shown no improvement in patient outcome or no proven benefit. Thank you.
Next, Dr. Tejasvi.
Good morning, respected professors. My e-poster is on anesthetic management of a patient with ruptured abdominal aortic aneurysm posted for emergency surgery. Aneurysm is a dilation of all 3 layers of an artery with 50% increase in diameter compared with normal. A 63-year-old male patient presented to the casualty with complaints of abdominal pain and back pain of few hours duration. He's a smoker for 40 years. No other positive history was elicited. His baseline investigations such as CBC, RFT, LFT, chest X-ray, ECG, echo was found to be normal, except that his HP was 9.4 gram%. On CECT abdomen, infrarenal aorta demonstrated cyclar aneurysm measuring 3.2 cross 6.7, extending over a distance of 6.2 centimeters from L2 to L4 vertebra. Hypodense collection was noted surrounding the aneurysm extending up to bilateral psoas 9.1 cross 8 centimeter, which is the contained rupture. Patient was planned to be taken up for emergency aortobiliac bypass graft under epidural and general anesthesia. Patient was assessed under ASA PS 5E. Preoperatively, 2 18G IV cannulae were secured in both upper limbs. Right IJV cannulation was done with 7 French 3-lumen catheter for CVP monitoring. Right radial artery was cannulated for invasive BP monitoring. Blood and blood products were arranged and kept ready. Monitoring was done as per ASA guidelines. Along with it, CVP, IBP, and urine output were measured. Epidural catheter was placed at T11, T12 interface with tip in T8. During induction, patient might develop cardiovascular collapse due to the cardiodepressant effects of intravenous and inhalational drugs used, and also due to relaxation of the abdominal muscles, reducing tamponade effect. Hence, induction was done carefully with titrated doses. Under rapid sequence intubation, 8 mm cuffed endotracheal tube was inserted. Plane of anesthesia was maintained with sevoflurane and atracurium. Analgesia was given through epidural catheter. Cross-clamp time was 40 minutes. Increased afterload after cross-clamping was attenuated by administering vasodilators and increasing the depth of anesthesia. Balanced administration of crystalloids, colloid, and blood, along with vigilant intraoperative monitoring, prevented hypotension post-unclamping the aorta. Patient was not extubated on table and was shifted to ICU for elective post-op ventilation. After 24 hours, patient was successfully weaned from the ventilator with stable hemodynamics. Thank you.
Next, Dr. Iluri Surya.
Good morning. My poster case is on challenges in managing a deaf-mute patient for emergency surgery complicated by COVID-19 pandemic, goiter, diabetes mellitus, hypertension, and abnormal sonographical anatomy of brachial plexus. Coming to introduction, WHO considered there are 278 million people with hearing impairment, and in India there are 18 million individuals are there. Handling congenitally deaf and mute patients is a challenge for majority of Indian hospitals due to lack of sign language interpreter and a lack of basic training in sign language in Indian schools. This case was done during COVID pandemic at our hospital, when a majority way of communication with the deaf patients is in form of lip reading was out of question, as all anesthetists were sticking to PPE protocol. Our patient, in addition to being deaf, a multiple comorbidities like diabetes, goiter, hypertension. The management was further complicated by abnormal sonographical anatomy of brachial plexus. Coming to case report, a 69-year female presented to casualty with a fall from bike. She had suffered elbow dislocation with fractured radial head. For this, she underwent emergency radial head excision. During the pre-anesthetic checkup, we encountered multiple issues. She was apprehensive due to severe pain and a visible goiter. Since we don't have any recent thyroid profile report in emergency nature of surgery, only basic test was ordered. Plan A was to provide sole anesthesia with brachial plexus blocked by supraclavicular approach. General anesthesia with endotracheal intubation was kept as backup plan with a difficult airway cart reserved in case of failure to secure adequate analgesia by brachial plexus alone. Inside operation theater, during scanning of supraclavicular space, we encountered an artery lying below the brachial plexus running parallel to the first rib. This made the placement of brachial plexus block tricky due to risk of puncturing the artery sitting just below the nerve bundles. Presence of short neck, goiter, and pain, we decided to place the block slightly higher above to avoid the risk of arterial puncture. After block was placed, it was difficult to get correct response from the patient. She was not able to communicate with us regarding her pain relief. Objective test with pinprick give us a clue towards adequate analgesia, but patient was too apprehensive due to lack of communication with anesthesiologist. Coming to conclusion, with this case report, we want to highlight that even though our patient has a multiple comorbidities, adequate anesthesiologist is usually trained well enough to handle with her. In this case, we as anesthesia providers felt more disabled than our patient herself due to lack of communication with her. We would suggest all hospitals to have at least one sign language interpreter to significantly improve the basic patient-doctor coordination. As a society, as we need to little more empathy towards the disabled individuals. A basic sign language course can be implemented in schools itself to have adequately trained professionals in all fields. Thank you.
Thank you. Now we move on for the question session, sir.
Yeah. Can I know the name of the doctor who presented the case report on Takayasu arthritis?
Sir, and Dr. Lahari, sir.
Am I audible?
Yes, sir.
Am I audible?
Yes, sir.
Excuse me.
Yes, sir, you are audible, sir.
Am I audible?
Yes, sir, you are audible.
Pradeep, audible. Hello? Am I audible?
Yes, sir, you are audible, sir.
Okay,
yes,
Lahari, did
sir,
you
good evening,
use
sir.
steroids pre-operatively?
Yes,
Was
sir.
there patient was getting steroids?
Yes, sir.
Was the patient getting steroids? What was your proposal on intra-op steroids? Not written?
Sir, we are given injection hydrocortisone 100 mg intraoperatively, sir.
Okay, what is the protocol? What is the protocol of pre-op? That is enough? Is that enough?
Yes, sir.
Over to Pradeep. Pradeep is not there.
Yes, sir. He's not disconnected.
He's got disconnected. Okay. Next.
Next participant, Dr. Aruna.
Good evening, sir.
Aruna, proceed. Robotic. So you
Yes, sir.
said obstructive sleep apnea syndrome and restrictive lung disease. How come you come to a diagnosis of restrictive lung disease in this case?
So these were my preoperative considerations. The patient didn't have restrictive airway disease, sir. But
Okay.
these were my considerations. So I checked for the restrictive airway disease, sleep apnea, and yes, sir. These were my considerations, sir.
Okay. Did you monitor ETCO2?
Yes, sir.
It was not mentioned. Did you apply PEEP? What is the role of PEEP on induction?
The role of induction PEEP is it helps in.
Have you done or not done?
Yes, sir. Done, sir.
But it's not written. Is it
I
important or not?
Yes, sir. It is important, sir, to prevent the collapse of the
Okay, next.
basal alveoli.
Next, Revati.
Good evening, sir.
Can I move on to Revati?
Yes, sir. Please.
Yes, sir.
Pradeep has come.
Yes, sir.
Pradeep. Okay. Revati, you have used NRBM.
Yes, sir.
How much F5O2 you will get with NRBM?
Maximum up to 90%, 80%, sir.
You have now given three answers.
18, sir.
100, 90, and 80.
80%.
Okay, you have given both hydrocortisone and dexamethasone. Where do you want to use both? You have given both hydrocortisone and dexamethasone.
Yes,
that is what written in the poster. Why do you want to use both? What was your topic?
Sir, COVID positive patient undergone emergency relaparotomy, sir.
Okay, what is your consideration intra-op? What is your consideration? Did you use intra-op PEEP? What is your consideration
Yes,
intra-op?
7 centimeters of high PEEP with minimal tidal volume, sir.
You have written?
6 ml per kg.
You have written that?
Sir?
You have written in the poster?
Yes, sir. Yes, sir. Written, sir. Yes, sir.
Written in the
but
poster.
not.
You have written in the poster or not? Not means no. Okay.
Yes, sir.
Tejashree.
Thank you, sir.
Tejashree.
Dr. Tejashree, are you there?
Tejashree, are you on the line? Unmute you. Unmute.
Is Dr. Tejashree online?
Yes,
Am
sir.
I
Good
audible
evening,
now?
sir. Yes, sir.
Pradeep is there? Pradeep has come proceed, sir. Pradeep, proceed.
Good evening, sir.
Yes, sir. Yes, sir. I'm back. Sorry for the connectivity issues.
No problem.
Yeah.
Because of the lack of time, I have finished 3, sir. Sorry.
Yes, sir. Yes, sir. It's better, sir. It's better.
It's better. Okay.
Yeah.
You carry on with the ruptured aortic aneurysm.
Okay. Yeah. The ruptured aneurysm. Intraoperatively, what difficulties did you face?
Sir, post cross clamping, there was hypertension, sir.
Okay. Severe hypertension.
Yes, sir, which was managed with nitroglycerin, sir.
Okay. Managed it.
Then following unclapping, there was to prevent hypotension, we had initially started the patient on dopamine, sir.
Wi-Fi password hakuna.
Pradeep? Pradeep is gone again. See, Tejashree, you have written pulse rate of 70 per minute and a BP of 120/70. Ruptured aortic aneurysm will be like that?
Sorry,
pulse
sir?
rate of 70. You have written, what is your pre-op pulse rate?
70, sir. The patient was hemodynamically stable, sir.
How much was there in the rupture? Nothing is there. No rupture.
It was a retroperitoneal rupture.
What was the clinical finding intra-op?
So intra-op, there was a retroperitoneal contained
there any
rupture,
blood?
sir. Yes, sir.
No blood.
Retroperitoneal
Okay, Pradeep,
contained hematoma
unmute
was
you.
present, sir.
Pradeep.
Sir, shall we move on to next participant?
Let's move on to next. Next, Pradeep.
Move on to next, sir. Move on to
Dr. Surya.
next.
Dr. Surya.
Yeah. Just as it was a deaf mute patient. Why did you choose brachial plexus block? You could have chosen. General anesthesia with a block, right? Why did you choose specifically a brachial plexus block alone?
Sir, because we couldn't communicate with her, that's why we initially chose supraclavicular block, sir.
Communicating with her, how do you explain a supraclavicular block to her? Isn't it even more difficult? Actually, don't you think general anesthesia would have been a better option? You could have always given analgesia. You had an ultrasound. You could have always given analgesia with a brachial plexus block, right? Don't you think so?
First of all, my thought is giving supraclavicular block. Later, if it is failed, we will move on to general anesthesia with difficult airway cart ready, sir.
No, that's what I'm trying to ask you. If tomorrow you are given a choice whether to prefer brachial plexus block for a patient whom you could not communicate to and general anesthesia, which would you choose?
I will take general anesthesia, sir.
Okay, fine.
And next.
Next session is a video session. It's Dr. Keerthana.
Yes.
Kindly play Dr. Keerthana's
I'm Dr.
session.
Keerthana, second year DMB anesthesiology, presenting a case of emergency laparoscopic cholecystectomy with ERCP in a morbidly obese patient with dilated cardiomyopathy and severe LV dysfunction. Anesthesia to a patient with dilated cardiomyopathy is always a challenge to anesthesiologists as they most commonly progress to cardiac failure. In a morbidly obese patient with dilated cardiomyopathy with LV dysfunction present for emergency surgery, it is a nightmare for any anesthesiologist. Here we report a 30-year-old male who is morbidly obese with BMI of 58.5, presented with abdominal pain for 3 days. He is a known case of hypertension, dilated cardiomyopathy with severe LV dysfunction on medical management for the past 1 month. He had elevated liver enzymes and renal function and decreased urine output. The CT showed CVD calculus with acute calculus cholecystitis. It was planned for ERCP with a lab or open cholecystectomy. Cardiologist and nephrologist opinions were obtained and a high-risk informed consent was taken in view of his comorbidities. Procedure was planned under general anesthesia and invasive lines. He had airway difficulty and was accepted under ASA 4E. Radial artery was cannulated before induction and anesthesia induction was performed in supine end-up position using fentanyl, propofol and anticoagulant. He was intubated using a McCoy blade and anesthesia was maintained with distributed and air oxygen mixture. ERCP was planned in lateral position. On positioning, the patient developed severe hypotension and desaturated. Hence, he was turned to supine position and was started on infusion noradrenaline. ERCP in supine position was technically very challenging, so we decided to tilt the table to the left after securing the patient with multiple beds and start standing by the side. ERCP was completed after 3 hours following considerable difficulty. Laparoscopic cholecystectomy was done with the end-up position. It was a challenging procedure for the surgeon as well, as the instruments were not of sufficient length due to its morbid obesity. Patient was extubated after undergoing 5 hours of general anesthesia without any major complications and was transferred to PACU after extubation. Post-operative oxygenation and hemodynamics were stable. He was monitored with utmost caution for any delay effect of anesthesia and surgery. Patient was monitored in SDU for the next 24 hours. This AKI gradually resolved and was discharged home on post-op day 5 without further incidents. Patient under ASA 4E who is morbid, obese with dilated cardiomyopathy and severe LV dysfunction are a challenge to any attending anesthesiologist. These patients can be well managed by thorough preoperative assessment and multidisciplinary management, formulating a good anesthetic plan and prompt diagnosis and management of ongoing issues and complications. Thank you.
Thank you. Next, Dr. TNISA.
This poster presentation is regarding anesthetic management of arthrogryposis multiplex congenita patient with scrotal abdomen posted for elective laparotomy and proceed. Arthrogryposis multiplex congenita is a rare non-progressive congenital syndrome characterized by contractures of several joints in different parts of body due to fibrosis of affected muscle or thickening of periarticular capsular tissue with an intact sensory and a normal intellect. There are three types. Type 1 primarily involving the extremities being a less severe form, whereas the type 3 most severe form is associated with CNS dysfunction. Etiology is multifactorial. Anesthetic concerns of this disease includes in difficult airway due to associated micropnea, cleft palate, cervical instability. There is an increased risk of malignant hyperthermia, myopathy resulting in increased sensitivity and a prolonged duration of neuromuscular blockers, high risk of postoperative respiratory depression and increased risk of aspiration, difficulty in regional anesthetic techniques due to anatomical variations, difficult IV access due to thick skin and contractions, difficulty in positioning due to contractions. This case presentation is regarding a 20-year-old male with a normal size thorax and a greatly reduced limb length confined to wheelchair who was planned for an elective laparotomy in view of a massive scrotal swelling of 40 cross 30 centimeter. Preoperative assessment revealed him as a case of arthrogryposis multiplex congenita from history. Routine preoperative investigations, including pulmonary function test, was normal. Airway examination revealed a Mallampati grade 2 with a short neck with normal dentition and adequate neck movements. Patient was planned for an elective surgery after 2 weeks of regular incentive spirometry. On the day of surgery, difficult intubation cart was kept ready. New respiratory circuits along with fresh soda lime was used. Oxygen flush was done for 10 minutes to avoid triggers of malignant hyperthermia. Standard monitoring with special emphasis to temperature and EtCO2 was 10. We encountered a difficulty in securing a peripheral IV line, hence right internal jugular vein was cannulated under USG guidance. After routine premedication, patient was induced with propofol 120 mg IV. After ensuring no difficulty in mask ventilation, patient was paralyzed with injection becuronium 5 mg IV. Patient was intubated in the first attempt. During laryngoscopy, karmic Lehen grade was 2. Maintenance was with nitrous oxide. Inhalational agents were not used. Intraoperative period was uneventful. Tab block was performed at the end of the procedure to supplement postoperative analgesia. In view of a massive scrotal abdomen, patient was planned for an elective mechanical ventilation. Patient was sedated but not paralyzed. In immediate postoperative period, patient was successfully weaned and extubated on first postoperative day. Just physiotherapy, including spirometry and mucolytics, were continued. Patient developed no respiratory complications postoperatively on 14-day follow-up. Though arthrogryposis multiplex congenita is a rare entity, it becomes highly challenging to select the mode of anesthesia since each modality has its own pros and cons. Ideal mode of anesthesia in a patient with arthrogryposis multiplex congenita is patient-specific and disease-specific. Understanding pathophysiology along with a proper preoperative evaluation and planning helps in good outcome. Thank you.
Next, Dr. Lavanya. Technical team, can you play Dr. Lavanya's?
Hello. She has not sent, Lavanya is not there. She has not sent a video. Next to Nancy.
Yes, okay. Dr. Nancy. Yeah, please play.
Good evening, all. I'm Dr. Nancy and I'm going to present a case of anesthetic management of an instantly detected case of congenital methemoglobinemia in a child. Methemoglobinemia is a condition in which heme ion is oxidized, changing from ferrous, that is Fe2+, to ferric, that is Fe3+4. This is a case of a 4-year-old child with known history of cleft tip and cleft palate, now posted for pharyngeal flap surgery. His previous history was uneventful except for 2 surgeries, that is lip repair and paratoplasty done at the age of 4 months and 9 months in our hospital. As regarding his family history, he was born out of a 3rd-degree consanguineous marriage. On examination findings were normal, except for a low SpO2 of 88 to 90% in Omer with pulse oximeter, which was not improving significantly with the oxygen supplementation. So, in a view of this unexplained low SpO2, we have retrospectively investigated his previous records, which was also showing similar SpO2 recordings, for which a cardiorespiratory evaluation was done at that time. This was also normal, and they have proceeded with the surgery. This time, we have taken an arterial blood gas analysis, which was showing methemoglobin level of 34.7 in presence of other normal parameters. In view of this history of consanguineous marriage and persistently low SpO2 levels and elevated methemoglobin levels, we have provisionally diagnosed this case as congenital methemoglobinemia, and we have proceeded with avoidance of precipitating factors such as inhalation nitrous oxide and local anesthetic. local anesthetics. So methylene blue was kept ready in the operation theater, and 100% oxygen was given throughout the procedure with avoiding nitrous oxide during intraoperatively. So for the monitoring of such cases, co-oximetry should be available, but we were not having co-oximetry in our operation theater. Other modalities of management include vitamin C and XL transfusion, which were also not given for this case. After incision, we have found out that the boy was having chocolate brown colored blood, which was also supportive of our diagnosis. Coming to discussion, hemoglobin is normally converted into methemoglobin in our body in presence of any oxidative stress or any free radicals, or normally during physiological conversion of oxyhemoglobin to deoxyhemoglobin. This methemoglobin will be converted back into hemoglobin in presence of cytochrome B5 reductase enzyme, during which oxidized cytochrome B5 will be converted to reduced cytochrome B5. So deficiency of this enzyme or cytochrome B5 will lead to congenital methemoglobinemia, or it can be due to the presence of hemoglobin M. Other causes of methemoglobinemia can be exposure to dapsone, antimalarials, topical anesthetics, inhaled nitrous oxide, nitric oxide, etc., and nitrates and lindite. The child was stable throughout the procedure, and after procedure, child was extubated and eventually. And from this case, we can conclude that proper entry and maintenance of records made this uncommon diagnosis easy. And this was also showing the value of routine pulse oximetry as a cheap, non-invasive, and readily available monitor for the detection of subclinical hypoxia. No, SpO2 readings are not a contraindication for anesthesia or surgery unless the patient is symptomatic. Finally, we can conclude that a good preoperative evaluation is the keystone for safe anesthesia. Thank you.
Next, Dr. Niranjan.
Good evening, everyone. I'm here to present a case report of hemophilia A with shaft of humerus fracture, posted for realignment and skin grafting. Introduction. Hemophilia is an X-linked recessive disease caused by factor VIII deficiency, predominantly affecting males. All patients with hemophilia A, regardless of severity of disease, are at increased risk of bleeding during surgery. 25 years old male admitted with fracture shaft of humerus left. External fixator was done under ultrasound-guided left side supraclavicular block. Preoperative hemoglobin was 6 grams, appropriate blood transfusion was done, and hemoglobin improved to 10 grams. Patient was treated with 4 units of cryoprecipitate and factor VIII, 3,500 units stat, followed by factor VIII for 1 week. Later, factor VIII, 2,500 units stat, followed by 50% correction of factor VIII, following which factor VIII assay showed 173% of factor VIII. Patient was posted for elective surgery, and factor VIII 250 units IV infusion was given before and proceeded. Patient was pre-medicated with injection glycopyrrolate polymer 2 mg IV, injection fentanyl 150 micrograms IV, and induced with injection thiopentone 200 mg IV and injection succinylcholine 100 mg IV and sevoflurane vapors. Neuromuscular blockade was achieved with injection atracurium in titrated doses. Intraoperatively, blood loss was minimal, 200 ml, and urine output was 300 ml. Heart rate was around 90 to 115 minutes. Duration of surgery was around 1 hour, 40 minutes. After adequate respiratory attempts, patient was reversed and extubated. Patient had no postoperative complications. Follow-up was made to 4 weeks postoperatively. Discussion. Normal level of factor VIII 60 to 150%. APTT 23 to 31 seconds. Postoperatively, factor VIII should be continued till 2 weeks in order to prevent bleeding, which impedes wound healing. In case of bones and joint surgery, 4 to 6 weeks of replacement is needed. 50% of factor VIII level is needed for a patient undergoing surgery. Factor VIII transfusion, according to factor VIII activity, before surgery had reduced intraoperative bleeding complications in patients with hemophilia A. Half-life of factor VIII is 12 hours in adults and 6 hours in children. Thank you.
As Dr. Lavanya video is not received, we are moving to Dr. Pavitra. Next video.
Good evening all. I am Dr. Pavitra Dev, doing MD Anesthesiology in Mathur Medical College. I am here to present a poster on addition of dexamethasone to bupivacaine in ultrasound-guided femoropopliteal block and analysis of 10 cases. Various additives are used in peripheral nerve blocks to prolong the postoperative analgesia. One among the additives is dexamethasone. The aim of this study is to analyze the impact of adding dexamethasone to bupivacaine in femoropopliteal block. 100 patients undergoing lower limb surgery selected for this study. Under ultrasound guidance, femoral nerve identified 15 ml of 0.25% bupivacaine mixed with 4 mg of dexamethasone given after careful aspiration. Then popliteal nerve blocked with 15 ml of 0.25% bupivacaine mixed with 4 mg of dexamethasone. We collected the data consisting of total block time, needle visibility, success rate of the block, need for hydroresection, complications if any. Total duration of postoperative analgesia, average year of experience of operator. Results. By adding dexamethasone to bupivacaine in femoropopliteal block, increase the duration of postoperative analgesia by 7.1 plus or minus 0.76 hours. In the study, needle tip was not visualized in 2 patients. For them, hydrodissection done to block the nerve. Out of 10 cases, 1 block failed. Failure rate is 10%. There was no adverse events related to dexamethasone. Discussion. Dexamethasone suppresses the synthesis and secretion of inflammatory mediators, which prolongs the period of analgesia. It also inhibits ectopic neural discharge by directly acting on nerve membrane. It acts on glucocorticoid receptors, which increases the activity of inhibitory potassium channels and nociceptive C fibers. It also prevents the bupivacaine-induced reversible neurotoxicity and certain rebound hyperalgesia after the resolution of nerve block. Average duration of postoperative analgesia in this study is 7.1 plus or minus 0.76 hours. Since the average year of experience of operator between 6 months to 2 years, the failure rate is 10% occurred. Over a period of expertise, the failure rate will be reduced. Conclusion, addition of dexamethasone to bupivacaine significantly prolongs the duration of postoperative analgesia by 7.1 plus or minus 0.76 hours.
Thank you. So now we move on to the question session, sir. First, Dr. Keerthana.
Dr. Keerthana presented on obese patients coming for laparoscopic surgery, right? With LV dysfunction. Yeah. Dr. Keerthana, what was the post-operative oxygen delivery device you used?
No, actually,
You extubated the patient, right?
We extubated wide awake in sitting position, sir. Actually, the patient was not even desaturated after extubation. So normally we should have used CPAP, sir. But in this case, the patient was like maintaining saturation with 5 liters of O2 through face mask, sir.
Okay. Anytime during the post-operative period, later he required any kind of CPAP or anything like that?
No, sir. Not until he was in a hospital, sir. But we advised him to take on a CPAP.
Okay, fine. So he had OSA also?
Yes, sir. He had, sir.
He had OSA. But during your perioperative period, he didn't require oxygen at all?
No, sir. No, sir.
Okay, fine. Yeah. Okay, the next presenter.
Keerthana?
Yes, sir.
Keerthana?
Yes, sir.
What is the spelling of laparoscopic? What is the spelling of laparoscopy you put on the title? Okay. Next.
Next, Dr.
Next person.
Dr. Keerthana, yes.
Good evening, sir.
Yeah. Parthasarathi, sir, you can.
What is that? What is the
Sir,
anesthesia given in this case? Keerthana?
General anesthesia was given initially, sir. For post-operative analgesia, we gave a tab block, sir.
What is the general anesthesia? You have not used agent. You have not used dexmedetomidine. You have used only fentanyl. How the patient will get anesthetized? How the patient? This is simply relaxation. Simply you have relaxed the patient, which is good for the surgeon and the anesthetist. But for the patient,
so we have used a fentanyl.
You have not used agent. You have not used any. So there are enough doses you have given.
Only
the
muscle
patient
relaxant and nitrous oxide we have used, sir. Only nitrous oxide was used for maintenance, sir.
Is it enough to anesthetize? Is it enough to anesthetize? When you have not given any relational agent, do you? Okay, next one.
In fear of triggering.
Dr. Ninsi.
Keerthana, you are not audible.
Sir, in fear of triggering malignant hyperthermia, we did not use inhalational agents, sir.
Yes. Then you would have given some propofol infusion or some dexmed infusion or something else to get the patient anesthetized. Yes, okay, next.
Dr. Ninsi.
This
is Dr. Ninsi.
Next
sir.
person is?
Dr. Ninsi.
Dr. Ninsi, you presented a case of methemoglobinemia. Preoperatively, you did do an EBG. Did you do a repeat ABG in the intraoperative and postoperative periods?
No, we are not doing routinely. The patient was having unexplained low SpO2 values. So for evaluation only, we have done an ABG.
Okay. Intraoperatively, you did not monitor because you don't have a co-oximeter. You mentioned that you didn't have a co-oximeter, right?
Yes, sir. Yes, sir.
How long did the procedure last?
Around 45 minutes, sir.
Okay, it was a short procedure. Okay,
Yes, sir.
fine. Yeah.
Yes, sir.
Was it
That's it
done
from
in
my side.
Meenakshi Mission Madurai?
Yes,
Which
sir.
which hospital was it?
Meenakshi
Mission Madurai.
Yes, sir.
Yes, I know this. Okay, next person. I know the management of the case.
Okay, sir. Next person, we can go on.
Niranjan, sir.
Niranjan?
Yes, sir.
Niranjan?
Yes, sir.
Niranjan, what is the nerve block of choice for humorous?
Supraclavicular block, sir.
Is it? Okay, next question is, what is the target? You have put 173%. Is it okay? Do you want 173% to start surgery?
No, it's more than enough, sir. It's very high.
So when did you give actually? You have given, you said 1 week before you have given this factor 8.
Yes, sir.
When did you give? When is supposed to give factor 8? Okay, next.
The half-life of factor 8.
Pradeep. Carry on. Pradeep.
Yeah. Well, when do you say that, to add on to Dr. Parthasarthi's question, when do you say that the patient has a severe factor 8 deficiency? That is one thing. Second thing is, when do you administer factor 8, as Parthasarthi was asking?
Factor 8 half-life in adult was about 12 hours, sir. So we should be transmitting factor 8 12 hours before, sir.
Yeah, but then you gave it for a week. Why did you feel that you need to give it for a week? What was the initial percentage?
It was around 20%, sir.
Okay, fine. Okay, then do you think once, as sir said, I don't think 173% is required. You could have done away with a single dose of factor 8 preoperatively. Don't you think so?
Yeah, sir. It's more than enough.
Yeah. Okay.
Next.
We can go to the next. Yeah.
Dr. Pavitra.
Good evening, sir.
Good evening, Dr. Pavitra. I
Good
have
evening,
a question for you. What kind of, you kept mentioning that you did a study. What kind of a study was it?
Who is there to prompt you? You are looking someone else.
What kind of a study do you think you did? You just tell me what you thought you did. Let us discuss about it later.
Sir,
No, you gave dexamethasone as an adjuvant for femoral nerve block and popliteal nerve block, right?
yes, sir.
You had a single group and you used 4 milligrams dexamethasone at both sites, right? So what kind of study is it?
Sir, it analyzes only 10 cases only, sir. Randomly.
No, I agree. No, what I'm trying to assert here is you have used the word analysis of, but your study looks more like a descriptive study. If it is a study, you have done only 10 cases. I would present it more like a case series rather than a study. And even if it is a study, it is only a descriptive study. And when you say that you have done a descriptive study and you have added dexamethasone, how do you say that there is a prolongation in the duration of analgesia? You have given dexamethasone to all your 10 patients. Okay.
Yes, sir.
You
Yes, sir.
don't have a control group or a comparative group where you have given bupivacaine alone. So how can you say that there is a prolongation in the duration of analgesia? Don't you think it's wrong? Instead, you could have submitted your results by saying what was the actual mean duration of analgesia that was obtained.
Yes.
Yeah. That would have described the period of analgesia, and you could have said further studies, comparative studies are required to actually see whether dexamethasone is an active, is an available adjuvant. Further studies are required, right? Don't you think that would have been an appropriate conclusion for your case series of 10 cases, right?
Yes.
Okay. Sir, Parthasarathi sir, anything to add?
What is the type of surgery and what is the type of anesthesia given?
Sir, it's lower limb below knee surgery.
What is anesthesia given?
Sir,
What anesthesia was given?
ultrasound guided femoropopliteal block.
This only was the anesthetic technique.
Yes, sir.
No other GA or no other spinal was given.
Yes, sir.
What surgery
sir.
was done? Did they put tourniquet?
Below knee amputations. No, sir.
Anesthesia was only this.
Yes, sir.
No other anesthesia like spinal epidural, sedation, ketamine was given.
Yes, sir. No,
okay,
sir.
Next.
So next, we are
next.
Kindly play with Dr. Gokul Ram.
I thank Department of Anesthesiology, Stanley Medical College and TNISA for giving me the opportunity to present the e-poster on anesthetic management of a case of hand replantation under continuous supraclavicular block. A 39-year-old female with history of road traffic accident presented with a total crush amputation at mid 1/3 level of left forearm. The patient presented to the hospital within 2 hours. The severe limb was brought along with. After initial stabilization, on assessing, the patient was healthy otherwise, had no allergies and took no medication. The patient had eaten a solid meal just 3 hours prior. The vitals were normal and the saturation was normal. The patient was scheduled to transferred urgently to the operating room for debridement and reimplantation of the severe limb. The surgeons wanted to end-to-end repair, which was expected to last about 8 to 10 hours. The main anesthetic consideration was the patient was not fasting, hence had a very high risk for aspiration under general anesthesia. There was very limited time for preoperative optimization. Shingle short brachial plexus block would not last the duration of surgery. Microcatheter or specialized catheter for continuous regional block could not be procured within the given time. Hence, we chose the anesthetic management of ultrasound guided continuous supraclavicular block. The patient was shifted to the operating room under strict aseptic precaution using ultrasound guidance, using a 18 gauge standard IV cannula, 20 ml of local anesthetic mixture containing 10 ml of 0.5% bupivacaine and 10 ml of 2% lignocaine, which injection epinephrine 100 microgram was injected perineurally and around the brachial plexus. Finally, the 18 gauge IV cannula was placed near the proximity of the middle of the brachial plexus using ultrasound guidance, and the stillet was removed. The position of the tip was checked with injecting 2 ml of local anesthetic mixture, and it was confirmed using ultrasonogram. But the total duration of the surgery lasted for 10 hours. The intraoperative vitals were stable. The major anesthetic consideration are the time. The reimplantations are lost around 10 to 12 hours, and the main considerations were vasospasm and reperfusion injuries and pain control. Since we are using a continuous supraclavicular block, and local anesthetic systemic toxicity was also an important consideration during the procedure, and the patient was monitored for all the above. And on concluding, hand amputation with avulsion and crush injury is one of the challenging presentations in anesthesia. Continuous supraclavicular brachial plexus block using a standard intravenous catheter is a good choice considering the emergent nature and prolonged duration of the procedure. Thank you.
Next, play Dr. Karpagam.
Good morning, everyone. My poster presentation is on erector spinae plane block for a case of 45 years post-menopausal woman with previous history of lumpectomy done in 2016, and in 2018 she had a recurrent episode of the same, following which She had a defaulted follow-up, and now she presented with recurrent lump in the left breast with discharge for the past 2 months. There is no relevant past history or positive family history of breast cancer. And following the investigations, the CT chest revealed left breast mass infiltrating into the pectoralis major muscle with the pericardial deposits. And the histology showed a picture of malignant cystosarcoma phylloides tumor with no evidence of lung metastasis. So after pre-operative assessment of the patient was taken up for proposed surgery of left mastectomy with reconstruction of the anterior chest wall under general anesthesia with ultrasound guided erectospinal plane block. The block was performed under sterile aseptic precautions with the patient in sitting position, and the block was administered under ultrasound guidance by in-plane technique using 8 cm 16 gauge 2-His needle inserted in craniocaudal direction. Deep to the erectospinal muscle, the needle placement was confirmed by hydrodissection on injecting 2 to 3 ml of normal saline, following which 25 ml of 0.25% bupivacaine was injected into the interfacial plane deep to the erectospinal muscle. Following this block, general anesthesia was administered and intraoperative ventilation strategies were included with low tidal volume with high respiratory rate, controlled positive pressure ventilation during anterior chest wall reconstruction for better surgical conditions. The surgery lasted for about 5 hours and the patient was extubated. And post-operative pain relief with erectospinal block for this case was satisfactory for about 12 hours post-operatively without any complications. So the major advantages of erectospinal block is that it is a novel regional upcoming technique which is simpler and safer to perform, which provides an effective analgesia with less opioid requirement, and it eliminates the risk due to the epidural anesthesia. And for the surgical side, it gives a superior analgesic effect post-operatively with a better lung expansion and early ambulation. Thank you.
Next, Dr. Srinivas Ramanan.
Good morning. My topic is about anesthetic management of a kyphoscoliotic spine patient having a carcinoma thyroid with a retrosternal extension coming for an intertrochanteric fracture of femur. The patient is a 75 years old female with a Mallampati classification airway of MPC3 and edentless denture. She is having a 10 cross 12 centimeter right lobe of thyroid swelling, which compresses and deviates the trachea towards the left side. She is a known case of diabetic for 2 years under regular insulin treatment, and she is a known case of carcinoma thyroid for 10 years in a regular treatment. The blood investigations were done. It's within the normal limit. The anesthesia concern about this patient is transporting the patient to the operation theater and securing IV access, appropriate gadgets for intraoperative monitoring. Difficult airway cart has been kept ready due to anticipated difficult airway in this patient, difficulty in performing neuroaxial blockade technique, so USG has been kept ready, altered drug distribution in kyphoscoliotic spine, surgical positioning, intraoperative maintenance of hemodynamics and maintenance of glycemic control and preventing hypoxia and post-operative pain relief. The anesthesia management chosen was combined epidural and spinal anesthesia. The patient was shifted to the operation theater. Standard ASTM monitors attached and baseline vitals have been recorded. The IV access secured, and her preoperative blood sugars was 160 mg per deciliter, for which 1 unit per hour of regular insulin infusion have been started. Under sterile asepsis using ultrasound, the L2, L3 interspinous and L3, L4 interspinous space have been located. L2, L3 interspinous space, the epidural 16 gauge 2E needle have been inserted. Within 2.5 centimeter, the epidural space have been identified by loss of resistance to air technique. The epidural test dose given, which was negative. In L3, L4 interspinal space, the subarachnoid block have been given by 2 ml of 0.5% bupivacaine. A level of block was T8. The patient was positioned in the fracture table supine. Supplemental O2 through the Hudson mask have been kept. Intraoperatively, the patient was sedated with midazolam and fentanyl in a titrated dose. The intraoperative event was uneventful. Postoperatively, the epidural was activated with 0.125% bupivacaine 6 ml QID for 3 days. The patient didn't complain of any pain postoperatively and intraoperatively. My study in this for this patient with a kyphoscoliotic spine, for going for a regional technique is far better than going for a general anesthesia, even though this patient is having an difficult airway, which poses a significant challenge for the anesthetist. So we can go for an regional technique in this patient. Thank you.
Thank you. Next, Dr. Arun Dev.
Good morning, sir. I am Dr. Arun Dev, second year postgraduate, Department from Vinayaga Missions Medical College, Karaikal. My poster topic is a case of intratracheal tumor resection. Introduction. Management of airway in tracheal tumors is challenging, as the airway has to be shared between the surgeon and patency must be maintained despite the airway manipulation. Patent airway has to be established and maintained throughout the surgery. Case report. A 61-year-old male patient with complaints of progressive dyspnea, which was positioned in nature. Routine blood investigations were done, like blood routine examination, LFT, RFT, coagulation profile, ECG, and 2D echo, which came out to be normal. CT revealed a uniform mass 2.5 centimeter from the vocal cord. Plan was excision of the intratracheal tumor with possible resection and anastomosis of an involved tracheal segment. A careful perioperative plan involving the thoracic surgeon, anesthetist, and cardiovascular surgeon was done. A pediatric flexible fiber optic olimbocellular DP bronchoscope was introduced under local anesthesia with an internal diameter of 3.1 mm. Patient was pre-oxygenated, induced with propofol and with oxygen and sevoflurane, and paralyzed with succinyl-choline. 5 mm microlaryngeal cuffed oral endotracheal tube was able to pass beyond the tumor. Ventilator settings was inspiratory-expiratory ratio of 1:3, tidal volume of 550 ml, respiratory rate between 12 to 14, and PEEP was 4. With this airway pressure was 22 centimeters of water, and EtCO2 was maintained between 30 to 40 millimeters mercury. Tracheal wall was incised below the tumor, and a sterile 6.5 mm cuffed oral endotracheal tube was placed at the distal end of the trachea. 3.5 centimeter length of the trachea, inclusive of the tumor, was excised. Patient was extubated at the completion of surgery. Discussion. The anesthetic techniques depends upon the size, location, extent of the luminary occlusion. The widely used methods are high-frequency jet ventilation, rigid bronchoscopy, distal tracheal intubation, tracheostomy under local anesthesia, one-lung ventilation, cardiopulmonary bypass, and extracorporeal membrane oxygenation. Alternatives in case of failure to negotiate the growth were also kept in mind. Communication. A good communication and coordination between the surgeon and the anesthesiologist is needed throughout the intraoperative period for a successful outcome. The anesthetist should also have a knowledge of different airway management techniques. Thank you.
Next, Dr. Divyashree.
Hello everyone, I'm Dr. Divyashree, Junior Resident, SMS Medical College, Jaipur. My poster is on erector spinae plane block, a novel post-operative analgesic technique. Introduction. Erector spinae plane block is a paraspinal facial plane block where the needle placement is between the erector spinae muscle and the transverse process. Local anesthetic is administered, which blocks the dorsal and ventral rami of the thoracic and abdominal spinal nerves, leading to multidermatomal sensory block. This is due to the cranial and caudal spread of the injected local anesthetic, which is aided by the thoracolumbar fascia. The spread is as follows: diffusion of the injected local anesthetic through the connective tissues and towards the spinal nerve roots, transforaminal spread and epidural spread. Objectives: 5 patients undergoing different abdominal surgeries under GA were administered erector spinae plane block prior to induction under ultrasound guidance using 20 ml of 0.25% ropivacaine. Pain scores were assessed for 48 hours post-op using numerical rating scale along with total analgesic consumption. This was the position of the patient and the position of the probe and the corresponding sono image. Materials and methods. The block was performed in sitting position under USG guidance using a curvilinear probe of frequency 3 to 12 millihertz. I have a video of the same. The probe was placed in cephalocaudal orientation over the midline of the back at the desired level, moved laterally to identify the transverse process. As you can see in the video, the needle was inserted superior to the ultrasound probe using an in-plane approach through trapezius, erector spinae, and towards transverse process. Hydrodissection was done to confirm the plane. Erector spinae muscle was visualized separating from the transverse process, and the local anesthetic was deposited there. In the postoperative period, injection diclofenac 75 mg IV was given whenever NRS was more than or equal to 4, with the exception of patient number 4, who was a case of CA esophagus, posted for VATS. As he had additional neck dissection, diclo was given throughout a week BD. These were the different patients, their diagnosis, surgery, the level where the block was done, and level of sensory block achieved. Results. Technical difficulties were encountered in patient number 1, as she had a BMI of 37.7. There was a difficulty in delineating the structures. No complications were encountered during the procedure. Intraoperatively, all the patients showed decreased analgesic consumption and better hemodynamic stability, which was particularly important in patient number 5, case of periampullary carcinoma with CAD triple vesicle disease and severe MS, posted for lab bubbles. There was no significant hypertension or tachycardia. NRS of different patients is as follows. Patient number 1 had NRS 4 at 12 hours, patient number 2 and 3 at 20 hours. Rest of the patients, it never crossed 4. Coming to the conclusions, erector spinal plane block effectively covers visceral pain along with parietal pain, owing to its spread as described previously. Hence, the block can be effectively used for post-op analgesia in both open and lap surgeries, even though the origin of pain in both of them is different. Additionally, for thoracic surgeries, erector spinal plane block helps in better lung expansion, provides superior analgesia, allows patients to cough, early weaning off mechanical ventilation, and early ambulation, decreasing post-op morbidity significantly. These are my references. And I also thank the Department of General Surgery of my college for helping me out. Thank you.
Sir, we can move on to the question session, sir.
This is Gokul Rama.
Yes, sir. Good evening, sir.
What is this hand replay implantation?
Yes, sir.
So did you top up intra?
Yes, sir. Intraoperatively, after 5 years of the initial blockade, I top up with injection bupivacaine 0.25%, 8 ml, sir.
Why did you top up?
Because I did not want the patient to have the pain and any movement in the surgical site.
Did he have pain?
No, sir. There was no breakthrough pain. Sir.
No pain.
Yes,
so why did you? It was mentioned in between that you topped up.
Yes, sir. I have mentioned, sir.
You have mentioned that you are topped up in between.
Yes, sir. Every hourly.
In the poster.
Yes, sir. Yes, sir. I have mentioned, sir.
In the poster, have you mentioned?
Yes, sir. I have mentioned in the. Yes, sir. I have mentioned in the poster, sir. In the intraoperative period, I have mentioned.
What do you mean by perineural? What do you mean by perineural?
Sir, in
you
the
inserted the catheter perineural.
Perineural means.
What do you mean by perineural?
Perineural means just around the perineurium, sir. I am not placed the catheter.
Can you see the perineurium in ultrasound? Can you see the perineurium in ultrasound? Okay, next. Karpagam. Can you move on to Karpagam?
Yes, sir. Good evening, sir. Good evening, sir.
Karpagam.
Yes, sir.
You have mentioned the erector spinal plane block.
Yes, sir. Yes, sir.
Which needle did you use?
I used an 18 gauge 2-His needle, sir. Which was.
Why do you want to use that?
It's a bigger needle, and we are moving through 3 planes of muscle, sir. We will start like the plane is across the trapezius muscle, followed by the rhomboidus.
Can you see a 23 gauge spinal? Can you use or not?
Yes,
can
sir,
we use 23 gauge or not? Then why did you want to use
sir, we can use
18 gauge needle? Okay, you have mentioned in the talk that you are giving ESP block into the erector spinae muscle. Is it correct?
No, sir, beneath the plane of erector spinae.
But you are not told like that. You are told you are injecting the drug into the erector spinae muscle. Okay. Next.
Sorry, sir.
No, that's okay.
Srinivas Ramanan.
Srinivas Ramanan, carcinoma thyroid.
Yes, sir.
So you have revealed the identity of the patient without closing the face. Is it okay?
Oh, sorry, sir.
You revealed the identity of the patient without closing the airway. You have mentioned that you have done under CSEA. You think any other method is there?
Actually, we can't we can intubate the patient, sir. It is safe for us because during any intra-op loss or patient going for any hemodynamic instability, we can start the case by intubating the patient because we have kept ready the fiber optic bronchos was kept ready, sir. Actually,
can we use continuous spinal?
Continuous spinal, no, sir. Continuous spinal is not desirable, sir. Yeah, thank you.
Why?
Sir, you're asking me, no, sir?
Yes.
Hello, sir. Yes, sir. Continuous spinal is
Yes.
not desirable because the patient
Why
is
it is not desirable?
Spine. Yes, okay. Yeah. The patient is having a kyphoscoliotic spine, sir, because the drug spread is unpredictable. So we can't use continuous spinal, sir.
So that is when you can use 2 ml of you have used spinal only, no? What is your anesthetic management?
Yes, sir.
Then
anesthetic
okay.
management
Next,
I have
Arun
used
Dev, sir,
spinal,
Pradeep sir,
So,
come in.
yes,
Pradeep sir is joined, sir.
Pradeep.
Okay, thank you.
Pradeep. Next person is who's that? Arun Dev.
Yes, sir.
Yeah, you have
Good evening,
used,
sir.
you
Good
have
evening,
used
sir.
ultrasound.
Hello.
No, sir. Ultrasound was not used. No,
Sorry
not
to
used to
interrupt,
that.
sir.
Hello, sir.
Huh.
Arun Dev.
Yeah.
Yes, sir. Good evening, sir. Good evening, sir.
I'm talking of for the kyphoscoliotic patient.
Scoliosis is gone. Finished.
Sorry. I think. Finished.
Your
no, sir.
voice is
Okay,
breaking, sir. We are moving, seeing the face only.
Okay.
Voice is not firm, not heard.
Let me try to go to a better connectivity area.
Sir, you can stop video, sir. You can only give voice call, sir. You can stop video then.
Okay, fine. Sir, you can continue. I think there's a lot of.
Arun Dev.
There
Yes, sir.
seems to
Good
be a
evening,
lot
sir.
of.
You have done tracheal tumor resection. Good, neat presentation. Your thing was very nicely, cleanly seen. But
Yes,
what
sir.
is the normal diameter of the trachea? Okay. You have mentioned that the diameter of the mass is eternal diameter. What do you mean by eternal diameter?
Sir, that is like inside the diameter of the tube, sir.
Is it external or eternal?
Sir, eternal, sir. Eternal.
Eternal diameter. I don't know what is you mean by eternal diameter. Okay. How do you use in a tracheal tumor one lung ventilation? Why do you want to use one lung ventilation in tracheal tumor?
Sir, one lung ventilation was not used in this case, sir. Like alternative methods were like
But you said
one lung ventilation.
How it is possible? One lung ventilation in tracheal tumor. Why do you want to use?
Actually, for this case, one lung ventilation was not at all used, sir. But like alternatives
okay,
are
man.
like one
That's
lung.
okay.
Yes,
but why do you want as an alternate method, and how do you want to do is as a tracheal tumor resection one lung ventilation?
Like if the tumor is like lower in any of the bifurcation areas.
Yes, sir. Can you hear me, sir? Now, is it better now?
Pradeep, sir.
Yes, sir.
Can you hear me, sir? I can hear you. I can hear you. Audible now? Am I audible now?
Audible, sir.
Sir, audible, sir. You asked a question, sir.
Yeah, really, what sir is asking is right. Do you think that you require a one lung ventilation in a patient with tracheal tumor? Was there any thoracic approach used? Anything like that?
No, sir. Actually, if a patient, if patient is elderly, like if patient is having any pathologies in lung means, then and as an alternative, one lung ventilation can also be considered.
No. Did this patient have any pathology in the lung? Why do you want to?
No, sir. This patient doesn't have any pathology, sir. Like just an alternative only I just mentioned, sir.
Alternative, okay. But for tracheal resection, I don't think you require, because what is more required is what would be the positioning of the patient in the post-operative period? Would you extubate this patient? What would you do?
Post-operatively, patient should be kept in a slight flexion, sir. Otherwise, if we go for extension, then chances of this breakage will be less. So for more adhesion of the trachea, patient should be kept in a slight flexion.
Flexion. You want flexion of the neck, of the neck and
head. Yes, sir. Neck should be kept in.
Yeah, head and neck should be flexed. Okay, that is one thing. Do you? How long did you keep the patient intubated? Did you post-operatively intubate and ventilate? Or
no, sir. Immediately after the procedure, patient was extubated, sir.
Okay. Do you think which is better? Keeping the patient intubated? You have done a tracheal surgery, right? Do you
Yes,
think
sir, yes, sir.
keeping the patient intubated is better or extubating is better, and why?
Patient extubation will be better. That's what I think, sir. Because keeping intubation means again chances of infection from in the surgical site will also be high. Also, recovery will be somewhat low, sir. Alveoli walls and all can get collapsed.
Shall we go to the next person? Pradeep?
Okay, we can go on to the next.
Previously, yes?
Yes, sir. Good evening. Good evening, sir.
You have told one thing, erector spinae plane block. For it to be given, you have to cross 2 muscles. Is it 3 muscles or 2 muscles?
Sir, if we are giving the block about T5 level, then we have to cross trapezius, rhomboid, and then erector spinae. If it is below, then we don't have to cross the rhomboid, sir.
But you have mentioned 2. You are not background about T5.
Sir, our cases we gave the blocks below T5 only, sir.
Below T5.
Yes, sir.
Okay. You have mentioned that this erector spinae block will block visceral pain. Is it true?
Yes, sir. Erector spinae block. The advantage of erector spinae block is it gives additional visceral analgesia because of the spread, sir. There is more blockage of the dorsal ramus, and then there are studies which show that it blocks it spreads into the paravertebral space and also the epidural. So there are more chances of it blocking the visceral pains.
So what is the disadvantage of ESP?
So it cannot be used as a sole anesthetic technique. It has to be supplemented.
Why? Why it cannot be used as a sole anesthetic technique?
Sir, it is more of an analgesic technique than a anesthetic, sir.
Okay. Why it cannot be used as a sole anesthetic technique for appendectomy? Okay,
motor
take
blockade.
appendectomy.
Motor blockade will not be.
What happened? Motor blockade will not be there. Okay. Then, okay. Sir Pradeep. Pradeep.
Sir,
Pradeep is not there.
Not there, sir. I think
Who administered the block?
Sorry, sir.
Who administered
the block?
Sir,
Can you hear me now?
Yes, sir, I can hear you. I did, sir. I and one of my associate professors were there.
Hello. Who administered the block? Yes.
Sir, we did the block on 5 patients. On 1 or 2 patients, it was my professor, and rest of the patient it was me.
Who administered the block?
Sir, of the 5 patients, in 2 patients, it was my professor, and rest 3 patients I did, sir. Hello.
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 Divyashree?
Yes, sir. Hello,
Can you
sir.
tell the origin from where the erector spinae starts?
Sir, erector spinae runs between the base of the skull till the sacrum, sir.
So have you erector spinae block before? Before have you given?
Sir, it is actually my thesis topic, sir. So I have administered the block. Hello.
Okay.
What is the type of study?
Okay, right.
Hello. Sir, we used it in abdominal surgery, sir.
What
Various
is the
abdominal
type of
surgeries.
study?
Sir, this is a case series, sir.
What is the type of study?
Case series.
Okay.
Case series.
Okay. Okay.
Thank you.
Let us conclude, sir.
Okay, right. Done. Type of study. Answer to next.
Sir, case series.
Okay, sir.
Can we conclude?
Can yes?
Okay. Sir, Pradeep, sir.
I'm ready.
Okay, sir.
Sir, first of all, I apologize for the connectivity issues.
No, sir, no issue.
I'm very sorry. And most of the thank you for the opportunity. And
Yes.
thank
That's
you
what
for
I'm also
providing me this
telling.
opportunity.
Okay, okay. So we
And
have, okay. So we have come to the end of the 2 days hectic academic event. First of all, I thank the judges, Parthasarathi and Pradeep Dangre, for sparing your valuable time and remaining with us in the late evening also. Thank you. Thank you, the coordinator, Dr. Gunalan.
Thank you, sir.
Thank you. I once again thank the A1 Logics for the uninterrupted relay for the last 2 days. Thank you, Nanda. Be with us tomorrow also. Thank you.
Thank you, sir. Thank you very much.
Thank you, sir. Thank you.
So we can
Thank you all. Thank you all, and wishes to all the participants.
Thank you, Partha.
Thank you, sir.
Congratulations.
Score sheet to my email ID. Okay.
Yeah, I will do.
Thank you, sir. Good night. Good night.
I will do after going home.
Okay, okay. No problem.
Thank you, sir.
Shilpa,
Good
we
night.
can wind up.
Yes, sir. We can wind up, sir.
Okay. Thank you, Kunal.
Thank you, sir. Thank you.